Okay, gonna do a Foundations of Nursing 1 final exam blueprint overview. Um, so, start off with Unit 1, 3 questions about mobility. What happens to body when body's immobile? Gonna read out of ATI, Chapter 40, Mobility and Immobility. Physiological Integrity, Section Basic Care and Comfort, Chapter 40, Immobility and Immobility, Overview. Mobility is the freedom and independence in purposeful movement. Mobility refers to adapting to and having self-awareness of the environment. Functional, musculoskeletal, and nervous systems are essential for mobility. Immobility is the inability to move freely and independently at will. The risk of complications increase with the degree of immobility and the length of time of immobilization. Nursing interventions are designed to maintain mobility and prevent or minimize complications of immobility. Cutaneous stimulation in the form of cold and heat applications helps relieve pain and promote healing. Promoting venous return is another key component of reducing the complications of immobility. Mobility and immobility. Immobility may be temporary, such as following knee arthroplasty, permanent, such as a paraplegia, sudden onset, such as a fractured arm and leg following a motor vehicle crash, or slow onset, such as multiple sclerosis. The principles of body mechanics are based on alignment, balance, gravity, and friction. Movement depends on an intact skeletal system, skeletal muscles, and nervous system. Assessment of the client focuses on mobility, range of motion, or ROM, gait, exercise status, activity tolerance, and body alignment while standing, sitting, and lying. Factors affecting mobility include alterations in muscles, injury to musculoskeletal system, and abnormal posture. Also, impaired central nervous system and health status and age. Changes that occur in body system include I'm just going to go to body system here. Integumentary, the changes in the integumentary system are increased pressure on skin, which is aggravated by metabolic changes, decreased circulation to tissue causing ischemia, which can lead to pressure ulcers. Respiratory system changes, decreased respiratory movement resulting in decreased oxygenation and carbon dioxide exchange, stasis of secretions, and decreased and weakened respiratory muscles resulting in atelectasis and hypostatic pneumonia. Also decreased cough response. Body system, cardiovascular. Changes that can occur in the system with immobility are orthostatic hypotension, less fluid volume in the circulatory system, stasis of blood in the legs, diminished autonomic responses, decreased cardiac output, leading to poor cardiac effectiveness, which results in increased cardiac workload, increased oxygenation requirement, and increased risk of thrombus development. Metabolic changes that can occur: altered endocrine system, decreased basal metabolic rate, changes in protein, carbohydrate, and fat metabolism, decreased appetite with altered nutritional intake, negative nitrogen balance, decreased protein resulting in loss of muscle, loss of weight, alterations in calcium, fluid, and electrolytes, resorption of calcium from bones. It's resorption, not reabsorption. Decreased urinary elimination of calcium resulting in hypercalcemia. Changes in the elimination patterns. Genitourinary, you have urinary stasis. Change in calcium metabolism with hypercalcemia resulting in renal calculi. I think that's stones. Decreased fluid intake, poor perineal care, and indwelling urinary catheters resulting in urinary tract infections. Gastrointestinal, you have decreased peristalsis, decreased fluid intake, and constipation, then fecal impaction, then diarrhea. Changes in the musculoskeletal system. Decreased muscle endurance, strength, and mass. Impaired balance, atrophy of muscles. Decreased stability, altered calcium metabolism. Osteoporosis, contractures, foot drop, altered joint mobility. Neurological and psychosocial changes are changes in emotional status, depression, alteration in self-concept, and anxiety. Behavioral changes, withdrawal, altered sleep-wake pattern, hostility, inappropriate laughter, and passivity. Altered sensory perception, and ineffective coping. Developmental changes. In infants, toddlers, and preschoolers, it's slower progression in gross motor skills and intellectual and musculoskeletal development. Body aligned with line of gravity, resulting in unbalanced posture. Adolescence, imbalanced growth spurt, possibly altered with immobility, delayed development of independence, and social isolation. Adults, alterations in every physiological system, alterations in family and social systems, alterations in job identity. Older adults, alterations in balance resulting in a major risk for falls and injuries, steady loss of bone mass resulting in weakened bones, decreased coordination, slower walk with smaller steps, alterations in functional status, and increased dependence on staff and family. So, assessment and nursing interventions related to immobility, specifically the integumentary system, basically to maintain intact skin. Your assessment would be: observe the skin for breakdown, warmth, and change in color. Look for pallor or redness in fair-skinned clients and purple or black discoloration in dark-skinned clients. Observe bony prominences. Check skin turgor. Use a pressure ulcer risk scale such as Norton or Braden. Assess at least every 2 hours. Observe for urinary or bowel incontinence. And the interventions for all these would be: identify clients at risk for pressure ulcer development. Position the client using corrective devices such as pillows, foot boots, trochanter rolls, and wedge pillows. Turn the client every 1 to 2 hours and use devices for support or per protocol. Teach clients who can move independently to turn at least every 15 minutes. Provide clients who are sitting in a chair with a device to decrease pressure. Limit sitting in a chair to less than 2 hours. Instruct the client to shift his weight every 15 minutes. Use a therapeutic bed or mattress for a client who is in a bed for an extended time. Monitor nutritional intake. Provide skin and perineal care. Okay, and now respiratory. Main thing would be maintain airway patency, achieve optimal lung expansion and gas exchange, and mobilize airway secretions. And assessment, you'd complete the following every 2 hours. Observe the client's chest wall movement for symmetry. Auscultate breath sounds. And observe for productive cough and note the color, amount, and consistency of secretions. Interventions would be: reposition the client every 1 to 2 hours. Excuse me. Teach the client to turn, cough, and deep breathe every 1 to 2 hours while awake. Teach the client to yawn every hour while awake. Teach the client to use an incentive spirometer while awake. Remove abdominal binders every 2 hours and ensure their correct placement. Use chest physiotherapy. Auscultate the lungs to determine the effectiveness of chest physiotherapy or other respiratory therapy. Teach the client to consume at least 2,000 milliliters of fluid per day unless the client's intake is restricted. Monitor the client's ability to expectorate secretions. Use suction if the client is unable to expectorate secretions. Now on to cardiovascular. The big thing here is maintain cardiovascular function, increase activity tolerance, and prevent thrombus formation. So your assessment, you have measure orthostatic blood pressure and pulse, lying to sitting and to standing, and assess for vertigo. Palpate the apical and peripheral pulses. Auscultate the heart at the apex for S3, an early sign of heart failure. Older adult clients may not adapt well to immobility. Palpate for edema in the sacrum, legs, and feet. Palpate the skin for warmth in peripheral areas to include the nose, earlobes, hands, and feet. Assess for deep vein thrombosis by observing the calves for redness and palpating for warmth and tenderness. Measure the circumference of both calves and thighs and compare in size. Calf 10 centimeters below the middle of the patella. Okay. Nursing interventions for cardiac or cardiovascular. Increase the client's activity as soon as possible. Have the client dangle his feet on the side of bed or transfer to a chair. Have the client perform isometric exercises to increase his tolerance for activity. Change the client's position as often as possible. Teach the client to avoid the Valsalva maneuver. Give a stool softener as prescribed to prevent straining. Teach range of motion exercises such as ankle pumps or knee flexion. Teach the client to avoid placing pillows under the knees or lower extremities, crossing the legs, wearing tight clothes around the waist or on the legs, sitting for long periods of time, and massaging the legs. Use elastic stockings. Use sequential compression devices or SCD or intermittent pneumatic compression IPC. Increase fluid intake if not contraindicated. Give low-dose heparin, 5,000 units, every 8 to 12 hours. Contact the provider immediately if assessment data indicates venous thrombosis. Okay, metabolic. You want to reduce skin injury and maintain metabolism for metabolic. Assessment. Record anthropometric measurement of height, weight, and skin fold. Assess I&O. Assess food intake. Assess food intake. Review urinary and bowel elimination status. Assess wound healing. Auscultate bowel sounds. Check skin turgor. And review laboratory values for electrolyte, serum, total protein, and BUN. Interventions here would be provide a high-calorie and high-protein diet with vitamin B and C supplements. Also monitor and evaluate oral intake. If the client cannot eat or drink, enteral or parenteral nutritional therapy may be indicated. Okay, and then for elimination, you want to maintain or achieve normal urinary and bowel elimination patterns. Assessment for elimination is assess I&O, assess the bladder for distension, observe urine for color, amount, clarity, and frequency, auscultate bowel sounds, and observe feces for color, amount, frequency, and consistency. And interventions: maintain hydration at least 2,000 milliliters a day unless fluid is restricted. Teach the client to consume a diet that includes fruits and vegetables and is high in fiber. Give a stool softener as prescribed. Consider laxatives only as a last resort. Provide perineal care. Teach bladder and bowel training if needed. Insert a straight or indwelling catheter as prescribed if the bladder is distended. Promote urination by pouring warm water over the perineal area if the client has difficulty urinating. On to musculoskeletal. Here you want to maintain or regain body alignment and stability, decrease skin and musculoskeletal system changes, achieve full or optimum ROM, and prevent contractures. So you want to assess ROM capability. You want to assess muscle tone and mass. Observe for contractures. Monitor gait. Monitor nutritional intake for calcium. And monitor use of assistive devices to assist with ADLs. Nursing interventions. Assist and instruct the client to change positions in bed at least every 2 hours and perform weight shifts in the wheelchair every 15 minutes. Provide active and or passive ROM 2 or 3 times a day. Teach the client to perform ROM while bathing, eating, grooming, and dressing. Monitor the client's nutritional intake of calcium. Develop an individualized program for each client. Older clients may require a program that addresses the aging process. Cluster care to promote a proper sleep-wake cycle. Request that the provider prescribe physical therapy if the client has decreased mobility. Advise the client to follow the physical therapy program. Use a continuous passive motion device. Cane instructions. Maintain 2 points of support on the ground at all times. Keep the cane on the stronger side of the body. Support body weight on both legs. Move the cane forward 6 to 10 inches. Then move the weaker leg forward toward the cane. Support body weight on both legs. Move the cane forward 6 to 10 inches. Then move the weaker leg forward toward the cane. Okay. Next, advance the stronger leg. Okay. Crutch instructions. Do not alter crutches after proper fit has been determined. Follow the prescribed crutch gait. Support body weight at the hand grips with the elbows flexed at 30 degrees. Position the crutches on the unaffected side when sitting or rising from a chair. Position the crutches on the unaffected side when sitting or rising from the chair. Okay. Psychosocial. Here you want to maintain an acceptable sleep-wake pattern, achieve socialization, and complete self-care independently. Assessment. You want to assess emotional status, assess mental status, assess behavior and decision-making skills, monitor mobility status, observe for unusual alterations in sleep-wake pattern, assess coping skills, especially for loss, monitor activities of daily living, ADLs, and assess for family support and relationships, and monitor social activities. Interventions. Assist in using coping skills or in developing new coping skills. Maintain orientation to time, clock and calendar with date, person, call by name and introduce self, and place, talk about treatments, therapy, and length of stay. Develop a schedule of therapies and place it on a calendar in the client's room. Arrange for the client to be in a semi-private room with an alert roommate. Involve the client in daily care. Provide stimuli such as books, television, newspapers, and radio. Help the client maintain body image by performing or assisting with hygiene and grooming tasks such as shaving or applying makeup. Have nurses and other staff interact on an informal social basis. Recommend to the provider a referral for consultation, psychological, spiritual, or social worker, if the client is not coping well. Okay, developmental. Here you want to continue expected development and achieve physical and mental stimulation. In infancy through school age, gross motor skills and intellectual and musculoskeletal development. These are assessments. Assess body alignment, posture, and developmental tests specific to age. In adolescence, and then for interventions for infancy through school age, you want to initiate events that stimulate physical and psychosocial systems, increase mobility, and involve play therapists in age-appropriate activities. You want to use measures to prevent falls, develop strategies for maintaining or enhancing the developmental process, teach the family that their perception of immobility can affect the child's progress and ability to cope. Encourage the parents to stay with the child, incorporate the child's involvement, if it is age appropriate, in his treatments, and place the child in a room with others who are age appropriate. In adolescence, you want to assess growth and development specific to age, level of independence, and social activities. Interventions for adolescents would be initiate care that facilitates independence, involve adolescents in decision-making for ADLs, and provide stimuli to promote socialization, interaction with peers, use of adolescents' activity room. Okay, adults assess all physical systems, family relationships, social status, and meaning of career/job. Interventions provide care that promotes activity in all physical systems. Discuss with the family the importance of interaction with the client. Discuss the client's social involvement. And discuss the meaning of the client's career/job. And in older adults, assess balance, coordination, gait, functional status, level of independence, and social isolation. And interventions plan care with the client and family to increase independence with ADLs and decision-making skills, teach the staff to facilitate the client's independence in all activities, maintain stimuli such as a clock, newspaper, calendar, and weather status, encourage the family to visit to maintain socialization, and plan for staff to spend some time talking and listening to the client. Okay, on to application of heat and cold. Therapeutic effects of heat and cold applications. Heat. It increases blood flow, increases tissue metabolism, relaxes muscles, and eases joint stiffness and pain. And cold decreases inflammation, prevents swelling, reduces bleeding, reduces fever, diminishes muscle spasm, and decreases pain by decreasing the velocity of nerve conduction. For clients at risk for injury from heat/cold applications, use extreme caution with very young, fair-skinned, and older clients as they have fragile skin. Clients who are immobile may not be able to move away from the application if it becomes uncomfortable. They are at risk for skin injuries. Clients who have impaired sensory perception may not feel pain or burning. Avoid extremely long applications of either heat or cold, as they will result in a reaction opposite to the intended response. Heat. Monitor bony prominences carefully, as they are more sensitive to heat applications. Avoid the use of heat application over metal devices, e.g. pacemakers, prosthetic joints, to prevent deep tissue burns. Do not apply heat to the abdomen of a pregnant woman to prevent harm to the fetus. Do not place a heat application under an immobile client, as this may increase the risk of burns. Cold application is appropriate for clients with cold intolerance. Cold application is inappropriate for clients with cold intolerance, vascular insufficiency, and disorders aggravated by cold, such as Raynaud's phenomenon. Make sure the provider has written a prescription that includes location, duration and frequency, specific type, moist or dry, and temperature to use. Collaborative care. Equipment. Heat application supplies include, for the moist, it would be a hot compress, towel bath thermometer, hot water, plastic covering, hot pack, or aquathermia pad with distilled water and tape. Hot soaks is water, bath thermometer, basin, and waterproof pads. A sitz bath. Disposable or built-in bath thermometer, bath blanket, and towels. A dry heat application supply would be a hot pack, disposable or reusable, or an aquathermia pad with distilled water, and a pillowcase. And then a warming blanket also. There's a dry application. Cold application supplies include, for moist cold, would be large basin of ice. You could have just cold water, or you could use a cold pack to be used in place of ice. Dry would be ice bag, ice collar, ice glove, or a cold pack, or a cooling blanket. Apply the application to the area. Make sure the client's call light is within reach and instruct the client to report any discomfort. Assess the site every 5 to 10 minutes to check for redness or pallor, pain or burning, numbness, shivering with cold applications, blisters, decreased sensation, cyanosis with cold applications. Discontinue the application if any of the above occur, or remove the application at the predetermined time, usually 15 to 20 minutes. Document location, type, and length of the application, condition of the skin before and after the application, and the client's ability to tolerate the application. Alright, now on to promoting venous return. Elastic stockings or thromboembolic devices, TED hose, help maintain external pressure on the muscles of the lower extremities and promote blood return to the heart. Sequential compression devices, or SCDs, and intermittent pneumatic compression, or IPC, have plastic or fabric sleeves that wrap around the leg and secure with Velcro. The sleeves are then attached to an electric pump that alternately inflates and deflates the sleeve around the leg. These machines are set to cycle, typically a 10 to 15 minute inflation and a 45 to 65 second deflation. Positioning techniques reduce compression of leg veins also, and ROM exercises cause skeletal muscle contractions, which promote blood return. Specific exercises that help prevent thrombophlebitis include ankle pumps, foot circles, and knee flexion. TED hose, SCDs, and IPC require a provider's order. Immobile clients should perform leg exercises, increase their fluid intake, and change positions frequently. These interventions can be implemented without a provider's order. When poor venous return or possible thrombus is suspected, the provider must be notified and no pressure applied to a thrombus to avoid dislodging it. Collaborative care. TED hose. Equipment: tape measure and TED hose. Procedure: perform hand hygiene, assess the condition of the skin and the circulation in the client's legs, measure the client's calf and or thigh circumference and the length of the leg to select the correct size of stocking. Turn the stockings inside to the heel. Put the stocking on the foot. Pull the remainder of the stocking over the heel and up the leg. Smooth any creases or wrinkles. Remove the stockings and reapply them at least twice a day. Make sure the client has the necessary support to accomplish this task. Make sure the stockings are not too tight over the toes. Keep the stockings clean and dry. A post-surgical client or a client with special needs may need a second pair of hose. Document the application and removal of the stockings. SCDs and IPC equipment. Tape measure sequential stockings. Stockinette. 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 Procedure. Perform hand hygiene. Assess circulation and skin prior to application. Measure around the largest part of the client's thigh to determine the stocking size. Place the stockinette on first. Apply the sleeves. Attach the sleeves to the inflator. Turn on the device. Monitor circulation and skin after application. Document the application and removal of the stockings. Positioning techniques to reduce compression of leg veins. Equipment, none. Procedure, teach the client to avoid crossing the legs, sitting for long periods of time, wearing restrictive clothing on the lower extremities, putting pillows behind the knees, and massaging the legs. ROM exercises are performed hourly while the client is awake. Equipment, none. Procedure, teach the client to perform ankle pumps, point the toes toward the head and then away from the head. Foot circles, rotate the feet in circles at the ankles, and knee flexion, flex and extend the legs at the knees. Complications. Thrombophlebitis, or deep vein thrombosis, is an inflammation of a vein, usually in the lower extremities, that results in clot formation. Clinical manifestations are pain, edema, warmth, and erythema at the site. Nursing actions. Notify the provider immediately. Position the client in bed with the leg elevated. Avoid any pressure at the site of the inflammation. And anticipate giving anticoagulants as prescribed. A pulmonary embolism is the occlusion of blood flow to one or more of the pulmonary arteries by a clot. The condition can be life-threatening. The clot or embolus often originates in the venous system of the lower extremities. Clinical manifestations are shortness of breath, chest pain, hematemesis or coughing up blood, decreased blood pressure, and rapid pulse. I thought it was hemoptysis. Oh well. Hematemesis. Nursing actions. Prepare to give thrombolytics or anticoagulants as prescribed. Okay, application exercises. A nurse is caring for a client who has been sitting in a chair for 3 hours. Which of the following is the client at risk for developing? A. Stasis of secretions. B. Muscle atrophy. C. Pressure ulcer. Or D. Fecal impaction. Okay, it's C. A pressure ulcer. Unrelieved pressure over bony prominence for too long increases the risk for skin breakdown. Sitting up in a chair will help prevent stasis of secretions. Muscle atrophy and fecal impaction would be complications for a client on prolonged bed rest. Okay, so 2. Which of the following nursing interventions should be implemented to maintain a patent airway in a client on bed rest? A. Perform isometric exercises. B. Suction every 8 hours. C. Give low-dose heparin as prescribed. Or D. Teach to use an incentive spirometer while awake. Answer is D. Teach to use incentive spirometer while awake. Using an incentive spirometer helps keep the airways open and prevents atelectasis. Performing isometric exercises strengthens skeletal muscles. Suctioning should not be done routinely, and low-dose heparin helps prevent thrombus formation. 3. Which of the following nursing interventions reduce the risk of thrombus development? Select all that apply. Teach the client not to use Valsalva's maneuver. Apply elastic stockings. Review laboratory values for total protein level. Place pillows under the client's knees and lower extremities, and assist the client to change position often. And the only ones it is apply elastic stockings and assist the client to change position often. Okay, elastic stockings promote venous return and prevent thrombus formation. Frequent position changes prevent venous stasis. The Valsalva's maneuver increases the workload of the heart, but it does not affect peripheral circulation. A review of the client's total protein level is important for evaluating his ability to heal and prevent skin breakdown. Placing pillows under the knees and lower extremities further impairs circulation of the lower extremities and should be avoided. Unless there actually is a thrombus, then you want to elevate that affected leg. Which of the following clients would benefit from the application of cold? Select all that apply. A client who has a sprained ankle, a client who has Raynaud's phenomenon, a client who just had knee arthroplasty, a client who has a toothache, a client who has a nosebleed. And the answer is all of them except a client who has Raynaud's phenomenon. A client who has a sprained ankle, a client who has a knee arthroplasty, a client who has a toothache may benefit from the application of cold to reduce pain and decrease inflammation. A client who has a nosebleed may benefit from cold application to reduce or stop bleeding. Cold could trigger Raynaud's phenomenon. So no Raynaud's, no Raynaud's, no Raynaud's for cold. 5. Sequential compression devices are used to A. Prevent pressure ulcers, B. Promote venous return, C. Prevent muscular atrophy, D. Increase joint mobility. And it's B. Promote venous return. The purpose of sequential compression devices is to promote venous return. Sequential compression devices do not prevent bed sores or muscular atrophy, and they do not increase joint mobility. Excuse me. Okay. Identify the order in which the following steps of elastic stockings application should be completed. I'll just do it in order. Okay, so first you perform hand hygiene. Second, you assess the condition of the client's skin and the circulation of his legs. Then you measure the client's calf and or thigh circumference and length of the leg and select the correct size of stocking. 4, you turn the stockings inside to the heel. 5, you put the stocking on the client's foot. And 6, pull the remainder of the stocking over the client's heel and on up his leg. And then 7, smooth any creases. Okay. And that was Unit 1 so far. Yeah, that's Unit 1. We'll do Unit 2 in just a sec. Okay, Unit 2. Let's talk about pressure ulcers, wounds, and wound management. Wounds are a result of injury to the skin. Although there are many different methods and degrees of injury, the basic phases of healing are essentially the same for most wounds. A pressure ulcer, formerly called a decubitus ulcer, is a specific type of tissue injury caused by unrelieved pressure that results in ischemia and damage to the underlying tissue. Pressure ulcers are classified according to a staging system developed by the National Pressure Ulcer Advisory Panel. The stages are suspected deep tissue injury. This is a discolored but intact skin caused by damage to underlying tissue. Then you go to stage 1, and that would be intact skin with an area of persistent non-blanchable redness, typically over a bony prominence that may feel warm or cool to touch. The tissue is swollen and congested with possible discomfort at the site. With darker skin tones, the ulcer may appear blue or purple. Stage 2, partial thickness skin loss involving the epidermis and the dermis. The ulcer is visible and superficial and may appear as an abrasion, blister, or shallow crater. Edema persists and the ulcer may become infected, possibly with pain and scant drainage. Stage 3, full thickness tissue loss with damage to or necrosis of subcutaneous tissue. The ulcer may extend down to, but not through, underlying fascia. The ulcer appears as a deep crater with or without undermining or adjacent tissue and without exposed muscle or bone. Drainage and infection are common. Stage 4, full thickness tissue loss with destruction, tissue necrosis, or damage to muscle, bone, or supporting structures. There may be sinus tracts, deep pockets of infection, tunneling, undermining, eschar, which is black scab-like material, or slough, tan, yellow, or green scab-like material. Unstageable. These are ulcers whose stage cannot be determined because eschar or slough obscures the wound. View media supplement. Stages of pressure ulcers. Or it's an image, whatever. Okay. Wound healing and management. Stages of wound healing. The inflammatory stage is the first 3 days after the initial trauma. Attempts are made at the site to control bleeding with clot formation, deliver oxygen, white blood cells, and nutrients to the area via the blood supply. The proliferative stage lasts the next 3 to 24 days, and effects to the wound include replacing lost tissue with connective or granulated tissue, contracting the wound's edges, and resurfacing of new epithelial cells. The maturation or remodeling stage involves the strengthening of the collagen scar and the restoration of a more normal appearance. It can take more than 1 year to complete, depending on the extent of the original wound. Okay, so then we're going to do a chart about the healing process. Type of healing. Primary intention healing. Characteristics: little or no tissue loss. Edges are approximated as with a surgical incision. The wound type heals rapidly, low risk of infection, and no or minimal scarring. Secondary intention healing. This involves loss of tissue, wound edges widely separated. This would be like pressure ulcers or stab wounds. And the wound type is longer healing time, increased risk of infection and scarring. And then there's the tertiary intention healing, which is widely separated edges, deep, spontaneous opening of a previously closed wound, risk of infection. And this has extensive drainage and tissue debris, closed later, not closed right away, and long healing time. Factors affecting wound healing. Increased age delays healing because of loss of skin turgor, skin fragility, decreased peripheral circulation and oxygenation, slower tissue regeneration, decreased absorption of nutrients, and decreased collagen and impaired function of the immune system. Oh, there's more. Oh wait, no. Overall wellness is a compound fracture of the femur, and a client with a head injury will present greater healing problems. So if you've got one problem, it makes your healing harder. Immune function is the body's ability to fight infection by destroying invading pathogens. On the right page. Yeah. Okay. Medications may interfere with the body's ability to respond to and or prevent infection. Nutrition provides energy and elements required for wound healing. Tissue perfusion provides circulation that delivers the required elements for tissue repair and infection control. Obesity, fatty tissue, lacks blood supply. Chronic diseases such as diabetes mellitus place additional stress on the body's healing mechanisms. Chronic stress further impedes healing. Smoking impairs oxygenation and clotting. Wound stress, such as from vomiting or coughing, puts pressure on the suture line and disrupts the wound healing process. General principles of wound management. Wounds impair skin integrity. Inflammation is a localized protective response triggered by injury or destruction of the tissue. Wounds heal by various processes and in stages. Wounds may become infected by the invasion of pathogenic microorganisms. Principles of wound care include assessment, cleansing, and protection. Wound care is a nursing responsibility that has a significant impact on wound healing. Assessment/data collection. Appearance. Note the color of open wounds. The following colors reflect the wound's condition. Red is healthy regeneration of tissue. Yellow is presence of purulent drainage and slough. And black presence of eschar that hinders healing and must be removed. Closed wounds. Skin edges should be well approximated. Drainage is a normal result of the healing process and occurs during the inflammatory and proliferative phases of healing. Note the amount of drainage from a drain or on a dressing. With each cleansing, observe the skin around a drain for irritation and breakdown. The character of drainage is distinguished by consistency, color, and odor. Serous drainage is the portion of the blood or serum that is watery and clear or slightly yellow in appearance. Sanguineous drainage contains serum and red blood cells. It is thick and appears reddish. Serosanguineous drainage contains both serum and blood. It is watery and appears blood-streaked or blood-tinged. Purulent drainage is the result of infection. It is thick and contains white blood cells, tissue debris, and bacteria. It may have a foul smell, and its color reflects the type of organism present. Green for Pseudomonas aeruginosa infection. Wound closure. Staples, sutures, wound closure strips or steri-strips. Pain. Note location, quality, intensity, timing, setting, associated symptoms, and aggravating relieving factors. Nursing interventions. Provide adequate hydration and meet protein and calorie needs. Encourage an intake of 2,000 to 3,000 milliliters of fluid a day with or from food and beverage sources if not contraindicated, e.g. heart failure or renal failure. Provide education about good sources of protein, meat, fish, poultry, eggs, dairy products, beans, nuts, whole grains. Note if serum albumin levels are low, below 3.5 grams, and because lack of protein puts the client at greater risk for delayed wound healing and infection. So that was below 3.5 serum albumin if they have a wound. Promote or provide nutritional support as indicated, vitamin and mineral supplements, nutritional supplements, enteral nutrition, and parenteral nutrition. Perform wound cleansing. Cleanse in a direction from the least contaminated toward the most contaminated. Use gentle friction when cleansing or applying solutions to the skin to avoid bleeding or further injury to the wound. While other mild cleansing agents may be prescribed, isotonic solutions remain the preferred cleansing agent. Never use the same gauze to cleanse across an incision or wound more than once. Irrigation with a solution-filled syringe held at 2.5 centimeters or 1 inch above the wound may be used. For wound dressings, use woven gauze, sponges. This absorbs exudate from the wound, and non-adherent material does not adhere to the wound bed. Self-adhesive transparent film. This is a temporary second skin, ideal for small superficial wounds. Hydrocolloid. This is an occlusive dressing that swells in the presence of exudate. It's used to maintain a granulating wound bed and may be left in place for up to 5 days. That's hydrocolloid. Hydrogel or Aquasorb may be used on infected deep wounds. It provides a moist wound bed. Okay, use the negative pressure of a wound vacuum-assisted closure if prescribed. Remove sutures / staples as prescribed. Administer analgesics as prescribed. And administer antimicrobials like topical and or systemic as prescribed. Document the location and type of wound / incision, the status of the wound and type of drainage, the type of dressing and materials used, client teaching provided, and how the client tolerated the procedure. Complications and nursing implications. There's a weird word. Dehiscence, 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 I guess, is a partial or total rupture or separation of a sutured wound, usually with the separation of underlying skin layers. Evisceration is a dehiscence that involves the protrusion of visceral organs through a wound opening. It is usually caused by the increased flow of serosanguinous fluid about 3 to 11 days postoperatively. Signs and symptoms of dehiscence include a significant increase in the flow of serosanguinous fluid on the wound dressing, immediate history of sudden straining, coughing, sneezing, vomiting, and the client reporting a change of popping or giving way in the wound area. Visualization of viscera. Risk factors include chronic disease, advanced age, obesity, invasive abdominal cancer, and vomiting. Also, dehydration and malnutrition, ineffective suturing, abdominal surgery. Evisceration / dehiscence requires emergency treatment. Call for help, stay with the client, cover the wound and any protruding organs with sterile towels or dressings that have been soaked in sterile normal saline solution. Do not attempt to reinsert the organs. Position the client supine with the hips and knees bent. Observe the client for signs of shock. Maintain a calm environment. Boy. Infection. Risk factors. Extremes in age, immature immune system, decreased immune function. Okay, extremes in age, so really young or really old. Impaired circulation and oxygenation, COPD, peripheral vascular disease. Wound condition or nature, a gunshot wound versus surgical incision. Impaired, suppressed immune system. Malnutrition, such as with alcoholism. Chronic disease. Poor wound care, such as breaches in a septic technique. Signs and symptoms are usually apparent within 2 to 7 days of injury / surgery. These signs and symptoms would be purulent drainage, pain, redness and edema in and around the wound, fever, chills, increased pulse and respiratory rate, increase in WBC count. Interventions. Prevent infection by using appropriate asepsis when performing dressing changes. Provide optimal nutrition to promote the immune response. Provide for adequate rest to promote healing. Administer antibiotic therapy as prescribed. Pressure ulcers. Pressure ulcers range from non-blanchable tissue redness to full-thickness skin loss with damage to underlying muscle and bone. Excellent nursing care is the primary factor in the prevention of pressure ulcers. The primary focus of prevention and treatment is to relieve the pressure and provide optimal nutrition and hydration. All clients must be assessed regularly for skin integrity status and evaluated regularly for risk factors that contribute to impaired skin integrity. Pressure ulcers are a significant source of morbidity and mortality among older adults and those who have limited mobility. Risk factors for developing pressure ulcers include skin changes related to aging, immobility, incontinence or excessive moisture, skin friction and shearing, vascular disorders, obesity, inadequate nutrition and or hydration, anemia, fever, impaired circulation, edema, sensory deficits, impaired cognitive functioning or neurological disorders, chronic diseases like diabetes mellitus, chronic renal failure, congestive heart failure, and chronic lung disease, and sedation that impairs spontaneous repositioning. Nursing interventions for pressure ulcers. Prevention. Maintain clean, dry skin and wrinkle-free linens. Appropriately use pressure-reducing surfaces and pressure-relieving devices. Inspect the skin frequently and document the client's risk using a tool such as the Braden scale. Clean and dry the skin immediately following urine or stool incontinence. Apply moisture barrier creams to the skin of clients who are incontinent. Use tepid water, not hot, minimal scrubbing, and pat the skin dry. Reposition the client in bed at least every 2 hours and every 1 hour in a chair. Document position changes. Place pillows strategically between bony surfaces. Maintain the head of the bed at or below a 30-degree angle or flat, unless contraindicated, to relieve pressure on the sacrum, buttocks, and heels. Keep the client from sliding down in bed, as this increases shearing forces that pull tissue layers apart and cause damage. Lift rather than pull the client up in bed or in the chair, because pulling creates friction that can damage the outer layer of skin, the epidermis. Raise the client's heels off of the bed to prevent pressure on the heels. Ambulate the client as soon as possible and as often as possible. Implement active/passive exercises for immobile clients. Do not massage bony prominences. Provide adequate hydration, 2,000 to 3,000 milliliters a day, and meet protein and calorie needs. Note if serum albumin levels are low, below 3.5 grams, because a lack of protein puts the client at greater risk for skin breakdowns, slowed healing, and infection. Provide nutritional support as indicated, such as vitamin and mineral supplements, nutritional supplements, enteral nutrition, and parenteral nutrition. Okay. Now this is a chart for treatment. Stage: suspected deep tissue injury and stage 1. The intervention: you want to relieve pressure, encourage frequent turning and repositioning, use pressure relieving devices such as air fluidized bed, implement pressure reduction surfaces, air mattress, foam mattress, and keep the client dry, clean, well nourished, and hydrated. Stage 2: maintain a moist healing environment, saline or occlusive dressing. Promote natural healing while preventing the formation of scar tissue. Provide nutritional supplements as prescribed and administer analgesics as prescribed. Stage 3: clean and or debride. Prescribed dressing, surgical intervention, proteolytic enzymes. Provide nutritional supplements as prescribed Administer analgesics as prescribed, and administer antimicrobials, a topical and/or systemic, as prescribed. Stage 4, clean or debride, prescribe dressing, surgical intervention, proteolytic enzymes, and perform non-adherent dressing changes every 12 hours. Treatment may include skin grafts. Provide nutritional supplements as prescribed. Administer analgesics as prescribed. And administer antimicrobials, topical and/or systemic, as prescribed. Unstageable, debride as prescribed until the ulcer can be staged. Complications and nursing implications. Deterioration to a higher stage ulceration and/or infection. You want to assess/monitor the ulcer frequently and report increases in the size or depth of the lesion, changes in granulation tissue, i.e. color, texture, and changes in exudates, color, quantity, odor. Follow the facility's protocol for ulcer treatment. Systemic infection. Assess and monitor the client for signs of sepsis, changes in level of consciousness, persistent recurrent fever, tachycardia, tachypnea, hypotension, oliguria, increased WBC count. Prevent infection by using appropriate asepsis when performing ulcer treatment and dressing changes. Provide optimal nutrition to promote the immune response. Provide for adequate rest to promote healing. Administer antibiotic therapy as prescribed. Yay, application exercises. An adolescent child or client who has diabetes mellitus is 2 days post-operative following an appendectomy. The client is tolerating a regular diet well. He has ambulated successfully around the unit with assistance and requests pain medication every 6 to 8 hours while reporting pain at a 2 on a scale of 0 to 10 after the medication is given. His incision is approximated and free of redness with scant serous drainage noted on the dressing. Which of the following risk factors for poor wound healing does this client have? And the choices are extremes in age, impaired circulation, impaired suppressed immune system, malnutrition, and poor wound care, such as breaches in aseptic technique. And the answers are impaired circulation and impaired suppressed immune system. Diabetes mellitus places this client at risk for impaired circulation and impaired immune system function. The client is not at either extreme of the age spectrum, and there is no indication that he is malnourished or that there have been any breaches in aseptic technique during wound care. 2. An entry in a client's chart states the wound drainage is sanguineous. That means it's A. Watery in appearance, B. Green tinged or yellow, C. Bright red, or D. Foul smelling. The answer is C. Sanguineous drainage is bright red and the result of active bleeding. A watery appearance is characteristic of serous or serosanguineous drainage, and green tinged or yellow and foul smelling are characteristics of purulent draining. 3. Which of the following is an example of a wound or injury healing by secondary intention? A. An open burn area. B. A bone fracture that is casted. C. A sprained ankle. Or D. A sutured surgical incision. And the answer is A. An open burn area. A burn has loss of tissue and the skin edges are not together. A fractured bone and sprained ankle are injuries to underlying structures and do not require healing of the skin. A sutured surgical incision heals by primary intention. Okay, 4. Scenario. An older adult woman is 6 days post-operative following surgery for a bowel obstruction. During the last 24 hours, she has reported nausea and she vomited small amounts of clear liquid 3 times in the last 8 hours. Her vital signs are stable. Currently, her incision is well approximated and free of redness, tenderness, and swelling. Which of the following findings would indicate development of a wound infection? A. Decreased pulse rate. B. Increased pain. C. Decreased WBC count. Or D. Increased thirst. The answer is B, increased pain. An increase in incisional pain is a sign of a possible wound infection. With infection, the pulse rate and WBC count increase. Increased thirst has many possible causes and does not necessarily indicate an infectious process. 5. Later that day, the client becomes confused and pulls off her surgical dressing. The nurse enters the room and finds the client's wounds separated with viscera protruding. Which of the following nursing interventions are appropriate? Select all that apply. Repack the wound, call for help, assist the client to a chair, cover the wound with a sterile dressing moistened with 0.9% sodium chloride, and stay with the client. And it's call for help, cover the wound with sterile dressing of 0.9% sodium chloride, and stay with the client. It is appropriate for the nurse to call for help, cover the wound with a sterile dressing moistened in 0.9% sodium chloride, and stay with the client. The nurse should not attempt to reinsert the organs or repack the wound. The nurse should have the client lie supine with her hips and knees bent. Scenario. This is 6. An older adult client who has diabetes mellitus must now use a wheelchair after a cerebrovascular accident, CVA, 2 years ago that affected her right side. She does not respond to pain on the right side of her body. Her fluid and food intake is good, but she needs help with eating. Which of the following risk factors for developing pressure ulcers does this client have? A. Dehydration. B. Limited mobility. C. Nutritional impairment. D. Incontinence. The answer is B. Limited mobility. The client's limited mobility is as a result of the CVA puts her at risk for skin breakdown. She is well hydrated and nourished, and there are no data to indicate that she has urinary or fecal incontinence. 7. Which of the following can the nurse do to prevent skin breakdown? A. Massage the client's bony prominences frequently. B. Keep the client in high Fowler's position while in bed. C. Have the client sit on a donut-shaped cushion. D. Encourage repositioning every 15 minutes while the client is in the wheelchair. And, of course, it's D. It is essential to encourage and help the client alter her position every 15 minutes while seated to prevent sustained pressure on any skin areas. While in bed, the head of the client's bed should be elevated no more than 30 degrees to prevent skin breakdown from shearing forces in the sacral area. Donut-shaped cushions increase pressure on the sacral area. A gel foam or air cushion would be a better choice. Why do they even make donut cushions then? Oh, I don't know. Okay. Which of the following statements describes a stage 3 pressure ulcer? A. The skin is reddened and does not blanch with pressure. B. The ulcer is an abrasion or a blister. C. The bone is exposed at the center of the ulcer. Or D. The ulcer extends past the subcutaneous tissue to the muscle. And it's D. The ulcer extends past the subcutaneous tissue of the muscle. A stage 3 ulcer may extend past all layers of skin and subcutaneous tissue to the muscle. Reddened skin that does not blanch is characteristic of stage 1. An abrasion or a blister is seen with stage 2, and exposed bone is characteristic of stage 4. Alright, and that was Unit 2. Moving right along to Unit 3. Alright, Unit 3. GI, acid-base, balance, electrolytes, lab values, blood gases, all that good stuff. Very important stuff. 9 questions on the final. Okay. Here we go. Overview. Fluids. Body fluids are distributed between intracellular or ICF and extracellular ECF compartments. Fluid can move between compartments through selectively permeable membranes by a variety of methods: diffusion, active transport, filtration, and osmosis, in order to maintain homeostasis. Electrolytes. Electrolytes are minerals, sometimes called salts, that are present in all body fluids. They regulate fluid imbalance and hormone production, strengthen skeletal structures, and act as catalysts in nerve response, muscle contraction, and the metabolism of nutrients. When dissolved in water or another solvent, electrolytes separate into ions and then conduct either a positive, cations, magnesium, potassium, sodium, calcium, or negative, anions, phosphate, sulfate, chloride, and bicarbonate, electrical current. Electrolytes are distributed between ICF and ECF compartments. While laboratory tests can accurately reflect the electrolyte concentrations in plasma, it is not possible to directly measure electrolyte concentrations within cell. Fluid imbalances that the nurse should be familiar with are fluid volume deficits and fluid volume excesses. Fluid volume deficits. Fluid volume deficits, or FVDs, include hypovolemia, isotonic, and that's loss of water and electrolytes from the ECF, and dehydration, osmolar. That's loss of water with no loss of electrolytes. So hypovolemia is loss of water and electrolytes from the ECF, and dehydration is just loss of water, keeping the electrolytes in the body. Hemoconcentration occurs with dehydration, resulting in increases in HCT, serum electrolytes, and urine-specific gravity. Okay. Note: compensatory mechanisms include sympathetic nervous system response of increased thirst, antidiuretic hormone ADH release, and aldosterone release. Hypovolemia can lead to hypovolemic shock. Older adults have an increased risk of dehydration due to a decrease in total body mass, which includes total body water content. Assessment. Risk factors. Causes of hypovolemia: abnormal gastrointestinal losses, vomiting, nasogastric suctioning, diarrhea, abnormal skin losses, diaphoresis, sweated, abnormal renal losses, diuretic therapy, diabetes insipidus, renal disease, adrenal insufficiency, and osmotic diuresis. So those were the abnormal renal losses. Third spacing, which would be peritonitis, intestinal obstruction, acidez, and burns. Hemorrhage, and then there's altered intake, such as nothing by mouth, NPO. Causes of dehydration would be hyperventilation, diabetic ketoacidosis, enteral feeding without sufficient water intake. Subjective and objective data would be vital signs, hyperthermia, tachycardia, thready pulse, hypotension, orthostatic hypotension, decreased central venous pressure, tachypnea, which is increased respirations, and hypoxia. Musculoskeletal, be dizziness, syncope or fainting, confusion, weakness, fatigue. GI would be thirst, dry furrowed tongue, nausea, vomiting, anorexia, acute weight loss. Renal would be oliguria, which is decreased production of urine. Other signs: diminished capillary refill, cool, clammy skin, diaphoresis, sunken eyeballs, and flattened neck veins. All subjective and objective data for hypovolemia and dehydration. Lab findings: HCT. Not sure what HCT is. Hypovolemia would be increased HCT, and dehydration would be increased hemoconcentration. No, it's probably hemoconcentration, isn't it? Okay. So hypovolemia is increased HCT, and dehydration is increased hemoconcentration, but not present when dehydration is caused by hemorrhage. Right, because you're losing blood at the same time. Serum osmolarity. Dehydration would be increased hemoconcentration osmolarity greater than 300 MOSM per liter, and increased protein, bun, electrolyte, and glucose. So all those are increased with dehydration. Urine specific gravity and osmolarity. Dehydration, increased concentration. Serum sodium, be dehydration, increased hemoconcentration. Collaborative care, nursing care. Assess respiratory rate, symmetry, and effort. Monitor for shortness of breath and dyspnea. Check urinalysis, oxygen saturation, SaO2, CBC, and electrolytes. Administer supplemental oxygen as prescribed. Measure the client's weight daily at the same time of day using the same scale. Observe for nausea and vomiting. Assess and monitor the client's vital signs. Check for hypotension and orthostatic hypotension. Check neurological status to determine level of consciousness. Assess heart rhythm, may be irregular or tachycardic. Initiate and maintain IV access. Place the client in shock position, which is on back with legs elevated. Fluid replacement. Administer IV fluids as prescribed. Isotonic solutions such as lactated ringers or 9.9% sodium chloride, or blood transfusions. Monitor IO. Alert the provider to a urine output less than 30 mils an hour. Monitor level of consciousness and ensure client safety. Assess level of gait stability. Encourage the client to use the call light and ask for assistance. Encourage client to change positions slowly, rolling from side to side or standing up. Check capillary refill. Expected range less than 2 seconds. Fluid volume excesses. Okay, and this fluid volume excesses, FVEs, include hypervolemia isotonic, which is water and sodium retained in abnormally high proportions, and overhydration osmolar, more water gained than electrolytes. Severe hypervolemia can lead to pulmonary edema, and heart failure. Hemodilution occurs with overhydration, resulting in decreases in HCT, serum electrolytes, and protein. Note: compensatory mechanisms include an increased release of natriuretic peptides, resulting in increased loss of sodium and water by the kidneys, and a decreased release of aldosterone. Risk factors. This is assessment. Risk factors. Causes of hypervolemia. Chronic stimulus to the kidney to conserve sodium and water. Heart failure, cirrhosis, increased glucocorticosteroids. Abnormal renal function with reduced excretion of sodium and water. be like renal failure. Interstitial to plasma fluid shifts, be hypertonic fluids and burns. Related changes in cardiovascular and renal function, excess sodium intake. Causes of overhydration. Water replacement without electrolyte replacement. Be strenuous exercise with profuse diaphoresis. Subjective and objective data. Subjective and objective data. Vital signs. Tachycardia, bounding pulse, hypertension, tachypnea, increased central venous pressure. Neuromusculoskeletal would be confusion, muscle weakness. GI would be weight gain, ascetase. Respiratory would be dyspnea, orthopnea, crackles. Other signs, edema and distended neck veins. Big bulging neck veins. Laboratory findings. Hemoconcentration and hypervolemia is decreased HCT, and overhydration is decreased HCT equals hemodilution. Serum osmolarity, the overhydration would be decreased. Overhydration would be decreased hemodilution, osmolarity less than 270 MOSMs per liter. So below 270 for overhydration. Serum sodium. Hypervolemia. Sodium within expected reference range. Electrolytes, bun, and creatine, whatever. Overhydration and hypervolemia will have decreased electrolytes, bun, and creatine. Arterial gases, respiratory alkalosis, and decreased CO2 be less than 35 for the CO2. Increased pH greater than 7.45. So high pH, low CO2 for respiratory alkalosis, for overhydration and hypovolemia. Diagnostic procedures. Chest x-rays may indicate pulmonary congestion. Collaborative care, nursing care. Assess respiratory rate, asymmetry, and effort. Assess breath sounds in all lung fields. Lung sounds may be diminished with crackles. Monitor for shortness of breath and dyspnea. Check ABGs, SaO2, CBC, and chest x-ray results. Position the client in semi-Fowler's position. Measure the client's weight daily. Monitor I&O. Administer supplemental oxygen as needed. Reduce IV flow rates. Administer diuretics, osmotic loop as prescribed. Limit fluid and sodium intake as prescribed, and monitor and document edema, pretibial, sacral, and paraorbital. Orbital. Monitor and document circulation to the extremities. Reposition the client at least every 2 hours. And support arms and legs to decrease dependent edema as appropriate. Alright, electrolytes. Major electrolytes in the body include sodium, potassium, chloride, magnesium, phosphorus, and calcium. Nurses monitor the client's lab values to identify any electrolyte imbalances. It is important to recognize the signs and symptoms of electrolyte imbalance. Clients at greatest risk for electrolyte imbalance are infants and children, older adults, clients with cognitive disorders, and clients who are chronically ill. Sodium imbalances. Sodium, or Na+, is the major electrolyte found in ECF. Sodium is essential for maintenance of acid-base balance, active and passive transport mechanisms, and irritability and conduction of nerve and muscle tissue. Expected serum sodium levels are between 136 and 145 millicues per liter. 136 and 145. Hyponatremia is a serum sodium level less than 136 millicues per liter. Hyponatremia is a net gain of water or loss of sodium-rich fluids. Hyponatremia delays and slows the depolarization of membranes. Water moves from the ECF into the ICF, which causes cells to swell. Cerebral edema. Serious complications can result from untreated acute hyponatremia, i.e., coma, seizures, and respiratory arrest. Okay, so hyponatremia, salt moves out of the blood into the cells and causes it to swell, causes cerebral edema, coma, seizures, respiratory arrest. Okay, assessment. Risk factors. Causes of hyponatremia, loss of sodium, deficient ECF volume, abnormal GI losses, vomiting, nasogastric suctioning, diarrhea, tap water enemas. Renal losses, diuretics, kidney disease, adrenal insufficiency, excessive sweating. Skin losses, burns, wound drainage, gastrointestinal obstruction, peripheral edema, and ascites. Increased or normal ECF volume, be excessive oral water intake, syndrome of inappropriate antidiuretic hormone, which is SIADH, which is the excess secretion of antidiuretic hormone, or ADH. Edematous states, that'd be heart failure, cirrhosis, nephrotic syndrome, excessive hypotonic IV fluids, inadequate sodium intake, or NPO status, and age-related risk factors. Older adult clients are at a greater risk due to an increased incidence of chronic illness, use of diuretic medications, and risk for insufficient sodium intake. Subjective and objective data. Physical assessment findings. Physical assessment findings vary with a normal, decreased, or increased ECF volume. Vital signs: hypothermia, tachycardia, rapid thready pulse, hypotension, orthostatic hypotension, neuromusculoskeletal headache, confusion, lethargy, muscle weakness with possible respiratory compromise, fatigue, decreased deep tendon reflexes, DTR. And GI, increased motility, hyperactive bowel sounds, abdominal cramping, and nausea. So those are subjective and objective data for hyponatremia. Lab findings. Serum sodium decreased less than 136, and serum osmolarity decreased less than 280 MOSMs. Collaborative care, nursing care, Report abnormal laboratory findings to the provider. Fluid overload. Restrict water intake as prescribed. Acute hyponatremia. Administer hypertonic oral and IV fluids as prescribed, and encourage foods and fluids high in sodium, cheese, milk, condiments. Restoration of normal ECF fluid. Administer isotonic IV therapy, 0.9% sodium chloride lactated ringers. Monitor INOs and weigh the client daily. Monitor vital signs and level of consciousness, reporting abnormal findings. Encourage the client to change position slowly. Follow any prescribed fluid restrictions. Hypernatremia. Hypernatremia is a serum sodium level that is greater than 145 millicuries per liter. Hypernatremia is a serious electrolyte imbalance. It can cause significant neurological, endocrine, and cardiac disturbances. Increased sodium causes hypertonicity of the serum. This causes a shift of water out of the cells, making the cells dehydrated. Risk factors. Assessment. Risk factors. Causes of hypernatremia. Loss of sodium. Water deprivation and related to NPO. Excessive sodium intake. Dietary sodium intake. Hypertonic IV fluids. Bicarbonate intake. Excessive sodium retention, renal failure, Cushing's syndrome, aldosteronism, some medications like glucocorticosteroids, fluid loss, fever, diaphoresis, burns, respiratory infection, diabetes insipidus, hyperglycemia, watery diarrhea, age-related changes, specifically decreased total body water content and inadequate fluid intake related to an altered thirst mechanism. Okay. Compensatory mechanisms: increased thirst and increased production of ADH. Okay, so increased thirst, you need water, increased production of ADH, retains water. Okay. Subjective and objective data. Vital signs: hyperthermia, tachycardia, orthostatic hypotension. Neuromusculoskeletal would be restlessness, irritability, muscle twitching, muscle weakness, seizures, coma, reduced to absent DTRs. GI, thirst, dry mucous membrane, increased motility, hyperactive bowel sounds, abdominal cramping, nausea. Other signs: edema, warm flushed skin, oliguria. Laboratory findings: serum sodium increased greater than 145 millicuries per liter. Serum osmolarity increased greater than 300 MOSMs per liter. Okay. Collaborative care. Nursing care. Report abnormal laboratory findings to the provider. Fluid loss based on serum osmolarity. Administer hypertonic IV fluids, 0.45% sodium chloride. Administer isotonic IV fluids, 0.9% sodium chloride. Excess sodium. Encourage water intake and discourage sodium intake. Administer diuretics, loop diuretics. Monitor level of consciousness and ensure safety. Provide oral hygiene and other comfort measures to decrease thirst. Monitor INO and alert the provider if renal output is inadequate. Potassium imbalances. Oh, my favorite now. Here we go. Potassium, K positive, is the major cation in ICF, intracellular fluid. Potassium plays a vital role in cell metabolism, transmission of nerve impulses, functioning of cardiac, lung, and muscle tissues, and acid-base balance. Potassium has reciprocal action with sodium. Expected serum potassium levels are 3.5 to 5 millieqs. Hyperkalemia is a serum potassium level below 3.5 millieqs. So hypokalemia. Okay. Hypokalemia is the result of an increased loss of potassium from the body or movement of potassium into the cells. Risk factors. Causes of hypokalemia. Loss of potassium. Abnormal GI losses. Vomiting, nasogastric suctioning, diarrhea, inappropriate laxative use. Renal losses, excessive use of diuretics such as furosemide or Lasix, and corticosteroids. Skin losses, diaphoresis, wound losses, insufficient potassium, inadequate dietary intake, which is rare. Prolonged administration of non-electrolyte containing IV solutions such as 5% dextrose in water. ICF, metabolic alkalosis, after correction of acidosis, during periods of tissue repair, burns, trauma, starvation, and total parenteral nutrition. Age-related risk factors. Older adults clients are at greater risk due to increased use of diuretics and laxatives. Subjective and objective data having to do with hypokalemia. Vital signs: hyperthermia, weak irregular pulse, hypotension, and respiratory distress. Neuromusculoskeletal: weakness with respiratory collapse and paralysis, muscle cramping, decreased muscle tone, and hypoactive reflexes. Paresthesia, mental confusion. So weakness with respiratory collapse and paralysis, muscle cramping, decreased muscle tone, and hypoactive reflexes. Paresthesia and mental confusion. ECG would be premature ventricular contractions, or PVCs, bradycardia, blocks, ventricular tachycardia, inverted T waves, and ST depression. GI, decreased motility, abdominal distension, constipation, ileus, nausea, vomiting, anorexia. Other signs: polyuria, excretion of dilute urine. Laboratory findings: serum potassium decreased less than 3.5 millieqs. Arterial blood gases, you have metabolic alkalosis, pH greater than 7.45. Okay, and diagnostic procedures: electrocardiogram will show findings of dysrhythmias such as PVCs, or premature ventricular contractions, ventricular tachycardia, inverted T waves, and ST depression. Collaborative care, nursing care. Report abnormal findings to the provider. Treat the underlying cause. Replace potassium. Encourage foods high in potassium: avocados, broccoli, dairy products, dried fruit, cantaloupe, and bananas. Provide oral potassium supplementation. IV potassium supplementation. Never IV bolus, high risk of cardiac arrests. The maximum recommended rate is 5 to 10 millieqs per hour. Monitor for phlebitis or tissue irritant. Monitor for and maintain an adequate urine output. Monitor for shallow, ineffective respirations and diminished breath sounds. Monitor the client's cardiac rhythm and intervene promptly as needed. Monitor clients receiving digoxin. Hyperkalemia or hypokalemia increases the risk of digoxin toxicity. Monitor level of consciousness and ensure safety. Monitor bowel sounds and abdominal distension and intervene as needed. Now on to hyperkalemia. Hyperkalemia is a serum potassium level greater than 5 milliQs. Hyperkalemia is the result of an increased intake of potassium, movement of potassium out of the cells, or inadequate renal excretion. Assessment. Risk factors. Increased total body potassium, IV potassium administration, salt substitutes, ECF shift, decreased insulin, acidosis, diabetic ketoacidosis, tissue catabolism or sepsis, trauma, surgery, fever, myocardial infarction. That's ECF shift. Hypertonic states, uncontrolled diabetes mellitus. Decreased excretion of potassium, related to renal failure, severe hydration or dehydration, severe dehydration, potassium sparing diuretics, ACE inhibitors, NSAIDs, and adrenal insufficiency. Older adult clients at greater risk due to increased use of salt substitutes, angiotensin converting enzyme inhibitors, or ACE inhibitors, and potassium sparing diuretics. All risk factors for hyperkalemia. Subjective and objective data. Vital signs. Slow, irregular pulse, hypotension related to hyperkalemia, neuromusculoskeletal, restlessness, irritability, weakness, and ascending flaccid paralysis, paresthesias. ECG, ventricular fibrillation, peaked T waves, and widened QRS. So ventricular fibrillation, peaked T waves, and widened QRS, whereas the ECG. And GI, nausea, vomiting, increased motility, diarrhea, hyperactive bowel sounds. Other signs, oliguria. Laboratory findings. Serum potassium increased greater than 5 milliQs. Arterial blood gas, this is related to metabolic alkalosis. Hyperkalemia is metabolic alkalosis. pH less than 745. Diagnostic procedures. ECG will show dysrhythmias, ventricular fibrillation, peak T waves, and widened QRS. Okay, I'm noticing a possible misprint, or maybe I'm just wrong, but you might want to check. Metabolic alkalosis, it says pH greater than 745 for, wait, maybe not. Yeah. It says metabolic alkalosis, pH greater than 745 for hypokalemia, and then it says it's also metabolic alkalosis, pH less than 745 for hyperkalemia. So I don't know. I'll have to check that, but I don't know. So collaborative care, nursing care, report abnormal findings to the provider, decrease potassium intake, stop infusion of IV potassium, withhold oral potassium, provide a potassium-restricted diet, and avoiding avocados, broccoli, dairy products, dried fruit, cantaloupe, bananas. If potassium levels are extremely high, dialysis may be required. Promote the movement of potassium from ECF to ICF. Administer IV fluids with dextrose and regular insulin. Administer sodium bicarbonate to reverse acidosis. Monitor the client's cardiac rhythm and intervene promptly as needed. Medications to increase potassium excretion are administer loop diuretics such as Lasix. If renal function is adequate, loop diuretics increase the depletion of potassium from the renal system. Maintain IV access. Prepare this client for dialysis if prescribed. Now on to calcium imbalances. Calcium is found in the bones and the teeth. It is plentiful in the body. The expected calcium level is 9 to 10.5 milligrams or 4.5 milligrams for ionized calcium. But I think we do 9 to 10.5. Calcium balance is essential for proper functioning of the cardiovascular, neuromuscular, and endocrine systems, as well as blood clotting and bone and teeth formation. Hypocalcemia is a serum calcium level less than 9 milligrams. Risk factors: malabsorption syndromes such as Crohn's disease, end-stage renal disease, malabsorption syndromes such as Crohn's disease, end-stage renal disease, post-thyroidectomy, hypoparathyroidism, and repeated transfusion. Subjective and objective data: muscle twitches, tetany, frequent painful muscle spasms at rest, hyperactive DTRs, positive Chvostek's sign, that's tapping on the facial nerve triggering facial twitching, and positive Trousseau's sign, that's hand/finger spasms with sustained blood pressure cuff inflation. Cardiovascular: for hypocalcemia would be decreased myocardial contractility, decreased heart rate, and hypotension. GI: hyperactive bowel sounds, diarrhea, and abdominal cramping. Central nervous system: be seizures due to overstimulation of the CNS. Laboratory findings: calcium level less than 9 milligrams. Diagnostic procedures would be ECG, look for prolonged QT interval. Collaborative care: administer oral or IV calcium supplements, initiate seizure precautions, keep emergency equipment on standby, encourage foods high in calcium, include dairy products and dark green veggies. What, no hypercalcemia? Okay, good. On to magnesium imbalances. Most of the body's magnesium is found in the bones. Magnesium in smaller amounts is found within the body cells. A very small amount is found in ECF. The expected magnesium level is 1.3 to 2.1 millicues per liter. Hypomagnesemia. Hypomagnesemia is a serum magnesium level less than 1.3 milligrams. Risk factors and assessment risk factors. Causes of hypomagnesemia: malnutrition, insufficient magnesium intake, alcohol ingestion, magnesium excretion, Subjective and objective data, neuromuscular, increased nerve impulse transmission, hyperactive DTRs, paresthesias, muscle tetany, positive Chvostek's and Trousseau signs, also related to hypomagnesemia. GI, did I already say that? No, GI, hypoactive bowel sounds, constipation, abdominal distension, paralytic ileus, nursing care, discontinue magnesium losing medications like loop diuretics, administer oral or IV magnesium sulfate following safety protocols. IV route is used because IM can cause pain and tissue damage. Oral magnesium can cause diarrhea and increase magnesium depletion. Monitor closely. Encourage foods high in magnesium, including dairy products and dark green vegetables. Alright, that was the electrolytes, and we'll do application exercises now. One, a nurse is collecting data from an older adult client who states he has been vomiting and diarrhea for the last 48 hours. Which of the following findings should indicate to the nurse that the client is hypovolemic? Select all that apply. So, bradycardia, hypertension, tachypnea, furrowed tongue, and sunken eyeballs. Which ones are hypovolemic? And it'd be tachypnea, furrowed tongue, and sunken eyeballs. A client who has altered intake is at risk for hypovolemia. Older adults are at greater risk than younger adults. In the presence of hypovolemia, tachycardia, hypotension, tachypnea, a furrowed, dry tongue, and sunken eyeballs may be seen. So it's hypotension and tachycardia, not bradycardia and hypertension for hypovolemia. Whew. A nurse is providing teaching about a healthy lifestyle for a group of young adults who are training for a marathon. Which of the following should the nurse include in the teaching session? A. Decrease fluid intake after training. B. Decrease fluid intake in high altitudes. C. Increase fluid intake in dry climates. D. Increase intake of fluids containing caffeine. The answer is C. Increase fluid intake in dry climates. Fluid intake should be increased with excessive vigorous exercise in high altitudes. Fluid intake should also be increased in dry climates. Caffeine should be avoided because excessive intake may lead to dehydration. 3. A nurse is caring for a client who was admitted to the hospital for peritonitis and has signs of dehydration. Which of the following laboratory findings would be expected for this client? Select all that apply. Increased HCT, decreased serum osmolarity, increased serum sodium, decreased urine specific gravity, increased urine osmolarity. And the answer is increased HCT, increased serum sodium, and increased urine osmolarity. In the presence of dehydration, not related to hemorrhage, urine osmolarity and urine specific gravity are increased due to hemoconcentration. Serum osmolarity and serum sodium are increased. Four, a nurse on a medical surgical unit has been assigned to care for 4 clients. Which of the following clients is at risk for fluid volume excess or hypervolemia? A client who is receiving a high ceiling loop diuretic, a client who has had heart failure, a client who lost 500 milliliters of blood during surgery, a client who is 4 hours postoperative and receiving nasogastric suctioning. Answer is B, a client who has heart failure. Client who has heart failure is at risk for fluid retention and fluid volume excess. The other clients are at risk for hypovolemia. Okay, a nurse is reviewing the laboratory findings for a group of clients. Which of the following findings should be reported to the provider? A. Serum sodium 143 millicues. Serum potassium. B. Serum potassium 4 millicues. C. Serum calcium 8.5. D. Serum chloride 99 millicues. And it's C. Serum calcium 8.5. A serum calcium level of 8.5 is below the expected reference range and should be reported to the provider. The other findings are within the expected reference range. 6. A nurse on a medical surgical unit is caring for a client who is hypernatremic. Which of the following should be included in the plan of care? A. Infuse hypotonic IV fluids. B. Restrict oral intake of water. C. Increase sodium intake. D. Administer a loop diuretic. Answer is A. Infuse hypotonic IV fluids. The plan of care for a client who is hypernatremic should include hypotonic or isotonic fluids. Water intake is encouraged. Sodium intake is restricted. A loop diuretic will increase the secretion of sodium. Okay, and that was Unit 3. We'll do Unit 4 next. 6 questions about neuro, treatment of someone who had a stroke, thrombolytic, stroke gets TPA, diagnosis paralysis of face, not a bleed, Alzheimer's. Okay, that didn't make any sense, but we'll do that in a second here. Okay, here we go. Unit 4, Neuro. Switching over to the Med-Surg ATI book, we're in Nursing Care of Clients with Neurosensory Disorders, Chapter 4, Pain Management. Overview. Effective pain management includes the use of pharmacological and non-pharmacological pain management therapies. Invasive therapies such as nerve ablation may be appropriate for intractable cancer-related pain. Clients have a right to adequate assessment and management of pain. Nurses are accountable for the assessment of pain. A nurse's role is that of an advocate and educator for effective pain management. Nurses have a priority responsibility for the continual assessment of a client's pain level and to provide individualized interventions. They should assess the effectiveness of the intervention 30 to 60 minutes after implementation. Assessment challenges may occur with clients who are cognitively impaired or on a ventilator. Undertreatment of pain is a serious health care problem. Consequences of undertreatment of pain include physiological and psychological components. Acute/chronic pain can cause anxiety, fear, and depression. Poorly managed acute pain may lead to chronic pain syndrome. Physiology of pain. Transduction is the conversion of painful stimuli to an electrical impulse through peripheral nerve fibers called nociceptors. Transmission occurs as the electrical impulse travels along the nerve fibers and is regulated by neurotransmitters. The point at which one feels pain is known as the pain threshold. The amount of pain one is willing to bear is known as pain tolerance. Substances that increase pain transmission and cause an inflammatory response. Substance P, prostaglandins, bradykinin, histamine. Substances that decrease pain transmission and produce analgesia would be serotonin and endorphins. Perception of awareness or pain occurs in the brain and is influenced by thought and emotional processes. Modulation occurs in the spinal cord, causing muscles to contract reflexively, moving the body away from painful stimuli. Pain categories. Acute pain. Acute pain is protective, temporary, usually self-limiting, and resolves with tissue healing. Physiological responses. Sympathetic nervous system are fight or flight responses. Tachycardia, hypertension, anxiety, diaphoresis, muscle tension. Behavioral responses include grimacing, moaning, flinching, and guarding. Interventions include treatment of the underlying problem. Chronic pain. Chronic pain is not protective. It is ongoing or recurs frequently, lasting longer than 6 months and persisting beyond tissue healing. Physiological responses do not usually alter vital signs, but the client may experience depression, fatigue, and a decreased level of functioning. Psychosocial implications may lead to disability. Chronic pain may not have a known cause, and it may not respond to interventions. Management of pain is aimed at symptomatic relief. Chronic pain can be malignant or non-malignant. Nociceptive pain. Nociceptive pain arises from damage to or inflammation of tissue other than that of the peripheral and central nervous system. It is usually throbbing, aching, and localized. This pain typically responds to opioids and non-opioid medications. Types of nociceptive pain are somatic, which means in bones, joints, muscles, skin, or connective tissues. Visceral, in internal organs such as the stomach or intestines. It can cause referred pain in other body locations not associated with the stimulus, and cutaneous, in the skin or subcutaneous tissue. Neuropathic pain. Neuropathic pain arises from abnormal or damaged pain nerves. It includes phantom limb pain, pain below the level of a spinal cord injury, and diabetic neuropathy. Neuropathic pain is usually intense, shooting, burning, or described as pins and needles. This pain typically responds to adjuvant medications, antidepressants, antispasmodic agents, and skeletal muscle relaxants. Risk factors for undertreatment of pain. Risk factors for undertreatment of pain are cultural and societal attitudes, lack of knowledge, fear of addiction, exaggerated fear of respiratory depression, and anxiety about making errors in administration of pain medication. Populations at risk for undertreatment of pain are infants, children, older adults, and clients with substance abuse problems. Causes of acute and chronic pain: trauma, surgery, cancer, tumor invasion, nerve compression, bone metastasis, associated infections, immobility, arthritis, and fibromyalgia. Neuropathy, diagnostic or treatment procedures like injections, intubation, and radiation. The pain experience is affected by age. Infants cannot verbalize or understand their pain, and older adult clients may have multiple pathologies that cause pain and limit function. Fatigue, which can increase sensitivity to pain. Genetic sensitivity, which can increase or decrease the amount of pain an individual can tolerate. Cognitive function. Clients who are cognitively impaired may not be able to report pain or report it accurately. Prior experiences, which can increase or decrease sensitivity depending on whether or not adequate relief was obtained. Anxiety and fear, which can increase sensitivity to pain. Support systems that are present and can decrease sensitivity to pain. Culture, which may influence how a person expresses pain or the meaning given to it. According to noted pain experts Margot McCaffrey and Chris Passero, pain is whatever the person experiencing it says it is, and it exists whenever the person says it does. The client's report of pain is the most reliable diagnostic measure of pain. Self-report using standardized pain scales is useful for clients who are older than 7 years. Specialized pain scales are available for use with younger children. Pain should be assessed and recorded frequently and may be considered the fifth vital sign. Subjective data can be obtained using a symptom analysis. Parameters. The location is described using anatomical terminology and landmarks. Assessment. Ask, where is your pain? Does it radiate anywhere else? Ask the client to point to the location. Parameters. Quality refers to how the pain feels. Feelings of pain include sharp, dull, achy, burning, stabbing, pounding, throbbing, shooting, gnawing, tender, heavy, tight, tiring, exhausting, sickening, terrifying, torturing, nagging, annoying, intense, and or unbearable. Assessment. Ask the client, what does the pain feel like? Give the client more than two choices. Is the pain throbbing, burning, or stabbing? Parameters. Intensity, strength, and severity are measures of pain. Visual analog scales, e.g. description scale, number rating scales, can be used to measure pain, monitor pain, evaluate the effectiveness of interventions. Assessment. Ask the client the following questions. How much pain do you have now? What is the worst the best the pain has been? How would you rate your pain on a scale of 0 to 10? Timing, onset, duration, frequency. Ask the following questions. When did it start? How long does it last? How often does it occur? Is it constant or intermittent? Setting. How the pain affects daily life or how ADLs affect the pain. Ask the following questions. Where are you when the symptoms occur? What are you doing when the symptoms occur? What does the pain affect, or how does the pain affect your sleep? How does the pain affect your ability to work and do your job? Associated symptoms that should be noted include fatigue, depression, nausea, and anxiety. Ask, what other symptoms do you experience when you are feeling pain? Aggravating and relieving factors. Ask the questions, what makes the pain better? What makes the pain worse? Are you currently taking any prescription, herbal, or other over-the-counter medications? Objective data. Behaviors complement self-report and assist in pain assessment of clients who are nonverbal. Facial expressions, grimacing, wrinkled forehead, and body movements, restlessness, pacing, guarding, moaning, crying, decreased attention span. Acute pain temporarily increases blood pressure, pulse, and respiratory rate. Eventually, increases in vital signs will stabilize despite the persistence of pain. Therefore, physiologic indications may not be an accurate measure of pain over time. Cutaneous skin stimulation. This is non-pharmacological pain management. Cutaneous skin stimulation, transcutaneous electrical nerve stimulation, or TENS, heat, cold therapeutic touch, and massage. Interruption of pain pathways, cold for inflammation, heat to increase blood flow and to reduce stiffness. Distraction includes ambulation, deep breathing, visitors, TV, and or music. Relaxation includes meditation, yoga, and or progressive muscle relaxation. Imagery focuses on a pleasant thought to divert focus, requires an ability to concentrate. Acupuncture, vibration, or electrical stimulation via tiny needles inserted into the skin and subcutaneous tissue at specific points. Reduction of pain stimuli in the environment. Elevation of extremities that are edematous help to promote venous return and decrease swelling. So I don't know what edematous is, even though we read it earlier. Pharmacological interventions. Analgesics are the mainstay for relieving pain. The three classes of analgesics are non-opioid, opioid, and adjuvants. Non-opioid analgesics such as acetaminophen, ibuprofen, and aspirin are appropriate for treating mild to moderate pain. Acetaminophen has analgesic and antipyretic effects. NSAIDs have analgesic, anti-inflammatory, antiplatelet, and antipyretic effects. Be aware of the hepatotoxic effects of acetaminophen. A client who has a healthy liver should take no more than 4 grams a day. Be aware of opioids that can contain acetaminophen, such as hydrocodone, bitartrate 5 milligrams, and acetaminophen 500 milligrams, or Vicodin. Monitor the client for solipsism or tinnitus, vertigo, decreased hearing acuity. Prevent gastric upset in the client by administering the medication and food or acids. Monitor the client for bleeding with long-term NSAID use. Opioid analgesics, morphine, sulfate, fentanyl, codeine, are appropriate for treating moderate to severe pain, postoperative pain, MI pain, cancer pain. Following a PRN schedule, manage a client's acute severe pain with short-term 24 to 48 hour around-the-clock opioids. The parenteral route is preferred for immediate short-term relief of acute pain. The oral route is the preferred route for chronic non-fluctuating pain. Consistent timing and dosing of opioid administration will provide consistent pain control. It is essential to monitor and intervene for adverse effects of opioid use. Constipation. Use a preventative approach, monitoring for bowel movements, fluids, fiber intake, exercise, stool softeners, stimulant, laxatives, enemas. Orthostatic hypotension. Advise the client to sit or lie down if symptoms of lightheadedness or dizziness occur. Instruct the client to avoid sudden changes in position by slowly moving from a lying to a sitting or a standing position. Provide assistance with ambulation as needed. Urinary retention. Monitor the client's INO. Assess for distension. Administer bethanacol or uricoline and catheterize as prescribed. Nausea and vomiting. Administer antiemetic. Advise the client to lie still and or move slowly and eliminate odors. Sedation. Monitor the client's level of consciousness and take safety precautions. Sedation usually precedes respiratory depression. Respiratory depression. Monitor the client's respiratory rate prior to and following administration of opioids, especially in clients who are opioid naive. Initial treatment of respiratory depression and sedation is generally a reduction in opioid dose. If necessary, slowly administer diluted Narcan as prescribed to reverse opioid effects. Adjuvant analgesics enhance the effects of non-opioids, help alleviate other symptoms that aggravate pain, depression, seizures, inflammation, and are useful for treatment of neuropathic pain. Adjuvant medications, anticonvulsants, carbamazepine or Tegretol, anti-anxiety agents, diazepam, Valium, tricyclic antidepressants, amitriptyline or Elavil, antihistamine, hydroxyzine or Visceral, glucocorticoids, dexamethasone or Decadron, antiemetics, ondansetron, hydrochloride or Zofran. PCA is a medication delivery system that allows the client to self-administer safe doses of opioid narcotics. Constant plasma levels are maintained by small, frequent doses. The client experiences less lag time between identified need and delivery of medication, which increases the client's sense of control and may decrease the amount of medication needed. Commonly used opioids are morphine sulfate and hydromorphone or Dilaudid. Client teaching is an important aspect of successful PCA therapy. The client is the only person who should push the PCA button to prevent inadvertent overdosing. Other strategies for effective pain management. Take a proactive approach by giving the client analgesics before pain becomes too severe. It takes less medication to prevent pain than to treat pain. Instruct the client to report developing or recurrent pain and to not wait until pain is severe for PRN orders of pain medication. Okay, educate the client regarding misconceptions about pain. Assist the client to reduce fear and anxiety. Create a treatment plan that includes both non-pharmacological and pharmacological pain relief measures. Complications and nursing implications. Undertreatment of pain is a serious complication and may lead to increased anxiety and acute pain and depression with chronic pain. Assess, monitor, and the client for pain frequently and intervene as appropriate. Sedation, respiratory depression, and coma can occur as a result of overdosing. Sedation also precedes respiratory depression. Identify clients who are high risk, like older adult clients who are opioid naive. Carefully titrate doses while closely monitoring respiratory status. Stop the opioid and give the antagonist Narcan if the client's respirations are less than 8 per minute and shallow, or if the client is difficult to arouse. Identify the cause of sedation. Use a sedation scale in addition to a pain rating scale to assess the client's pain, especially when administering opioids. Application exercises. When caring for clients experiencing pain, a nurse should recognize that which of the following substances decrease pain transmission. Select all that apply. Substance P, serotonin, bradykinin, endorphins, histamine. Answers are serotonin and endorphins. Serotonin and endorphins are natural substances within the body that decrease pain transmission. Substance P, bradykinin, and histamine all increase pain transmission. A nurse is performing a pain assessment on a client. Which of the following subjective data describe the quality of the client's pain? A. My pain is so bad that I cannot sleep at night. B. My pain feels like a tight feeling in my chest. C. The pain started last week after I went for a hike. D. My pain feels better if I rest in an upright position. Answer is B. Option B describes, that's my pain feels like a tight feeling in my chest. B describes the quality of pain, referring to how the pain feels to the client. This is typically a description such as throbbing, sharp, dull, or tight feeling. Option A describes associated symptoms such as difficulty sleeping, nausea, and anxiety. C describes the timing of the pain, and D describes a relieving factor. Which of the following statements describes nociceptive pain? Select all that apply. Arises from nerves by damaged pain, usually well localized, responds well to opioid analgesics, may result in referred pain associated with phantom limb pain, and it's usually well localized, responds well to opioid analgesics, and may result in referred pain. Nociceptive pain is usually localized, responds well to opioid analgesics, and may result in referred pain. Neuropathic pain arises from damaged pain nerves and is associated with phantom limb pain. A nurse is caring for a post-operative client. Which of the following assessment findings is the most reliable indicator that the client is experiencing pain? A. Blood pressure of 166/90. B. Pain rating of 9 on a scale of 0 to 10. Client grimaces when bed is moved. Or client refuses to eat. And that be B. Pain rating 9 out of 10. The client's self-report of pain using a standardized pain scale is the most reliable indicator of pain. Vital signs, nonverbal communication, and other actions may be indicators of pain but are not the most reliable. Okay, on to Chapter 8 of MedSurg ATI, Alzheimer's disease. Overview. Alzheimer's disease, AD, is a non-reversible type of dementia that progressively develops through 7 stages over many years. A special framework made up of 7 stages has been designed to categorize the disease and its signs and symptoms. The framework is based on 3 general stages: early stage, mid stage, and late stage. AD is a type of dementia. Dementia is defined as multiple cognitive deficits that impair memory and can affect language, motor skills, and/or abstract thinking. Some people die 4 to 6 years after diagnosis, but others can live with the disease for up to 20 years. AD is responsible for 60% of dementia cases in clients over 65 years of age. Age is the number one known risk factor for AD, which usually occurs after the age 65. AD is characterized by memory loss, problems with judgment, and changes in personality. Severe physical decline occurs along with deteriorating cognitive functions. Assessment. Risk factors: advanced age, genetic predisposition, environmental agents, herpes virus, metal or toxic waste, previous head injury, and apolipoprotein E. Stage 1. No impairment, normal function, no memory problems. Stage 2. Very mild cognitive decline, may be normal age-related changes, or very early signs of AD. Signs and symptoms are forgetfulness, especially of everyday objects, eyeglasses or wallet. No memory problems evident to provider, friends, or coworkers. Stage 3. Mild cognitive decline. Problems with memory or concentration may be measurable in clinical testing or during a detailed medical interview. Signs and symptoms: mild cognitive deficits, including losing or misplacing important objects, decreased ability to plan, short-term memory loss, noticeably to close relatives, decreased attention span, difficulty remembering words or names, difficulty in social or work situations. Stage 4. Moderate cognitive decline. Mild or early stage AD. Medical interview will detect clear-cut deficiencies. Signs and symptoms of stage 4: personality changes, appearing withdrawn or subdued, especially in social or mentally challenging situations, obvious memory loss, limited knowledge and memory of recent occasions, current events, or personal history, difficulty performing tasks that require planning and organizing, paying bills, or managing money, difficulty with complex mental arithmetic. Stage 5. Moderately severe cognitive decline, moderate or mid-stage AD. This is signs and symptoms for stage 5. Increasing cognitive deficits emerge. Inability to recall important details such as addresses, telephone numbers, or schools attended, but memory of information about self and family remains intact. Disorientation and confusion as to time and place. Stage 6. Severe cognitive decline, moderately severe or mid-stage AD. Signs and symptoms of stage 6. Memory difficulties continue to worsen. Loss of awareness of recent events and surroundings. May recall own name but unable to recall personal history. Significant personality changes are evident. Delusions, hallucinations, and compulsive behaviors. Wandering behavior. Requires assistance with usual ADLs such as dressing, toileting, grooming. Normal sleep-wake cycle is disrupted. Increased episodes of urinary and fecal incontinence. And stage 7. Very severe cognitive decline, severe or late-stage AD. Ability to respond to environment, speak, and control movement is lost. Unrecognizable speech, general urinary incontinence, inability to eat without assistance, and impaired swallowing. Gradual loss of all ability to move extremities, ataxia. Laboratory tests. Genetic testing for the presence of apolipoprotein E can determine if late-onset dementia is due to AD. Diagnostic procedures. There is no definitive diagnostic procedure except brain tissue examination upon death. Magnetic resonance imaging, MRI, CT, and CAT scan, and also PET and ECG may be performed to rule out other possible causes of symptoms. Collaborative care. Nursing care. Assess cognitive status, memory, judgment, and personality changes. Initiate bowel and bladder program with the client based on a set schedule. Encourage the client and family to participate in an AD support group. Provide a safe environment. Keep the client on a sleeping schedule and monitor for irregular sleeping patterns. Provide verbal and nonverbal ways to communicate with the client. Offer snacks or finger foods if the client is unable to sit for long periods of time. Check the client's skin weekly for breakdown. Provide cognitive stimulation. Offer varied environmental stimulation such as walks, music, or craft activities. Keep a structured environment and introduce change gradually. A client's daily routine or a room change. Use a calendar to assist with orientation. Use short directions when explaining an activity or care the client needs, such as a bath. Be consistent and repetitive. Use therapeutic touch. Provide memory training. Reminiscence with the client about the past. Use memory techniques such as making lists and rehearsing. Stimulate the client's memory by repeating the client's last statement. Avoid overstimulation. Keep noise and clutter to a minimum and avoid crowds. Promote consistency by placing commonly used objects in the same location and using a routine schedule. Reality orientation, early stages. Easily viewed clock and single day calendar. Pictures of family and pets. Frequent reorientation to time, place, and person. Validation therapy, later stages. This would be acknowledge the client's feelings. Don't argue with the client. This will lead to the client becoming upset. Reinforce and use repetitive actions or ideas cautiously. Promote self-care as long as possible. Assist the client with activities of daily living as appropriate. Speak directly to the client in short, concise sentences. Reduce agitation. Use calm, redirecting statements. Provide a diversion. Provide a routine toileting schedule. Medications. Most medications for clients who have dementia attempt to target behavioral and emotional problems such as anxiety, agitation, combativeness, and depression. These medications include antipsychotics, antidepressants, and anxiolytics. Clients receiving these medications should be closely monitored for adverse effects. AD medications temporarily slow the course of the disease and do not work for all clients. Pharmacotherapeutics is based on the theory that AD is a result of depleted levels of enzyme acetyltransferase, which is necessary to produce the neurotransmitter acetylcholine. Benefits for those clients who do respond to medication include improvements in cognition, behavior, and function. If a client fails to improve with one medication, a trial of another one or of other medications is warranted. Excuse me. Aricept, which is donepezil hydrochloride. Aricept prevents the breakdown of, of acetylcholine or ACH, which increases the amount of ACH available. This results in increased nerve impulses at the nerve sites. Cholinesterase inhibitors help slow this process down. Nursing considerations. Observe the client for frequent stools and or upset stomach when taking donepezil hydrochloride. Monitor the client for dizziness and or headache. The client may feel lightheaded or have an unsteady gait. Use caution when administering this medication to clients who have asthma or COPD. Interdisciplinary care. Refer the client to social services and case managers for possible adult daycare facilities or long-term care facilities. Refer the client to the Alzheimer's Association and community outreach programs. This can include in-home care or respite care. Therapeutic procedures. Alternative therapy. Estrogen therapy for women may prevent Alzheimer's disease, but it is not useful in decreasing the effects of pre-existing dementia. Ginkgo biloba, an herbal product taken to increase memory and blood circulation, can cause a variety of side effects and medication interactions. If a client is using ginkgo biloba or other nutritional supplements, that information should be shared with the healthcare providers. Care after discharge. Refer to social services and case managers for long-term home management. Alzheimer's Association, community outreach programs, and support groups. Client education. Educate family and caregivers about illness, methods of care, and adaptation of the home environment. Home safety measures to be implemented may include removing scatter rugs, installing installing door locks that cannot be easily opened, and place alarms on doors. Keeping a lock on the water heater and thermostat. Keeping the water temperature tuned down to a safe level. Providing good lighting, especially on stairs. Installing handrails on stairs and marking step edges with colored tape. Placing the mattress on the floor. Removing clutter and clearing hallways for walking. Securing electrical cords to baseboards. Keeping clean supplies in locked cupboards. Installing handrails in the bathroom, at bedside, and in the tub. Placing a shower chair in the tub. Having the client wear a medical information bracelet if living at home with caregiver. Monitoring for improvement in memory and the client's quality of life. Support for caregivers. Determine teaching needs for the client, especially for family members, when the client's cognitive ability is progressively declining. Review the resources available to the family as the client's health declines. Include long-term care options. A wide variety of home care and community resources, such as respite care, may be available to the family in many areas of the country, and these resources may allow the client to remain at home rather than in an institution. Client outcomes. The client will remain free from injury. The client will sleep 5 to 6 hours every night. The client will be able to perform self-care independently with verbal assistance. Application exercises. 1. A nurse is providing teaching to an older adult client who has AD and his wife who cares for him full-time at home. The client is unable to care for himself and needs assistance with taking his medications. The client has been prescribed Aricept. Which of the following statements made by the wife indicate a need for further teaching regarding Aricept? This medication should increase my husband's appetite. This medication should help my husband sleep better. This medication should help my husband's daily function. This medication should increase my husband's energy level. Aricept helps slow the progression of the answer is C. This medication should help my husband's daily function. Aricept helps slow the progression of AD. It can also help improve behavior and daily function. It does not help with the client's appetite, sleep, or energy level. Excuse me. A nurse is making a home visit to a client who has AD. The client is often disoriented to time and place, is unsteady on his feet, and has a history of wandering. His wife is fearful that he will wander outside or injure himself in the home. Which of the following safety measures should the nurse instruct the wife to implement? Select all that apply. Remove floor rugs. Have door locks that can be easily opened. Provide good lighting, especially along the stairs. Install handrails along the stairs in the bathroom. Keep the mattress on the floor. Secure electrical cords to baseboards. All of them except have door locks that can be easily opened. Removing floor rugs can decrease the client's risk of falling. Good lighting can also decrease the risk of falling in dark areas such as stairways. Installing handrails on the stairs and in the bathroom could be useful for the client to hold on to when his gait is unsteady. By securing electrical cords to the baseboards and placing the client's mattress on the floor, the client's risk of falling or tripping is decreased. Easy to open door locks increase the risk for a client who wanders to get out of his home and get lost. A nurse is caring for a client who has AD and keeps falling. Which of the following actions should the nurse take first to keep the client safe? A. Keep the call light close to the client. B. Place the client in a room close to the nurse's station. C. Encourage the client to ask for help when he needs assistance. D. Remind the client to wait for assistance when he gets up unattended. Answer is B. Moving the client's room close to the nurse's station provides constant supervision by the nurse and staff to keep the client safe. Keeping the call light close to the client, encouraging the client to ask for help, and reminding the client to wait for assistance when he gets up are all part of the nursing process, but not first priorities. The client may not always remember to use the call light and ask for help when needed. And that's Alzheimer's. Next, we're going to do CVA. Okay, rolling right along to nursing care for clients with neurosensory disorders having to do with cerebral vascular accidents. Overview. Cerebral vascular accidents, or CVAs, or strokes, involve a disruption in the cerebral blood flow secondary to ischemia, hemorrhage, or embolism. There are three causes of CVAs. Hemorrhagic. These occur secondary to a ruptured artery or aneurysm. The prognosis for a client who has experienced a hemorrhagic CVA is poor due to the amount of ischemia and increased intracranial blood pressure or intracranial pressure caused by the expanding collection of blood. A CVA, if caught early, and evacuation of the clot can be done with cessation of the active bleed, the prognosis of a hemorrhagic CVA improves significantly. Thrombotic. These occur secondary to the development of a blood clot on an atherosclerotic plaque in a cerebral artery that gradually shuts off the artery and causes ischemia distal to the occlusion. Symptoms of a thrombotic CVA evolve over a period of several hours to days. And then there is the embolic. These occur secondary to an embolus, traveling from another part of the body to a cerebral artery. Blood to the brain, distal to the occlusion, is immediately shut off, causing neurologic deficits or a loss of consciousness to instantly occur. An embolic CVA is very sensitive because many can be reversed if anti-embolic medications such as TPA are administered within 4 to 6 hours of the initial symptoms. So that's hemorrhagic stroke, thrombotic stroke, and embolic stroke. Hemorrhagic is a ruptured artery or aneurysm. Thrombotic is a development of from a blood clot, thrombus. And embolic is an embolus traveling from another part of the body to a cerebral artery. Okay. Health promotion. Health promotion and disease prevention. Hypertension, diabetes mellitus, smoking, and other related disorders can increase clients' risk of a CVA. Early treatment of hypertension, maintenance of blood glucose within expected range, and refraining from smoking will decrease these risk factors. Maintaining a healthy weight and getting regular exercise can also decrease the risk of a CVA. Assessment. Risk factors. Cerebral aneurysm, arteriovenous malformation, or AV, diabetes mellitus, obesity, hypertension, atherosclerosis, hyperlipidemia, hypercoagulability, AFib, use of oral contraceptives, smoking, cocaine use. Subjective data. Some clients report transient symptoms such as dizziness, slurred speech, and a weak extremity. These symptoms may indicate a transient ischemic attack, or TIA, which can be a warning of an impending CVA. Antithrombotic medication and/or surgical removal of atherosclerotic plaques in the carotid artery can prevent the subsequent occurrence of a CVA. Objective data. Physical assessment findings. Symptoms will vary based on the area of the brain that is deprived of oxygenated blood. The left cerebral hemisphere is responsible for language, mathematics skills, and analytic thinking. Symptoms consistent with a left hemispheric CVA include expressive and receptive aphasia, ability to speak and understand language respectively. So expressive would be speak, and understand would be receptive aphasia. Okay, or wait, ability to speak would be expressive, yeah, and understand is receptive. Agnosia, or unable to recognize familiar objects. Alexia, reading difficulty. Agraphia, writing difficulty. Right extremity hemiplegia, paralysis, or hemiparesis, weakness. Slow, cautious behavior. Depression, anger, and quick to become frustrated. Visual changes, such as hemianopsia, which is loss of visual field in one or both eyes. The right cerebral hemisphere is responsible for visual and spatial awareness and proprioception. Altered perception of deficits, overestimation of abilities. Okay, so this is right cerebral hemisphere. Responsible for visual and spatial awareness and proprioception. Altered perception of deficits or overestimation of abilities. One-sided neglect syndrome, ignore left side of body, cannot see, feel, or move affected side, so client unaware of its existence, can occur with left hemispheric CVAs, but is more common with right hemispheric CVAs. Loss of depth perception, poor impulse control and judgment, left hemiplegia or hemiparesis, and visual changes such as hemianopsia. Diagnostic procedures: a magnetic resonance imaging or MRI, CT, and a CAT scan may be useful to identify edema, ischemia, and necrosis. A magnetic or MRA, which is a magnetic resonance angiography, or a cerebral angiography, are used to identify the presence of a cerebral hemorrhage, abnormal vessel structures, like an AV malformation or aneurysms, vessel ruptures, and regional perfusion of blood flow in the carotid arteries and brain. A lumbar puncture is used to assess the presence of blood in the cerebrospinal fluid, CSF. A positive finding is consistent with a cerebral hemorrhage or ruptured aneurysm. The Glasgow Coma Scale score is used when the client has a decreased level of consciousness or orientation. The risk for increased intracranial pressure, or ICP, exists related to the swelling of the brain that can occur secondary to ischemic insult. Collaborative care, nursing care. Monitor for changes in the client's level of consciousness, increased intracranial pressure sign. Elevate the client's head of the bed approximately 30 degrees to reduce ICP and to promote venous drainage. Avoid extreme flexion or extension of the neck and maintain the client's head in the midline neutral position. Institute seizure precautions. Assist with the client's communication skills if his speech is impaired. Assess the ability to understand speech by asking the client to follow simple commands. Observe for consistency affirmative answers. Observe for consistently affirmative answers when the client actually does not comprehend what is being said. Assess accuracy of yes/no responses in relation to close-ended questions. Supply the client with a picture board of commonly requested items, needs. Assist with safe feeding. Assess swallowing and gag reflexes before feeding. Speech therapy may be requested to do This during a swallowing study that can involve swallowing a barium substrate and radiography of the peristaltic activity of the esophagus. If a swallowing deficit is identified, the client's liquids may need to be thickened with a commercial thickener to avoid aspiration. Have the client eat in an upright position and swallow with the head and neck flexed slightly forward. Place food in the back of the mouth on the unaffected side. Have suction on standby. Maintain a distraction-free environment during meals. Maintain skin integrity. Reposition the client frequently and use padding. Monitor bony prominences. Pay particular attention to the affected extremities. If the client has one-sided neglect, teach him to protect and care for the affected extremity to avoid injuring it in the wheel of the wheelchair or smashing it against the doorway. Encourage passive range of motion every 2 hours to the affected extremities and active range of motion every 2 hours to the unaffected extremities. Teach the client how to use the unaffected side to exercise the affected side of the body. Elevate the affected extremities to promote venous return and reduce swelling. An elastic glove can be placed on the affected hand if swelling is severe. Teach the client to massage the affected hand by stroking it in a distal or to proximal manner, encouraging fluid in the hand to move back into the wrist and arm. Okay, maintain a safe environment to reduce the risk of falls. Assistive devices should be used during transfers, such as transfer belts and sliding boards. Sit-to-stand lifts can also facilitate transfers and reduce strain on the care provider's body. If the client has homonymous hemianopsia, loss of the same visual field in both eyes, instruct him to use a scanning technique. Turn head from the direction of the unaffected side to the affected side when eating and ambulating. To prevent deep vein thrombosis, or DVT, from developing, provide preventative measures such as sequential compression stockings, frequent position changes, and mobilization. Provide assistance with ADLs as needed. Instruct the client to dress the affected side first and sit in a supportive chair that aids in balance. Have occupational therapy assess the client for adaptive aids, such as a plate guard, utensils with built-up handles, a reaching tool to pick things up, and shirts and shoes that have hook and loop fastener/tape instead of buttons and ties. Prevent complications of immobility. While clients who have experienced CVAs are ambulated as soon as possible to prevent complications during periods of inactivity, preventative measures related to complications of immobility should be implemented. Clients who have experienced CVAs have decreased endurance and impaired balance due to paralysis on one side of the body. Frequent rest periods from sitting in their wheelchair should be provided by returning the client to bed after therapies and meals. When sitting the client up in bed or in the wheelchair leaning to the affected side typically occurs and should be countered with some manner of support. Shoulder subluxation can occur if the affected arm is not supported. The weight of the arm is such that it can actually cause a painful dislocation of the shoulder from its socket. Supporting the arm while in bed, the wheelchair, or during ambulation should be accomplished with an arm sling or strategically placed pillows. Support the client during periods of emotional lability and depression. Medications. Anticoagulants, aspirin, heparin, sodium, Lovenox, warfarin, or Coumadin. These medications are usually given to clients who have experienced an embolic CVA to prevent development of additional emboli. Antiplatelets, like Diclid or Plavix, these medications are usually given for clients who have experienced a thrombotic or CVA to prevent extension of the CVA. Thrombolytic medications, Activase or TPA, can be given within 3 hours of onset of symptoms to dissolve embolism. Anti-epileptic medications, phenytoin or Dilantin or gabapentin or Neurontin. These medications are not commonly given following a CVA unless the client develops seizures. Gabapentin can be given for paresthetic pain in an affected extremity. Interdisciplinary care. Speech and language therapists can be consulted for language therapy and swallowing exercises. Physical therapy can be consulted for assistance with reestablishment of ambulation, with or without assistive devices, single or quad cane, walker, or wheelchair support. Wheelchair adaptations, such as an extended brake handle on the client's affected side of the wheelchair, may be necessary. Safety features, such as placing the brakes on when preparing to transfer and the use of a cushion on the seat, may also be integrated by physical therapy into the client's plan of care. Occupational therapy can be consulted for assistance with reestablishment of partial or full function of the affected hand and arm. If function does not return to the extremity, measures such as massage and elastic gloves will be prescribed by the occupational therapy to prevent swelling of the extremity. Social services can be consulted to make arrangements for rehabilitation services and temporary placement on a skilled rehabilitation unit or extended care facility during provision of these services. Prior to discharge, the social worker may make a home visit with selected therapists and nurses to evaluate the need for environmental alterations in the home and adaptive equipment needed for ADLs. Therapeutic procedures. Systemic or catheter-directed thrombolytic therapy restores cerebral blood flow. It must be administered within 3 hours of the onset of symptoms. It is contraindicated for treatment of a hemorrhagic CVA and for clients with an increased risk of bleeding due to anticoagulant therapy or other bleeding anomaly. Possibility of a hemorrhagic CVA is ruled out with an MRI prior to the initiation of thrombolytic therapy. Surgical interventions. Carotid endarterectomy is performed to open the artery by removing atherosclerotic plaque. This procedure is performed when the carotid artery is blocked or when the client is experiencing TIAs. Client outcomes. The client's transient neurological deficits will cease and he will not experience a CVA. The client will use adaptive devices to compensate for neurological deficits. Complications. Dysphagia and aspiration. Dysphagia can result from neurological involvement of the cranial nerves that innervate the face, tongue, soft palate, and throat. As a result, the client's risk of aspiration is great. Not all clients who have experienced a CVA have dysphagia, but all should be evaluated prior to reestablishing oral nutrition and hydration. Nursing actions. Assess the client's gag reflex. If the gag reflex is present, give the client a small sip of water to determine if choking occurs. If the client exhibits some difficulty managing food or fluids, a swallowing evaluation should be done by a speech therapist. Begin the client with a prescribed diet and observe closely for choking. Have the suction equipment available. Initial feeding should be done by an RN, so appropriate interventions can be taken if choking occurs. Thicker liquids are usually tolerated better than thin liquids. Therefore, a thickener may need to be added to oral fluids. Use the appropriate amount of thickener to obtain the prescribed consistency. Client education. Teach the client's family how to thicken liquids to the proper consistency. Instruct the client to flex his head forward when swallowing to decrease the risk of choking. Unilateral neglect. Unilateral neglect is the loss of awareness of the side affected by the CVA. The client cannot see, feel, or move the affected side of his body, therefore he forgets that it exists. This lack of awareness poses a great risk for injury to the neglected extremities and creates a self-care deficit. Nursing actions. Observe the client's affected extremities for injury, bruises and abrasions of the affected hand and arm, hyperflexion of the foot from it falling off of the wheelchair during transport. Apply an arm sling if the client is unable to remember to care for the affected extremity. Ensure the footrest is on the wheelchair and an ankle brace is on the affected foot. Client education. Instruct the client to dress the affected side first. Teach the client how to care for the affected side. Use the unaffected hand to pull the affected extremity to midline and out of danger from the wheel of the wheelchair or from hitting or smashing it against the doorway. Teach the client to scan the affected side. All right, application exercises. Yay. Scenario: an older adult female client is brought to the emergency department after she fell from her chair during breakfast. The client has a Glasgow Coma Scale score of 5, and her blood pressure is 150/96. Respirations are 16, pulse is 56, and a temperature of 38.3. Her admitting medical diagnosis is a suspected CVA. A CT scan is scheduled for the client. 1. Based on CT results, the client is diagnosed with right hemisphere CVA or of embolic origin. Which of the following neurological deficits should the nurse expect to find? Select all to apply. 1. Aphasia, or receptive or expressive. Right hemiplegia or hemiparesis. Lack of awareness of deficits. Impulse control difficulty. Slow, cautious behavior. Left hemiplegia or left hemiparesis. Answers are lack of awareness of deficits, impulse control difficulty, and left hemiplegia or hemiparesis. A client who has experienced a right hemispheric CVA will experience left-sided hemiplegia or hemiparesis along with impulsive behavior and a lack of awareness of deficits. This client poses a safety problem as she may impulsively respond to the urge to use the restroom or get a drink of water from across the room without assistance and fall. This is because she does not recognize her neurological deficits. Aphasia, right hemiplegia or hemiparesis, and slow, cautious behavior is seen in clients who have had a left hemispheric CVA. 2. The client is diagnosed with left homonymous hemianopsia. Which of the following actions is appropriate for the nurse to include in the client's plan of care? A. Teach the client to scan to the right to see objects on the right side of her body. B. Place the client's bedside table on the right side of the bed. C. Orient the client to the food on her plate using the clock method. D. Place the client's wheelchair on her left side. Answer is B. Place the client's bedside table on the right side of the bed. A client who has left homonymous hemianopsia has lost the left visual field of both eyes. She is unable to visualize anything to the left of midline of her body. Placing the client's bedside table on the right side of her bed will allow her to easily visualize items on the table. Scanning to the right will decrease the client's field of vision. The clock method of food placement will be ineffective since only half of the plate can be seen. And a wheelchair should be placed on the right or unaffected side of the client. Okay? When the client resumes dietary intake, which of the following actions should the nurse take? Select all that apply. Have the suction equipment available for use. Thicken liquids using a commercial thickener. Place food on the client's unaffected side of her mouth. Assign an assistive personnel to slowly feed the client. Teach the client to swallow with her neck flexed. Discontinue feeding the client if choking occurs. And the answers are: have the suction equipment available for use. Thicken liquids using a commercial thickener. Place food on the client's unaffected side of her mouth. And discontinue feeding the client if choking occurs. Rationale is the nurse caring for this client should have suction equipment available in case the client begins to choke. Client should be given thickened liquids, which are easier to swallow. Placing food on the unaffected side of the client's mouth will allow her to have better control of the food, and again, reduce the risk of aspiration. Due to the risk of aspiration, an assistive personnel should not be assigned to the client because the client's swallowing ability needs to be assessed, and suctioning may be needed if choking occurs. The client should also be taught to flex her neck. Tucking the chin down and under to close the epiglottis during swallowing. If choking during feedings occurs, the client should be made NPO and the provider should be notified. Four, a nurse has been assigned a client who is diagnosed with global aphasia, both receptive and expressive. Which of the following interventions are appropriate to include in the client's plan of care? Speak to the client at a slower rate. Look directly at the client when speaking. Allow plenty of time for the client to answer. Complete sentences that the client cannot finish. Give instructions one step at a time. Speak louder if the client does not understand. And speak to the client at slow rate. Look directly at the client when speaking. Allow plenty of time for the client to answer. And give instructions one step at a time. Clients who have global aphasia will have difficulty with both speaking and understanding speech. Strategies that can enhance understanding are speaking at a slower rate, looking at the client when speaking, giving instructions one step at a time, and allowing the client time to answer questions without trying to answer for him. Speaking louder to a client with receptive aphasia who does not have a hearing deficit will not enhance his understanding. Okay, Unit 5, Endocrine. I'm just going to go over diabetic stuff. Unit 5, almost halfway through. Woohoo! Wow. 3 hours in. Okay, Chapter 96 of MedSurg ATI. Nursing care of clients with endocrine disorders. Chapter 96, Overview. Diabetes mellitus is characterized by chronic hyperglycemia due to inadequate insulin secretion and or the effectiveness of endogenous insulin or insulin resistance. Diabetes mellitus is a contributing factor to development of cardiovascular disease, hypertension, renal failure, blindness, and stroke as individuals age. Health promotion and disease prevention. Diabetic screening. Test urine for glucose and ketones during routine examinations to evaluate the need for further testing. Client education. Teach the client that exercise and good nutrition are necessary for controlling diabetes. Teach the client how to monitor blood glucose levels as prescribed. Teach the client with diabetes that foot care and skin care are priorities. Assessment. Risk factors. Genetics may predispose an individual to the occurrence of type 1 or type 2 diabetes. Toxins and viruses can predispose an individual to diabetes by destroying the beta cells, leading to type 1 diabetes mellitus. Obesity. Physical inactivity, high triglycerides greater than 250 mgs, and hypertension may lead to the development of insulin resistance and type 2 diabetes. Secondary causes of diabetes include pancreatitis and Cushing's syndrome. Because of the deterioration of the function of all organs, the older adult clients are at risk for kidney and liver dysfunction, leading to altered urinary output and altered metabolism of medications, vision alterations, yellowing of lens, decreased ability of depth perception, cataracts, as well as eye changes that may be related to diabetic retinopathy. Vision and hearing deficits may interfere with the understanding of teaching, reading of materials, and preparation of medications. Tissue deterioration secondary to aging may impact the client's ability to prepare food, care for self, perform ADLs, and perform foot wound care and perform glucose monitoring. A fixed income may mean that there are limited funds for buying diabetic supplies, wound care supplies, insulin, and medications. This may result in complications. Older adult clients may not be able to drive to the healthcare provider's office, grocery store, or pharmacy. Assess support systems available for older adult clients. Subjective and objective data. Blood glucose. I'm going to read this chart. Autonomic nervous system responses, rapid onset. Would be hunger, lightheadedness, and shakiness. Nausea, anxiety and irritability, pale, cool skin, diaphoresis, irritability, normal or shallow respirations, and tachycardia and palpitations. Impaired cerebral function, a gradual onset, would be strange or unusual feelings, decreased level of consciousness, difficulty in thinking and ability to concentrate, change in emotional behavior, slurred speech, headache and blurred vision, seizures leading to coma. So, okay, the subjective and objective data. Blood glucose would be hyperglycemia, blood glucose level usually greater than 250 mgs, thirst, frequent urination, hunger, skin that is warm, dry, and flushed with poor turgor, dry mucous membranes, and soft eyeballs. Weakness, malaise, rapid, weak pulse, and hypotension. Rapid, deep respirations, be called small respirations, with acetone or fruity odor due to ketones. Laboratory tests. Diagnostic criteria for diabetes include two findings on separate days of one of the following. Symptoms of diabetes plus casual plasma glucose concentration of greater than 200 mgs without regard to time since last meal. It's the casual. Fasting blood glucose greater than 120 mgs and a 2-hour glucose greater than 200 mgs with an oral glucose tolerance test. Fasting glucose, nursing actions, postpone administration of anti-diabetic medication until after the level is drawn. Client education, ensure that the client has fasted no food or drink other than water for the 8-hour period to the blood draw. Oral glucose tolerance is a fasting blood glucose level is drawn at the start of the test. The client is then instructed to consume a specific amount of glucose. Blood glucose levels are drawn every 30 minutes for 2 hours. The client must be assessed for hypoglycemia throughout the procedure. Client education. Instruct the client to consume a balanced diet for 3 days prior to the test. Then instruct the client to fast for 10 to 12 hours prior to the test. That's the fasting. Okay, glycosylated hemoglobin, or AC1 or A1C. The normal reference range is 4% to 6%, but an acceptable target for clients who have diabetes may be 6.5 to 8%, with a target goal of less than 7%. The HbA1c is the best indicator of the average blood glucose level for the past 120 days. Assists in evaluating treatment effectiveness and compliance. Diagnostic procedures. Self-monitored blood glucose, or SMBG. Nursing action. Follow or ensure that the client follows the proper procedure for blood sample collection and use of a glucose meter. Supplemental short-acting insulin may be prescribed for elevated pre-meal glucose levels. Client education. Instruct the client to check the accuracy of the strips with the control solution provided. Advise the client to keep a record of the SMBG that includes time, date, serum glucose level, insulin dose, food intake, and other events that may alter glucose metabolism, such as activity level or illness. Collaborative care, nursing care, monitor blood glucose levels and factors affecting levels, other medications, in and outs and weight, skin integrity and healing status of any wounds. Feet and folds of skin should be monitored closely. Sensory alterations, tingling, numbness, visual alterations, presence of recurrent infections, dietary practices, exercise patterns, the client's self-monitoring blood glucose skill proficiency, the client's self-medication administration proficiency. Teach the client proper foot care. Inspect feet daily. Wash feet daily with mild soap and warm water. Pat feet dry gently, especially between the toes. Use mild foot powder with cornstarch on sweaty feet. Do not use commercial remedies for the removal of calluses or corns. Consult a podiatrist. The best time to perform nail care is after a bath or shower. Separate overlapping toes with cotton or lamb's wool. Avoid open-toe, open-heel shoes. Leather shoes are preferred to plastic ones. Wear shoes that fit correctly. Wear slippers with soles. Do not go barefoot. Shake out shoes before putting them on. Wear clean, absorbent socks or stockings that are made of cotton or wool and have not been mended. Do not use hot water bottles or heating pads to warm feet. Wear socks for warmth. Avoid prolonged sitting, standing, and crossing of legs. Teach the client to follow agency policies for nail care. Some protocols allow for trimming toenails straight across with clippers and filing edges with an emery board or nail file. If clippers or scissors are contraindicated, the client should file the nails straight across. Teach the client to cleanse cuts with warm water and mild soap. Gently dry and apply a dry dressing. Instruct the client to monitor healing and seek intervention promptly. Provide nutritional guidelines. Plan meals to achieve appropriate timing of food intake. Activity, onset, and peak of insulin. Calories and food compensation should be similar each day. Eat regular intervals and do not skip meals. Count grams of carbohydrates consumed. Recognize that 15 grams of carbohydrates are equal to 1 carbohydrate exchange. Restrict calories and increase physical activity as appropriate to facilitate weight loss for clients who are obese or to prevent obesity. Include fiber in the diet to increase carbohydrate metabolism and help control cholesterol levels. Use artificial sweeteners. Keep fat content below 30% of the total caloric intake. Okay, teach the client appropriate techniques for SMBG, including obtaining blood samples, recording and responding to results, and correctly handling supplies and equipment. Teach the client guidelines to follow when sick. Monitor blood glucose every 3 to 4 hours. Continue to take insulin or oral anti-diabetic agents, and consume 4 ounces of sugar-free, non-caffeinated liquid every half hour to prevent dehydration. Meet carbohydrate needs through soft food if possible. If not, consume liquids equal to usual carbohydrate content. Test urine for ketones and report to provider if they are abnormal. The level should be negative to small. Rest. Okay. Call the healthcare provider if blood glucose is greater than 240 milligrams, fever is greater than 102 or 38.9 Celsius, does not respond to acetaminophen or lasts more than 12 hours. Feeling disoriented or confused, also call a healthcare provider if you're experiencing rapid breathing, vomiting occurs more than once, diarrhea occurs more than 5 times or for longer than 24 hours, you're unable to tolerate liquids, and illness lasts longer than 2 days. Advise the client to eat at regular intervals, avoid alcohol intake, and adjust insulin to exercise and diet to avoid hypoglycemia. Teach the client measures to take in response to signs and symptoms of hypoglycemia: shakiness, diaphoresis, anxiety, nervousness, chills, nausea, headache, weakness, confusion. Check blood glucose level. Follow guidelines outlined by the healthcare provider/diabetes educator. Guidelines may include treat with 15 to 20 grams of carbohydrates. Example, 4 ounces of orange juice, 2 ounces of grape juice, and 8 ounces of milk. Glucose tablets per manufacturer's suggestion is equal to 15 grams. Recheck blood glucose in 15 minutes. If still low, less than 70 mgs, give 15 to 20 grams more of carbohydrates. Recheck blood glucose in 15 minutes. If blood glucose is within normal limits, take 7 grams protein if the next meal is more than an hour away. Example, 1 ounce of cheese, 1 string cheese, or 2 tablespoons of peanut butter, or 8 ounces of milk. If the client is unconscious or unable to swallow, administer glucagon subcutaneous or IM. Repeat in 10 minutes if still unconscious, and notify the healthcare provider. Teach the client signs and symptoms of hyperglycemia, hot, dry skin, and fruity breath, and measures to take in response to hyperglycemia. Encourage oral fluid intake, administer insulin as prescribed, restrict exercise when blood glucose levels are greater than 250 milligrams, test urine for ketones and report if abnormal, consult the provider if symptoms progress. Encourage the client to wear a medical identification wristband. Medications. Clients who have type 1 diabetes are on an insulin regimen that frequently consists of more than one type of insulin, i.e. rapid, short, intermediate, and long-acting. Insulin given in this manner is administered 1 or more times per day and based on a client's blood glucose level. Some clients who have type 2 diabetes or women who have gestational diabetes may require insulin if glycemic control is unable to be obtained with diet, exercise, and oral hypoglycemics. Some clients are placed on an insulin pump, which is a small pump that is worn externally, contains insulin, and delivers insulin as programmed via a needle inserted into the subcutaneous tissue. The needle should be changed at least every 3 days. Clients who have type 2 diabetes can usually regulate their blood glucose with diet and exercise with the addition of oral hypoglycemics as needed. Rapid acting we have Humalog, Novolog, onset less than 15 minutes, peak half hour to an hour, duration 3 to 4 hours. Short acting Humulin R, half hour to an hour, onset, peak 2 to 3 hours, duration 5 to 7 hours. Intermediate acting NPH, that's 1 to 2 hours onset, 4 to 12 hour peak, and 18 to 24 hour duration. Then long-acting Glargine or Lantus is 1 hour. Onset, there's no peak in 10.5 to 24-hour duration. Nursing considerations. Observe the client perform self-administration of insulin and offer additional instructions as indicated. Do not mix insulin, Glargine, Lantus with other insulins due to incompatibility. Provide information regarding oral anti-diabetic medication. Administer as prescribed, for example, 30 minutes before first main meal and most oral blood glucose lowering agents, or with the first bite of each main meal for alpha-glucosidase inhibitors. Avoid alcohol with sulfonylurea agents because of the sulfa allergy, right? Yeah, the sulfium-like reaction. Monitor renal function. That's for biguanides. And monitor liver function. That's for thiazolidinediones and alpha-glucosidase inhibitors. Advise women of childbearing age taking thiolizadenolines that additional contraception methods may be needed since these medications reduce the blood levels of some oral contraceptives. Client education. Provide information regarding self-administration of insulin. Rotate injection sites. This prevents lipohypertrophy within one anatomic site. So rotate injection sites within one anatomic site. Prevent day-to-day changes in absorption rates. Inject at a 90% or 90-degree angle, 45 angle if you're thin. Aspiration for blood is not necessary. When mixing a rapid or short-acting insulin with a long-acting insulin, draw up the shorter-acting insulin into the syringe first, and then the longer-acting insulin. This reduces the risk of introducing the longer-acting insulin into the shorter-acting insulin vial. Oh, that's why. Oral hypoglycemics. Biguanides, metformin, HCl, or glucophage reduces the production of glucose through suppression of gluconeogenesis. Eats them. Nursing consideration. Monitor significance of GI effects, anorexia, nausea, vomiting. Monitor for lactic acidosis, especially in client with renal insufficiency or liver dysfunction. Client education. Instruct the client to take vitamin B12 and folic acid supplements. Instruct the client to contact the provider if signs of lactic acidosis, like myalgia, sluggishness, somnolence, hyperventilation, are experienced. Instruct the client that this medication may be taken during pregnancy for gestational diabetes. That's metformin. Sulfonylureas. Some names for that be orinase, diabinase, or glyburide, diabeta, micronase. Looks like they end in mide or ide. I don't know that all of them for sure, but all of these do. Tobutamide, chlorpropamide, and glyburide. This stimulates insulin release from the pancreas. Nursing considerations. Monitor for hypoglycemia. Beta blockers can mask tachycardia, typically seen during hypoglycemia. Adjust teaching regarding symptoms of hypoglycemia accordingly. Client education. Instruct the client to avoid using during pregnancy. Instruct the client to avoid alcohol due to disulfiram effect. Meglitinides, Prandin, Starlix. This stimulates insulin release from the pancreas. Nursing considerations. Monitor for hypoglycemia. Do not administer with gemfibrozole or Lopid. Client education. Wear a medical identification wristband due to the risk of hypoglycemia. Thiazolidindoins, or rosiglitazone, or Avandia, and pioglitazone, or Actos. Avandia and Actos are the thiazolidinoids. And this increases the cellular response to insulin by decreasing insulin resistance. Nursing considerations. Monitor for fluid retention, especially in clients with a history of heart failure. Monitor the client's LDL and triglycerides for elevation. Client education. Instruct the client to have serum alanin aminotransferase, or ALT, checked every 6 months after baseline. Alpha-glucosidase inhibitors, Precos or Glycet. This slows carbohydrate absorption and digestion. Nursing considerations. Alert the client of GI discomfort common with these medications: abdominal distension, cramps, excessive gas, diarrhea. Monitor for iron deficiency, anemia, hemoglobin, and iron levels. Client education. Instruct the client to have liver function tests performed every 3 months or as prescribed. Report jaundice immediately. And that's with alpha-glucosidase inhibitors. Gliptins, or that's sitagliptin or Januvia. This augments naturally occurring incretin hormones which promote release of insulin and decrease secretion of glucagon. Nursing considerations. These medications have very few side effects, but upper respiratory symptoms, nasal and throat inflammation may be present. Client education. Instruct the client to report persistent upper respiratory symptoms. Interdisciplinary care. Refer the client to a diabetes educator for comprehensive education in diabetes management. Client outcomes. The client will have blood glucose levels within an acceptable range. The client will be able to self-administer insulin. The client will be able to monitor for complications and intervene as necessary. Complications. Consistent maintenance of blood glucose levels within the normal reference range is the best protection against the complications of diabetes mellitus. Normal reference ranges may vary and will usually range from 70 to 120 mg. Cardiovascular and cerebrovascular disease. Hypertension, myocardial infarction, and stroke. Nursing actions. Monitor blood pressure. Client education. Encourage checks of cholesterol, HDL, LDL, and triglycerides yearly, and monitoring of blood pressure and HbA1c levels every 3 months. Encourage participation in regular activity. Encourage a diet of low-fat meals that is high in fruits, vegetables, and whole grain foods. Teach the client to report shortness of breath, headaches, persistent and transient, numbness in distal extremities, swelling of feet, infrequent urination, and changes in vision. Encourage a dietary consultant. Impaired vision and blindness caused by diabetic retinopathy. Client education. Encourage yearly eye exams to ensure the health of the eyes and to protect vision. Encourage management of blood glucose levels. Foot injury caused by sensory neuropathy, ischemia, and infection. Nursing actions. Monitor blood glucose levels. Provide foot care. Client education. Encourage annual exams by a podiatrist. Instruct the client to examine feet daily. Provide foot care instructions. Renal failure. Damage to the kidneys from prolonged elevated blood glucose levels and dehydration. Nursing actions. Monitor hydration and renal function. INO. Creatinine levels. Report an hourly output of less than 30 mils an hour. Monitor blood pressure. Client education. Encourage yearly urine analysis, bun, and creatinine clearance. Encourage the client to avoid soda, alcohol, and toxic levels of acetaminophen. Teach the client to consume 2 to 3 liters of fluid per day from food and beverage sources and to drink an adequate amount of water. Tell the client to report decrease in output to the provider. Application exercises. A nurse is caring for a client whose blood glucose is 49 mgs. The client is lethargic but arousable. Which of the following is the priority nursing action? A. Recheck blood glucose in 15 minutes. B. Give 7 grams of protein. C. Give 15 to 20 grams of carbs. Or D. Report finding to the client's healthcare provider. It's C. Give 15 to 20 grams of carbohydrates. The greatest risk to the client is a lack of glucose for cell metabolism. Therefore, the priority action is to give 15 to 20 grams of carbohydrates to raise the client's serum blood glucose. Level. Next, the client's blood glucose should be checked in 15 minutes. If the blood glucose remains below 70 mgs, give 15 grams more of carbohydrates. If the client's blood glucose should be rechecked in 15 minutes, this would be repeated until the client's blood glucose is above 70 mgs. Then 7 grams of protein should be given. Findings should be reported to the client's healthcare provider and actions should be documented. 2. A client's medication record reads Lispro insulin 10 units subcutaneously 0800. Which of the following actions should the nurse take when administering this medication? Check the client's blood glucose immediately after administration. Administer the medication when the breakfast tray arrives. Administer the medication within 30 minutes of the scheduled time. Clarify the prescription because the medication is usually given at bedtime. Answer is B. Administer the medication when the breakfast tray arrives. Insulin Lispro or Humalog is a rapid-acting insulin with an onset of less than 15 minutes. Administering the insulin at the time of the breakfast tray arrives will ensure adequate blood glucose at the time of peak action. The client's blood glucose levels should be checked prior to insulin administration to prevent an episode of hypoglycemia. This medication is given prior to meals and may be given 2 to 3 times a day. 3. A client's blood glucose level is 257 mgs at 8 o'clock, and the healthcare provider's prescription for sliding scale insulin for this blood glucose result is 6 units of regular insulin, Humulin R, subcutaneously. This client also receives 12 units of insulin glargine or Lantus subcutaneously every morning. Which of the following methods should the nurse use to draw up and administer the insulin? A. In one insulin syringe, draw up 6 units of regular insulin. In a separate insulin syringe, draw up 12 units of insulin glargine and give 2 separate injections. B. Drop the regular insulin first, then drop the insulin glargine in the same syringe. Administer 1 injection that contains blah blah blah. I'm not going to really, you don't mix Lantus. It's A. In one insulin syringe, draw up 6 units of regular insulin. In separate insulin, draw up 12 units of insulin glargine and give 2 separate injections. The insulin should be drawn in 2 separate syringes and given as 2 separate SC injections. Insulin, glargine, and regular insulin are not compatible and cannot be given in the same syringe. Even though it didn't cover that anywhere in that last chapter, but we knew that. We knew that already. Don't mix Lantus. An adult client who has type 1 diabetes mellitus is admitted to the hospital for circulatory impairment to the lower extremity and an open draining wound on the right foot. The client manages her own blood glucose monitoring and insulin injections at home. Her instructions include blood glucose monitoring before meals and at bedtime. At 8 o'clock, it is 8 o'clock. In what order should the nurse perform the following interventions? I'll just read them off. 1. First, you take vitals. 2. You perform a finger stick for blood glucose monitoring. 3. Administer the morning insulin injection. 4. Complete the morning assessment. 5. Assist with the breakfast tray. 6. Perform morning care and grooming. 7. Teach client about complications of diabetes and circulation. Okay. The nurse should obtain the client's vital signs, then check the client's blood glucose level. Insulin should be given approximately 30 minutes prior to a meal, so it should be given after the blood glucose level is drawn. The nurse should then complete the morning assessment, assist with the breakfast tray, and complete morning care and grooming. Education about the complications of diabetes mellitus should be performed when the nurse has adequate time and the client is not tired or distracted by other activities. Okay, well, that contraindicates what it said earlier too, because it said you were supposed to give insulin with the tray, but whatever. Uh-oh. Okay. Post. Okay. Complications of diabetes mellitus, Chapter 97. This is a short one. Okay. Chapter 97, Complications of Diabetes mellitus. Diabetes ketoacidosis, or DKA, is an acute life-threatening condition characterized by hyperglycemia, greater than 300 mgs, resulting in the breakdown of body fat for energy and an accumulation of ketones in the blood and urine. The onset is rapid, and the mortality rate of DKA is 1% to 10%. Hyperglycemia, or hyperglycemic hypersimolar state, or HHS, is an acute life-threatening condition characterized by profound hyperglycemia, greater than 600 mg, dehydration, and an absence of ketosis. The onset generally occurs over several days, and the mortality rate of HHS is up to 15% or more. Risk factors. DKA is more common in clients with type 1 diabetes mellitus. HHS is more common in older adult clients and in clients with untreated or undiagnosed type 2 diabetes. Physiological changes in cardiac and pulmonary function may place older adult clients at greater risk for fluid overload, precipitate heart failure exacerbation from fluid replacement therapy. Any condition that increases carbohydrate metabolism, such as stress, illness, infection, surgery, or trauma that requires an increased need for insulin, or that produces a lack of sufficient insulin, such as new onset of diabetes mellitus or non-adherence to a diabetic regimen. Subjective data: nausea, vomiting, and or abdominal pain for DKA metabolic acidosis. Reports of frequent urination, thirst, and hunger. Reports of confusion. Objective data: physical assessment findings. Polyuria, polydipsia, and polyphagia are early signs. Change in mental status, signs of dehydration, dry mucous membrane, weight loss, sunken eyeballs resulting from fluid loss such as polyuria, small respirations pattern, rapid and deep respirations, fruity breath, DKA, metabolic acidosis, generalized seizure and reversible paralysis, HHS. Okay, laboratory tests. Therapeutic management is guided by serial laboratory analysis. Diagnostic procedure: serum glucose levels, serum electrolytes, sodium and potassium, DKA, sodium and potassium greater than 300 megs. That would be sodium increased due to water loss, potassium initially low due to diuresis, which may increase due to acidosis. HHS, the glucose level for HHS is over 600, DKA is over 300.
Sodium for HHS is increased due to water loss. Potassium initially low due to diuresis. Okay, and serum renal studies. Bun creatinine. So it's going to be increased secondary to dehydration for DKA, and same for HHS, increased secondary to dehydration. Your bun and creatinine will be increased. DKA ketones are going to be present in serum and urine. In HHS, they're going to be absent in serum and urine. Ketones. Serum osmolarity, serum pH, or arterial blood gases. So DKA is going to be metabolic acidosis with respiratory compensation, or Kussmaul respirations. And HHS is going to be absence of acidosis. So, collaborative care, nursing care, always treat the underlying cause, infectious process. Provide rapid isotonic fluid, 0.9% sodium chloride, replacement to maintain perfusion to vital organs. Monitor the client for evidence of fluid volume excess due to the need for large quantities of fluid. Follow with a hypotonic fluid, 0.45% sodium chloride, to continue replacing losses to total body fluid. When serum glucose levels approach 250 mg, add glucose to IV fluids to minimize the risk of cerebral edema associated with drastic changes in serum osmolality. Administer regular insulin or Humulin R 0.1 unit per kilogram as an IV bolus dose, and then follow with a continuous IV infusion of regular insulin at 0.1 unit per kilogram per hour. Monitor glucose levels hourly. Monitor serum potassium levels. Potassium levels will initially be evaluated or elevated with insulin. Okay, didn't say that before. So K initially low due to diuresis on the chart. But over here it says monitor serum potassium levels. Potassium levels will initially be elevated with insulin therapy, but potassium will shift into cells and the client will need to be monitored for hypokalemia. Provide potassium replacement therapy in all replacement IV fluids as indicated by lab values. Make sure urinary output is adequate before administering potassium. Okay. Administer sodium bicarbonate by slow IV infusion for severe acidosis, pH of less than 7. Monitor potassium levels because correcting acidosis too quickly may lead to hypokalemia. Considerations for older clients. Encourage older adult clients to wear medical alert bracelets. Teach older adult clients to monitor blood glucose every 1 to 4 hours when ill. Emphasize the importance of not skipping an insulin dose when ill. Maintain hydration because older adult clients may have a diminished thirst sensation. Changes in mental status may keep older adults clients from seeking treatment. Client education. Provide the client with education to prevent reoccurrence. Take measures to decrease the risk of dehydration. Monitor glucose every 4 hours when ill and continue to take insulin. Consume liquids with carbohydrates and electrolytes, sports drinks, when unable to eat solid foods. Notify the health care provider if illness lasts more than 1 day. Gatorade sounds good, actually. Therapeutic outcomes. The client will maintain appropriate levels of blood glucose. The client will monitor for signs of impending complications and notify the healthcare provider immediately if any occur. Application exercises. A nurse is administering insulin by continuous IV infusion to a client who has diabetic ketoacidosis DKA. Explain why the nurse should monitor the client for hypokalemia. The answer is with insulin therapy, potassium will shift from intravascular spacing into cells rapidly. Therefore, the client should be monitored for hypokalemia. Potassium replacement should be administered while making sure urinary output is adequate prior to administration. 2. A nurse is caring for a client who is in a hypersimolar hyperglycemic state, HHS. Which of the following findings is consistent with HHS? I'll select all that apply. Abdominal pain, confusion, polyuria, polydipsia, pH of 724. And it's confusion, polyuria, and polydipsia. The client with HHS will not have abdominal pain, which is a symptom of acidosis. Confusion from dehydration may be present, as well as thirst and frequent urination. The client will also have a normal pH 735 to 745 instead of being acidotic at 724. Three, a nurse is caring for a client who has diabetic ketoacidosis, DKA. What type of IV fluid should the nurse expect to administer initially and subsequently as blood glucose decreases? Initially, 0.9% sodium chloride in isotonic solution should be infused rapidly to expand blood volume and maintain perfusion to vital organs. Then a hypotonic solution, such as 0.45% sodium chloride should be infused to replace losses to total body fluid. As blood glucose decreases, a 5% dextrose and 0.45% sodium chloride solution should be administered to maintain adequate blood glucose levels and prevent cerebral edema. What type of acid-base imbalance is likely in a client with diabetic ketoacidosis? How should the nurse recognize compensation for this acid-base disorder? Metabolic acidosis, secondary to breakdown of fats for energy manifested by ketosis, is most likely. Rapid, deep respirations or Kussmaul's respirations will show compensation for the acidosis as the body blows off carbon dioxide, a respiratory acid. Okay, that's Unit 5. Okay, Unit 6, renal. Nursing care of clients with renal disorders. Overview. Renal assessment and diagnostic procedures are used to evaluate kidney function by testing indicators such as an intravenous bolus or IV bolus, CT scan, or magnetic resonance imaging, MRI, or also by testing the kidney function, diagnosis of disease and efficacy of treatment can be determined. Renal diagnostic procedures that nurses should be knowledgeable about include radiography or X-ray, CT scan, MRI, IV bolus, voiding cystourethrophy or VCUG, excretory urography, renal biopsy, cystoscopy, renal scan, and ultrasound. Okay, test radiography or X-ray. Purpose: an X-ray of the kidneys, ureters, and bladder. Cub may also be prescribed as a flat plate. Allows for visualization of these structures. Nursing interventions. Ask a female client if she is pregnant. Inform client that clothes over the area will need to be removed, as well as jewelry and medallions. IV contrast dye, iodine-based, may be used to enhance images. Determine the client's allergy to iodine. dye can cause renal failure. Always check the client's creatinine levels. Parenteral fluids can be given for prevention. CT scan provides cross-sectional images of the kidney to assess the size of the kidney and to assess for obstruction, cysts, or masses on the kidney. Nursing interventions same as the CUB. MRI useful in staging cancer, similar to CT. The client will lie down and have to remain still for test. IV bolus used to detect renal stones and location as well as assess renal function. Interventions not to be done during pregnancy. Relieving bowels produces better images. IV bolus contrast dye, iodine base, may be used to enhance images. Determine the client's allergy to iodine. Dye can cause renal failure. A VCUG, used to outline the bladder's shape and to detect urinary reflux. This process can increase the risk of an infection. Monitor the client for infection for the first 72 hours after the procedure. Excretory urography, used to detect obstruction, assess for parenchymal mass, and assess size of the kidney, same as CUB. And renal biopsy, removal of a sample of tissue by excision or needle aspiration for a cytological or histological examination. The client receives sedation and is monitored for procedure. The client must lie on back post-operatively for 6 hours to prevent bleeding. Check for signs of bleeding and infection. A cystoscopy, used to discover abnormalities of the bladder wall and or occlusions of the ureter or urethra. The client is given anesthesia for procedure. Check for signs of bleeding and infection. Monitor the client for infection for the first 72 hours after the procedure. Renal scan, used to assess renal blood flow and function 48 hours prior to the procedure. ACE inhibitors should not be given. Medication can be given during the test. Watch for hypotension and make sure the client is well hydrated. Ultrasound, used to assess the size of the kidney for an obstruction in the lower urinary tract. Minimal risk for the client, good option if not able to do the excretory urography. Complications, bleeding. Bleeding can result from some of the above tests noted and should be monitored closely. Nursing actions, if bleeding does occur, notify the provider immediately. Hematuria, blood in the urine, is one of the most common complications with renal biopsy. Nursing actions, monitor the client's urinary output closely. Note the color and amount. If bright red or clots are observed, notify the provider immediately. Renal failure, using contrast dye can place the client at risk for renal failure. Nursing actions, always check the client's creatinine levels prior to the procedure. Parenteral fluid can be given for prevention of renal failure if needed. Infection can be the result of some of the above tests noted and needs to be monitored for the first 48 to 72 hours after the procedure. Nursing actions, notify the provider if the client has a temperature, is unable to void, or reports pain. Application exercise. A nurse is caring for a client undergoing a CUB and X-ray of the kidneys, ureters, and bladder. Which of the following should the nurse include in the teaching? This is a specific test and will take most of the day. That's A. B. You may experience some discomfort during the test. C. You will be in the prone position for the test. D. This test will determine if you have kidney stone. It's D. It determines if you have a kidney stone. A CUB can identify kidney stones and other abnormalities such as shapes, strictures, or obstructions. This test is very brief unless a contrast dye is used, in which case the client will be monitored for side effects. There is no discomfort experienced during this test, and the client should be positioned supine. 2. A nurse is caring for a client who has just had a renal biopsy. Which of the following complications is the most immediate risk to the client? A. Infection. B. Bleeding. C. Hematuria. D. Renal failure. Answer is B. Bleeding. The most immediate risk to the client is bleeding into the muscle or the kidney due to the invasiveness of the procedure. Infection, hematuria, and renal failure may be complications but may not develop immediately. Okay, here's something on nursing care of clients with renal disorders, Chapter 68. Nephrotic syndrome and acute and chronic renal failure. Overview. There are several disorders that affect the renal system and its ability to function. Some of these disorders include acute and chronic renal failure and nephrotic syndrome. Nephrotic syndrome. Overview. Nephrotic syndrome is a group of symptoms. Glomerular capillaries are damaged from immune complex deposits, nephrotoxic antibodies, or non-immunological insults. Damaged glomerular capillaries are permeable to serum proteins, resulting in decreased serum osmotic pressure. Nephrotic syndrome is characterized by proteinuria, hypoalbuminemia, and edema. Health promotion and disease prevention. Clients should consume a diet low in sodium and restrict fluid intake, and consult with a healthcare provider regarding diet restrictions. Assessment. Risk factors. Immunologic disorders, toxic injury to the kidney, neoplasms, multi-system diseases, diabetes mellitus, infections, and hyperlipidemia. Also, diseases of the vascular system. Chronic illness can increase the potential of nephrotic syndrome in the older adult client. Renal function decreases with aging, which increases the risk of nephrotic syndrome. Subjective data. Edema, periorbital or independent, irritability, malaise, fatigue, anorexia, and nausea. Objective data. Proteinuria, hematuria, hypertension, anosarca, that's generalized edema, foamy urine, oliguria, anemia, hemoglobin of 12 or less, azotemia, that's increased bun, uremia, symptoms of renal failure, and loss of skin integrity related to edema. Laboratory tests. Urinalysis, 24-hour urine collection. Protein as high as 3 or 4. It's greater than 3.5 grams in 24 hours. Casts. Serum lipid levels. Elevated serum cholesterol greater than 200. Elevated triglycerides. Elevated low density and very low density lipoproteins. Serum albumin less than 3 grams. Serum blood area or urea nitrogen or BUN, creatinine and glomerular filtration rate (GFR) levels may indicate minimal to extensive loss of kidney function. BUN and creatinine levels rise while GFR levels decrease with the loss of kidney function. So BUN and creatinine levels go up while the glomerular filtration rate decreases with loss of kidney function. Diagnostic procedures. Kidney biopsy. Minimal to extensive damage, fatty deposits and tubules, epithelial changes, hypercellularity, glomerular sclerosis, immunoglobulins in capillary walls. Nursing action. Explain the reason for the test, to prepare the client for the test, collect specimens accurately. Collaborative care, nursing care. Report abnormal findings to the provider. Provide periods of rest with activities. Provide emotional support. Encourage adequate nutritional intake within restriction guidelines. Encourage lowering sodium intake. Adjust protein intake according to protein loss in urine over 24 hours. Provide high biologic value protein, lean meat, fish, poultry, dairy. Provide small, frequent feedings due to the client's loss of appetite. Administer medications as prescribed. Assess skin and provide skin care. Medications: loop diuretics, furosemide, Lasix, butanide or Bumex. Considerations: administer IV furosemide, Lasix no faster than 20 mgs a minute, so slow administration of Lasix. Loop diuretics are indicated for renal impairment. Client education: instruct the client to take the medication with food. Inform the client that the medication may cause hypotension. Angiotensin converting enzyme ACE inhibitors, or captopril, captopril. This is used to block the production of angiotensin II, resulting in the excretion of sodium in water. Nursing considerations: monitor the client for increased potassium level. Monitor the client for hypotension. Use carefully on clients with renal impairment related to leukocyte depletion and watch for infection. Client education: inform the client that the medication may cause a dry cough. That would be with the ACE inhibitors. Anticoagulants: heparin, warfarin. This can be used to decrease proteinuria and renal insufficiency. Nursing considerations: monitor the client's PT levels for an appropriate Coumadin dose. Client education: instruct the client to monitor for signs of bleeding, dark stools, bruising easily. Erythropoietin alpha or Epigen or Procrit. This is used to stimulate the production of red blood cells and is given for anemia. Nursing considerations: monitor hemoglobin and hematocrit. Monitor the client's blood pressure. This is contraindicated for clients with uncontrolled hypertension. Okay, client education for erythropoietin alpha is instruct the client to have blood drawn twice a week to monitor hemoglobin and hematocrit. Interdisciplinary care: nephrology services may be consulted for renal impairment. Nutritional services may be consulted for dietary modifications. Care after discharge: nutritional services may be consulted for dietary modifications. Client education: instruct the client to consume a diet low in sodium and restrict fluid intake. Inform the client to consult with the provider regarding diet restrictions. Encourage the client to provide periods of rest with activities. Encourage the client to take medications as prescribed. Instruct the client to notify the provider for a possible increased risk for bleeding. Client outcomes: the client will adhere to a prescribed medication regimen. The client will have a decrease in anxiety. The client will have an increase in activity level, and the client will maintain an oral fluid restriction regimen. Complications: respiratory compromise. Nursing actions: assess and monitor breath sounds, respiratory rate. Peritonitis. Nursing actions: assess and monitor bowel sounds, monitor for infection, rigid tender abdomen, fever, elevated white blood cell count. Renal failure. Nursing actions: assess and monitor renal status, the BUN, the serum creatinine, the urinalysis. Prepare the client for dialysis if indicated. Shock and death. Nursing actions: assess and monitor for early indications of shock. Implement life-saving measures. Okay, and then acute and chronic renal failure, or renal disease, kidney disease. Overview: the kidneys regulate fluid, acid base, and electrolyte balance while also eliminating waste from the body. Renal failure may be diagnosed as acute or chronic. Acute renal failure can result in chronic renal failure without aggressive treatment or when complicating pre-existing conditions exist. Acute renal failure, or ARF, is the sudden cessation of renal function that occurs when blood flow to the kidneys is significantly compromised. ARF is a leading cause of death among hospitalized patients, and 50% is due to an iatrogenic cause. ARF is comprised of 4 phases. Onset begins with the onset of the event and lasts for hours to days. Oliguria begins with the renal insult and lasts for 1 to 3 weeks. Diuresis begins when the kidneys start to recover and can last for 2 to 6 weeks. And recovery continues until renal function is fully restored and can take up to 12 months. Pre-renal failure from volume depletion or prolonged reduction of blood pressure is the most common cause of acute renal deterioration and is usually reversible with prompt intervention. So it's from volume depletion or prolonged reduction of blood pressure. Okay, clinical manifestations occur abruptly with ARF. Chronic renal failure, or CRF, is a progressive, irreversible kidney disease. End-stage renal failure exists when 90% of the functioning nephrons have been destroyed and are no longer able to maintain fluid, electrolyte, or acid balance hemostasis. CRF is comprised of 5 stages. Stage 1, minimal kidney damage with normal glomerular filtration rate. Stage 2, mild kidney damage with mildly decreased GFR. Stage 3, moderate kidney damage with moderate decrease in GFR. Stage 4, severe kidney damage with severe decrease in GFR. And Stage 5, kidney failure and end-stage renal disease with little or no glomerular filtration. Dialysis or kidney transplantation can maintain life, but neither are cures for CRF. A client diagnosed with CRF may be asymptomatic except during periods of stress, i.e. infection, surgery, trauma. As renal failure progresses, clinical manifestations become apparent. Health promotion. Health promotion and disease prevention. Encourage clients to drink at least 3 liters daily. Consult with the provider regarding prescribed fluid restriction if needed. Promote smoking cessation. Assessment. Risk factors of ARF, or acute renal failure. African Americans, Native Americans, and Asians have the highest incidence of end-stage renal disease. Risk factors for acute renal failure include pre-renal, intrarenal, and post-renal causes. Pre-renal occurs before damage to the kidney occurs. Hypovolemia resulting from hemorrhage, dehydration, and prolonged vomiting or diarrhea. Decreased cardiac output resulting in reduced renal perfusion can be caused by myocardial infarction, cardiogenic shock, cardiac arrhythmias, heart failure, pericardial tamponade, open heart surgery. Decreased peripheral vascular resistance is associated with renal artery stenosis, septic shock, anaphylaxis, neurological injury. Renal vascular obstruction can be caused by thrombosis of renal arteries or veins, embolism. Intrarenal occurs within the kidney, and the damage is usually irreversible, acute tubular necrosis. Nephrotoxic injury can be caused by specific antibiotics, NSAIDs, burns, myoglobin, organic solvents, contrast dye, heavy metals, hemolytic transfusion reactions. Acute glomerular nephritis. Acute glomerulonephritis. That's acute pyelonephritis, toxemia of pregnancy, malignant hypertension, systemic lupus erythematosus, and interstitial nephritis. Post-renal obstruction of structures leaving the kidney would be renal calculi, urinary tract obstruction, prostate cancer, bladder cancer, trauma, strictures, spinal cord disease, risk factors and causes of chronic renal failure, acute renal failure, diabetes mellitus, chronic glomerular nephritis, nephrotoxic medications, i.e. gentamicin, NSAIDs, or chemicals. Hypertension, especially if African American. Autoimmune disorders, systemic lupus erythematosus, polycystic kidney, pyelonephrosis, renal artery stenosis, recurrent severe infections. These are all risk factors for chronic renal failure. Older adult clients are at an increased risk for renal failure related to the decreased number of functioning nephrons, decreased GFR, and water and sodium conserving and compensating mechanisms. An increased incidence of chronic renal failure may be related to the prevalence of diabetes mellitus, hypertension, and the use of NSAIDs in older adult clients. Subjective data: fatigue, lethargy, restless leg syndrome, depression, intractable hiccups. Objective data: in most cases, findings of renal failure are related to fluid volume overload and include renal polyuria, nocturia early, oliguria, anuria is late, proteinuria, hematuria, and dilute urine color when present. Cardiovascular would be hypertension, peripheral edema, pericardial effusion, congestive heart failure, cardiomyopathy, and orthostatic hypotension. Okay, and these are, once again, findings of renal failure are related to fluid volume overload and include respiratory, dyspnea, tachypnea, uremic pneumonitis, lung crackles, Kussmaul respirations, and pulmonary edema. Hematologic would be anemia, bruising, and bleeding. Neurologic would be lethargy, insomnia, confusion, encephalopathy, seizures, tremors, ataxia, paresthesias, and coma. Gastrointestinal would be nausea, anorexia, vomiting, metallic taste, stomatitis, diarrhea, uremic halitosis, and gastritis. Skin would be decreased skin turgor, yellow cast to skin, dry, pruritus, bruising, and uremic frost. That's late, uremic frost. Forgot what that was, but it's not cool. Musculoskeletal, osteomalacia, softening of bone, muscle weakness, pathologic fractures, and muscle cramps. And reproductive would be erectile dysfunction. Laboratory tests: urinalysis, hematuria, proteinuria, and alterations in specific gravity. Serum creatinine, gradual increase of 1 to 2 milligrams per every 24 to 48 hours for acute renal failure. Gradual increase over months to years for chronic renal failure exceeding 4 milligrams. Okay. Blood urea nitrogen, or BUN. 80 to 100 milligrams within 1 week with acute renal failure. Gradual increase with elevated serum creatinine over months to years for CRF. 180 to 200 milligrams with CRF. Serum electrolytes. Decreased sodium, dilutional, and calcium. Increased potassium, phosphorus, and magnesium. Complete blood count, CBC. Decreased hemoglobin and hematocrit from anemia, secondary to the loss of erythropoietin in chronic renal failure. Diagnostic procedures. Radiology. Demonstrates disease process, obstruction, and arterial defects. Renal ultrasound. Kidneys, ureter, and bladder, or CUB. Computerized tomography, CT. Aortorenal angiography. Cystoscopy. Retrograde pyelography. And renal biopsy. Collaborative care. Nursing care. Abnormal findings to be reported and monitored include urinary elimination, patterns, amount, color, odor, and consistency, vital signs, blood pressure may be increased or decreased, weight 1 kilogram is 2.2 pounds, daily weights increase in approximately 1 liter of fluid retained. Okay, so 1 kilogram in a daily weight increase is approximately equal to 1 liter. Okay, we do that. Assess and monitor vascular access of peritoneal dialysis insertion site. Provide the client a diet that is high in carbohydrates and moderate in fat. Restrict the client's intake of fluids based on urinary output. Balance the client's activity and rest. Prepare the client for hemodialysis, peritoneal dialysis, and hemofiltration if indicated. Provide skin care to the client in order to increase comfort and prevent breakdown. Protect the client from injury. Provide emotional support to the client and family. Encourage the client to ask questions and discuss fears. Encourage the client to diet, exercise, and take medication to control hyperlipidemia. Administer medications as prescribed. For clients with acute renal failure, nurses should identify and assist with correcting an underlying cause. The underlying cause, prevent prolonged episodes of hypotension and hypovolemia. Prepare for fluid challenge and diuretics during perennial period of azotemia if the client is showing signs of fluid volume deficit. Restrict fluid intake during oliguric phase. Restrict dietary intake of protein, sodium, and potassium during oliguric phase. This restriction is for the client not requiring dialysis. For clients with chronic renal failure, nurses should obtain a detailed medication and herb history to determine the client's risk for continued renal insult. Control protein intake based on the client's stage of renal failure and type of dialysis. Restrict the client's dietary sodium, potassium, and phosphorus and magnesium. Encourage the client with diabetes mellitus to adhere to strict blood glucose control, as uncontrolled diabetes is a major risk for renal failure. Medications. Cardiac glycoside or digoxin increases contractility of the myocardium and promotes cardiac output. Nursing considerations. Take apical pulse for 1 minute prior to giving the medication. Notify the client if the provider if the client's heart rate is less than 60 per minute. Client education. Instruct the client to take apical pulse for 1 full minute daily prior to self-administration of the medication. Instruct the client to notify the provider if the apical pulse is less than 60 a minute. Instruct the client to notify the provider immediately if vision changes, blurred vision, seeing more yellow color, or if there is a sensitivity to light or behavior changes. These are signs of digoxin toxicity and need immediate attention. Sodium, another drug for this, K-exolate or sodium polystyrene. K-exolate to increase elimination of potassium. Nursing considerations. Monitor levels of potassium. Monitor vital signs. Use it cautiously with clients who have heart failure, hypertension, or edema. Monitor clients who are taking digoxin cautiously. Erythropoietin alpha or Epigen or Procrit to stimulate production of red blood cells given for anemia. Nurse considerations. Monitor hemoglobin and hematocrit. Monitor the client's blood pressure. This is contraindicated for clients with uncontrolled hypertension. Use medication cautiously in clients who have bone marrow cancer. Client education. Instruct the client to have blood drawn twice weekly to monitor hemoglobin and hematocrit. Iron supplement. Ferrous sulfate. Increase the level of iron in blood. Nursing considerations. Administer medication after dialysis if applicable. Stool softeners should be used as this medication causes constipation. Client education. Instruct the patient to take the medication with food. Aluminum hydroxide gel or amphigel. A phosphate binder is used to increase the elimination of phosphate. Nursing considerations. Stool softeners should be used as this medication causes constipation. This is contraindicated in clients with gastrointestinal disorders. Client education encourages the client to report signs of constipation. Diuretics, except in ESRD, whatever that means. Lasix. This is used to excrete excess fluid. Nursing considerations. Monitor intake and output. Monitor blood pressure. Client education. Encourage the client to weigh daily. Instruct the client to notify the provider if experiencing thirst, coughing, or lightheadedness. Interdisciplinary care. Nephrology services may be consulted to manage dialysis or renal failure. Nutritional services may be consulted to manage the nutritional needs of the client. Therapeutic procedures. Hemodialysis. Care after discharge. Nephrology services may be indicated if the client is to receive outpatient dialysis. Refer the client to a community support group related to the disease. Nutritional services may be consulted for the client's dietary needs. Refer the client to a smoking cessation support group and counseling if needed. Client education. Instruct the client to monitor the daily intake of carbohydrates, proteins, sodium, and potassium according to the provider. Instruct the client to monitor fluid intake according to fluid restriction prescribed by the provider. Instruct the client to avoid antacids containing magnesium. Encourage the client to take rest periods from activity. Educate the client receiving hemodialysis or peritoneal dialysis on an outpatient basis. Educate the client on how to measure blood pressure and weight at home. Encourage the client to ask questions and discuss fears. Encourage the client to diet, exercise, and take medication as prescribed. Advise the client to notify the provider if observed signs of skin breakdown. Client client outcomes. The client will maintain a fluid balance. The client will improve tolerance to activity. The client will report a decrease in anxiety. The client will follow a medication regimen. The client will have no signs of skin breakdown. Complications. Potential complications of renal failure include electrolyte imbalance, dysrhythmias, fluid overload, metabolic acidosis, and secondary infection. Hyperkalemia. Nursing actions. Consider Kexalate or insulin as prescribed for hyperkalemia. Hypertension. Nursing action is administer antihypertensives and diuretics as prescribed. Seizures. Nursing actions to be implement seizure precautions and administer anti-epileptics as prescribed. Cardiac dysrhythmias. Provide life support interventions for life-threatening dysrhythmias. Monitor the client for and report non-lethal dysrhythmias. Pulmonary edema. Prepare the client for hemodialysis. Infection. Maintain the client's surgical asepsis of invasive lines, monitor breath sounds, and turn the client every 2 hours. Monitor the client for signs of localized and systemic infections and report. Metabolic acidosis. Prepare the client for hemodialysis. Uremia. Prepare the client for hemodialysis. Application exercises. Beginning with the first event, identify the sequence of pathological events that occurs in a client with nephrotic syndrome. So 1 would be renal insult, 2 would be increased glomerular permeability, 3 would be proteinuria, 4 would be decreased serum protein, and 5 would be generalized edema. According to the sequence of pathological events, a client with nephrotic syndrome will first experience renal insult, leading to an increase in glomerular permeability along with proteinuria. The client will next exhibit a decrease in serum protein in the blood, followed by generalized edema throughout the body. 2. A nurse is caring for a client with nephrotic syndrome. The client asks the nurse why her legs and feet are swollen. How can the nurse best address the client's concern? The nurse should explain that the client's kidneys are not able to rid her body of excess fluids that collects in the tissues. The nurse should reassure the client that interventions will be implemented to help rid her body of fluids while her kidneys heal. Which of the following signs and symptoms should the nurse monitor for in a client with nephrotic syndrome? Select all that apply. Malnutrition, hematuria, infection, peritonitis, hyperkalemia, hypotension, and fever. For that one, it's all of them except hypotension. Malnutrition, hematuria, infection, peritonitis, hyperkalemia, and fever should all be signs and symptoms related to a client with nephrotic syndrome. Hypotension would not be indicated in the client. Which of the following assessments should be made while the client is in acute renal failure? Select all that apply. I'll just tell you what they are. It's blood glucose, blood pressure, serum electrolytes, serum creatinine, arterial blood gas, and urine output. Prioritize the following nursing interventions according to how they occur in a client diagnosed with renal failure. So, 1, you monitor serum potassium level. 2, assess breath sounds. 3, turn the client every 2 hours. 4, offer emotional support to the family. According to the sequence of events, the first intervention the nurse should take with a client in renal failure is to monitor the client's potassium level. The nurse should then listen to the client's breath sounds to assess for a possible respiratory infection. Next, the nurse should turn the client every 2 hours since the client may be weak and unable to turn himself. This also promotes circulation to the body. The family will require emotional support due to the client's disease, which can be acute or chronic and may require dialysis or surgery with the medication regimen. Okay, nursing care of clients with cardiovascular disorders. We're on to Unit 7. This is Chapter 31 of ATI Med-Surg. And it's wasn't really part of the study guide, but I'm just going to stay true to the ATI and hope it gets me through. Overview. Cardiovascular diagnostic procedures evaluate the functioning of the heart by monitoring for enzymes in the blood. Using ultrasound to visualize the heart, determining the heart's response to exercise, and using catheters to determine blood volume, perfusion, fluid status, how the heart is pumping, and degree of artery blockage. Cardiovascular diagnostic procedures that nurses should be familiar with include cardiac enzymes and lipid profile, echocardiogram, stress testing, and hemodynamic monitoring, angiography, and vascular access. Cardiac enzymes and lipid profile. Cardiac enzymes are released into the bloodstream when the heart muscle suffers ischemia. A lipid profile provide information regarding cholesterol levels and is used for early detection of heart disease. Cardiac enzymes are a special marker in diagnosing MI. Indications: angina, MI, heart disease, and hyperlipidemia. Interpretation of findings. So, cardiac enzyme, the type of cardiac enzyme first is creatine kinase, MB, isoenzyme CK-MB, more sensitive to myocardium. Expected reference range would be 0% to total CK, or 30 to 170 units per liter. Elevated levels, first detectable following myocardial injury, is 4 to 6 hours. And expected duration of elevated levels is 3 days. So that was creatine kinase MB. Then there's troponin T, and that the expected reference range should be less than 0.2 ng per L. And elevated levels, first detectable following myocardial injury, would be 3 to 5 hours after MI. And expected duration of elevated levels would be 14 to 21 days. Next is troponin I, and that the expected reference range would be less than 0.03 ng per liters, and detectable after MI 3 hours, and 7 to 10 days expected duration. And then there's myoglobin, and that needs to be less than 90 micrograms per liter, and that's 2 hours after MI, and expected to be only 24 hours in duration. So the different tests they can do is cholesterol total, and that should be, the expected reference range should be less than 200 mg. And purpose for screening it's a screening a test for heart disease. Then there's HDLs. Females need to be between 35 and 80 milligrams, and males between 35 and 65. It's the good cholesterol produced by the liver. LDLs needs to be less than 130 mgs, and it's the bad cholesterol. It can be up to 70% of total cholesterol, so that needs to be less than 130. And triglycerides less than 150 mgs, and an evaluating test for atherosclerosis. So triglycerides, atherosclerosis, cholesterol, heart disease, HDLs, and LDLs. Okay, pre-procedure. Nursing actions. Explain the reason for the test to the client. Intra-procedure is a blood specimen is drawn from the client via venipuncture. Post-procedure, lab findings will be discussed with the client by the provider, and choice of treatment will be determined. Echocardiogram. An echocardiogram is an ultrasound of the heart. The test is used to diagnose valve disorders and cardiomyopathy. So, echocardiogram for valve disorders and cardiomyopathy. Indications: cardiomyopathy, heart failure, angina, myocardial infarction. Pre-procedure, nursing actions. Explain the reason for the test to the client. The test is pain-free and takes up to 1 hour. Intra-procedure would be nursing actions. Instruct the client to lie on left side and remain still. Post-procedure, nursing actions. Inform the client that the results of the test and a plan for follow-up care will be provided by the provider. There is no specific post-procedure instructions that need to be followed. Stress testing. The cardiac muscle is exercised by the client walking on a treadmill. This provides information regarding the workload of the heart. Once the client's heart rate reaches a certain rate, the test is discontinued. Clients sometimes become too tired and are unable to finish the test. The provider can reorder the test to be done as a pharmacological stress test. Indications: angina, heart failure, myocardial infarction, dysrhythmia. Pre-procedure, nursing actions. Ensure that informed consent has been obtained. Explain to the client that he will be walking on a treadmill and comfortable shoes and clothing are recommended. If the client is disabled or unable to be physically challenged, the provider can order the test to be pharmacological stress tests, where drugs such as adenosine or adenocard is given to stress the heart instead of walking on the treadmill. The client is instructed to fast 2 to 4 hours before procedure according to agency policy, and avoid tobacco, alcohol, and caffeine before the test. Intra-procedure, nursing actions. Remind the client that once the heart reaches a certain rate, the test will be discontinued. Post-procedure, nursing actions. The client is monitored by ECG, and his blood pressure is checked frequently until he is stable. The provider will discuss findings with client. There are no specific post-procedure considerations for this test. Hemodynamic monitoring. Hemodynamic monitoring involves special indwelling catheters to provide information about blood volume and perfusion, fluid status, and how well the heart is pumping. Hemodynamic status is assessed with several parameters. Central venous pressure, CVP, pulmonary artery pressure, PAP, pulmonary artery wedge pressure, PAWP, and cardiac output, CO, intra-arterial pressure. Mixed venous oxygen saturation, SVO2, indicates the balance between oxygen supply and demand. It is measured by a pulmonary artery catheter with fiber optics. A pressure monitoring system comprised of a catheter with an infusion system, a transducer, and a monitor is used to display a client's hemodynamic information. Components of hemodynamic monitoring system: pressure transducer, pressure tubing, monitor, pressure bag and flush device. Arterial lines. Arterial lines are placed in the radial, most common, brachial, or femoral artery. Artery lines provide continuous information about changes in blood pressure and permit the withdrawal of samples of arterial blood. Intra-arterial pressures can differ from cuff pressures. The integrity of the arterial waveform should be assessed to verify the accuracy of blood pressure readings. Monitor circulation in the limb with the arterial line, capillary refill, temperature, color. So monitor circulation in the limb with the arterial line, capillary refill, temperature, color. Okay. Arterial lines are not to be used for intravenous fluid infusion. Pulmonary artery catheters. Pulmonary artery catheters, or PA catheters, have multiple ports and components that enable a variety of hemodynamic measurements, the collection of blood samples, and the infusion of intravenous fluids. The PA catheter is inserted into a large vein, internal, jugular, femoral, subclavian, brachial, and threaded through the right atria and ventricle into a branch of the pulmonary artery. Pulmonary artery catheters have multiple lumens. Proximal lumen can be used to measure right atrial pressure, or CVP, infuse intravenous fluids, and to obtain venous blood samples. Distal lumen can be used to measure pulmonary artery pressure, PA systolic, PA dystolic, mean pulmonary artery pressure, and pulmonary artery wedge pressure. This lumen is not to be used for intravenous fluid infusion. Balloon inflation port is intermittently used for PAWP measurements, or wedge pressure measurements, when not in use. It should be left deflated and in the locked position. Thermistor measures temperature differences between the right atrium and the pulmonary artery in order to determine cardiac output. Additional infusion ports may be indicated depending on the brand. Indications: serious or critical illness, heart failure, post-coronary artery bypass graft, or CABG clients, graft clients. Okay, ARDS, ARDS, acute renal failure, burn victims, trauma victims. Interpretation of findings: normal values of hemodynamic readings. The CVP, the central venous pressure, 1 to 8 milligrams, or millimeters, 1 to 8, it's all mmHg. So 1 to 8, pulmonary artery systolic, 15 to 26, pulmonary artery dystolic, 5 to 15, pulmonary artery wedge pressure, 4 to 12, cardiac output, 4 to 6 liters a minute, and mixed venous oxygen saturation, SVO2, 60% to 80%. The intravascular volume in older clients is often reduced. Therefore, the nurse should anticipate lower hemodynamic readings, particularly if dehydration is a complication. Pre-procedure. Nursing actions.
Line insertion. Ensure the client's understanding of the procedure prior to obtaining consent. Assemble the pressure monitoring system. Purge all air from system. Maintain sterility of connections. Place the client in supine or Trendelenburg position. Not sure that one. Administer sedation and pain medications as prescribed. Level transducer with phlebostatic access, fourth intercostal space, and mid-axillary line. Zero system with atmospheric pressure. Hemodynamic pressure lines must be calibrated and read atmospheric pressure as 0, and the transducer should be positioned at the right atrium, the phlebostatic axis. Obtain initial readings as prescribed. Compare arterial blood pressure to non-invasive cuff pressure, NIBP. Document the client's response. Intra-procedure monitoring for symptoms of altered hemodynamics. So right heart equals CVP and left heart is PAWP. Okay, this is preload. This is monitoring of symptoms of altered hemodynamics. This is preload. Right heart CVP, left heart PAWP. Elevated would be crackles in lungs, jugular vein distension, hepatomegaly, peripheral edema, taut skin turgor. Decreased would be poor skin turgor and dry mucous membrane. Then afterload, right heart pulmonary vascular resistance, left heart systemic vascular resistance, the PVR and the SVR. And elevated would be cool extremities, weak peripheral pulse. Decreased would be warm extremities, bounding peripheral pulse. Okay, post-procedure. Nursing actions. Obtain chest x-ray, follow the procedure to confirm catheter placement. Continually monitor respiratory and cardiac status, vital signs, heart rhythm, SaO2. Observe respiratory pattern and effort. Compare NIBP to arterial blood pressure. Maintain line placement and integrity. Observe and document waveforms. Report changes in waveforms to the provider, as this can indicate catheter migration or displacement. Document catheter placement each shift and as needed after movement for transport. Monitor and secure connections between pressure tubing, transducers, and catheter ports. Obtain readings from hemodynamic catheter as prescribed. Place the client in supine position prior to recording hemodynamics values. Head of bed can be elevated 15 to 30%. Level the transducer at the phlebostatic axis before readings and with all position changes. Zero system to atmospheric pressure. Compare hemodynamic findings to physical assessment. Monitor trends and values obtained over time. Complications. Infection, sepsis. Infection at insertion site can occur if a septic technique is not used carefully. Nursing actions. Change dressing per hospital protocol and as needed. Gloves, sterile gloves. Maintain sterile field. Monitor for evidence of infection, elevated WBC count or temperature. Perform thorough hand washing. Collect specimens, blood culture, catheter tip cultures, and deliver to the laboratory. Administer antibiotic therapy as prescribed. Administer intravenous fluids for intravascular support. Administer vasopressors of dopamine for vasodilation secondary to sepsis. Embolism. Plaque or a clot can become dislodged during the procedure. Nursing actions. Use heparinized solution for flushing system to prevent thromboembolism. Avoid introduction of air into flushing system to prevent air embolism. Recognize that there is a risk of pneumothorax with insertion of the line, and recognize that there is a risk of dysrhythmias and with insertion / movement of the line.
Angiography. Okay, done with that. Angiography. A coronary angiogram, also called a cardiac catheterization, is an invasive diagnostic procedure used to elevate the presence and degree of coronary artery blockage. Angiography can also be done on the lower extremities to determine blood flow and areas of blockage. Angiography involves the insertion of a catheter into a femoral, sometimes a brachial vessel, and threading it into the right or left side of the heart. Coronary artery narrowings and or occlusions are identified by the injection of contrast media under fluoroscopy. Fun. Unstable angina and ECG changes. Oh, did I skip a page? Okay, indications. Unstable angina and ECG changes, T-wave inversion, ST segment elevation, and depression. Confirm and determine location and extent of heart disease. Pre-procedure. Nursing actions. Ensure that the consent form is signed. Maintain the client on NPO status for at least 8 hours. Risk for aspiration when lying flat for the procedure. Assess that the client and family understand the procedure. Assess for iodine shellfish allergy contrast media. Assess renal function prior to introduction of contrast dye. Administer pre-medications as prescribed, methylprednisone, solumedrol, medrol, and or diphenhydramine, which is Benadryl. Client education. Instruct the client that he can be awake and sedated during procedure. A local anesthetic should be used. A small incision is made often in the groin to insert the catheter. The client can feel warmth and flushed when the dye is inserted. After the procedure, the client must keep the affected leg straight. Pressure, a sandbag, can be placed on the incision to prevent bleeding. Sandbag. Okay, intra-procedure. Nursing actions. Administer sedatives and analgesia as prescribed. Continually monitor vital signs and heart rhythm. Be prepared to intervene for dysrhythmias. Have resuscitation equipment and emergency medical medications readily available. Post-procedure. Nursing actions. Assess vital signs every 15 minutes times 4, every 30 minutes times 2, every hour times 4, and then every 4 hours. Follow hospital protocol. Assess the groin site at the same intervals for bleeding and hematoma formation. Thrombosis. Document pedal pulse, color, temperature. Maintain bed rest in supine position with extremity straight for prescribed time. A vascular closure device may be used to hasten hemostasis following catheter removal. Older adult clients can have arthritis, which can make lying in bed for 4 to 6 hours after the procedure painful. The provider can be notified for prescribed medication. Conduct continuous cardiac monitoring for dysrhythmias. Reperfusion following angioplasty can cause dysrhythmias. Administer antiplatelet or thrombolytic agents as prescribed to prevent clot formation and stenosis. You can administer aspirin, Plavix, Ticlid, heparin, low molecular weight heparin or Lovenox, GPIIB or IIA inhibitors, such as integralin. Administer anxiolytics, Ativan, and analgesia morphine as needed. Monitor urine output and administer IV fluids for hydration. Contrast media acts as an osmotic diuretic. Perform assist with sheath removal from vessel. Apply pressure to arterial venous sites for the prescribed period of time. Varies depending upon the method used for vessel closure. Observe for vagal response, hypotension, bradycardia from compression of nerves. Apply pressure dressing. Client education. Instruct the client to avoid strenuous exercise for the prescribed period of time. Immediately report bleeding from the insertion site, chest pain, shortness of breath, and changes in the color or temperature of the extremity. Restrict lifting less than 10 pounds for the prescribed period of time. Clients with stent placement will receive anticoagulation therapy for 6 to 8 weeks. Instruct the client to take the medication at the same time each day, have regular laboratory tests to determine therapeutic levels, and avoid activities that could cause bleeding. Use soft toothbrush, wear shoes when out of bed. Encourage the client to follow lifestyle guidelines, manage weight, consume a low-fat, low-sodium diet, get regular exercise, stop smoking, decrease alcohol intake. Complications. Cardiac tamponade. Cardiac tamponade can result from fluid accumulation in the pericardial sac. Signs include hypotension, jugular vein distension, that's hypotension, muffled heart sounds, and paradoxical pulse, which is variance of 10 mm's or more in systolic blood pressure between expiration and inspiration. Hemodynamic monitoring will reveal intracardiac and pulmonary artery pressures similar and elevated or plateau pressures. Nursing actions. Notify the provider immediately. Administer IV fluids to combat hypotension as prescribed. Obtain a chest x-ray or electrocardiogram to confirm diagnosis. Prepare the client for pericardiocentesis. Informed consent, gather materials, administer medications as appropriate. Monitor hemodynamic pressures as they normalize. Monitor heart rhythm. Changes indicate improper positioning of the needle. So monitor heart rhythm, changes indicate improper positioning of the needle. Monitor for reoccurrence of signs after the procedure. Hematoma formation. Blood clots may form near the insertion site. Nursing actions. Assess the growing at prescribed intervals and as needed. Hold pressure for uncontrolled oozing and bleeding. Monitor peripheral circulation. Monitor peripheral circulation. Notify the primary care provider. Restenosis of treated vessel. Clot reformation in the coronary artery can occur immediately or several weeks after procedure. This is restenosis of treated vessel. Okay. Nursing actions for clot reformation in the coronary artery immediately or several weeks after procedure. Assess ECG patterns and for occurrence of chest pain. Notify the provider immediately. Prepare the client for return to cardiac catheterization laboratory. Retroperitoneal bleeding. Bleeding into the retroperitoneal space, abdominal cavity behind the peritoneum, can occur due to femoral artery puncture. Nursing actions. Assess for flank pain and hypotension. Notify the provider immediately. Administer IV fluids and blood products as prescribed. Vascular access. Okay, the site and type of vascular access is determined by the characteristics of the prescribed therapy, medication type, pH and osmolality, length of time for therapy. The goal is to minimize the number of catheter insertions and the risk for adverse reaction. Age-related loss of skin turgor and vein conditions pose challenges to vascular access. Using hand veins is not appropriate for older adult clients. So central catheters. Central catheters are appropriate for any fluids due to rapid hemodilution in the superior vena cava, SVC. They require X-ray verification of tip placement prior to use. All central catheters must be inserted by a provider with the exception of PICC lines, which may be inserted by a specially trained nurse. Insertion occurs in the OR, the client's hospital room, or in the outpatient facility. Tunneled and implanted catheters require surgical removal. Central catheter types include non-tunneled percutaneous central catheter, triple lumen, peripherally inserted central catheter PICC, or tunneled percutaneous central catheter, a Hickman-Grosjean, and an implanted port. Non-tunneled percutaneous central catheter. Description: 15 to 20 centimeters in length with 1 to 3 lumens. Length of use up to 3 months. Insertion location: subclavian vein, jugular veins. Tip in the distal third of the superior vena cava. Indications: administration of blood, long-term administration of chemotherapeutic agents, antibiotics, and the total parenteral nutrition. Okay. Peripherally inserted central catheters, PICCs. Description: 40 to 60 centimeters with single or multiple lumens. Length of use up to 12 months. Insertion location: basilic or cephalic vein at least 1 finger's breadth below or above the antecubital fossa. The catheter should be advanced until the tip is positioned in the lower 1/3 of the superior vena cava. Indications: administration of blood, long-term administration of chemotherapeutic agents, antibiotics, and total parenteral nutrition. Pre-procedure: PICCs may be inserted by specially trained nurses. Apply local anesthetic at insertion site and insert the catheter using surgical aseptic technique. Post-procedure: apply an initial dressing of gauze and replace with a transparent dressing within 24 hours. An initial X-ray should be taken to ensure proper placement. Care of a PICC line includes assessing the site at least every 8 hours. Note redness, swelling, drainage, tenderness, and condition of the dressing. Changing the tube and positive pressure cap per facility protocol, usually a minimum of every 3 days for the hospitalized client. Using 10 milliliters of large syringe or larger syringe to flush the line. Cleaning the insertion port with alcohol for 3 seconds and allowing it to dry completely prior to accessing it. Performing flush for intermediate medication. Administration per facility protocol, usually with 10 milliliters of 0.9% sodium chloride before, between, and after medications. Obtaining blood samples by withdrawing 10 milliliters of blood and discarding. Taking a second syringe and withdrawing 10 milliliters of blood for sample. Taking a third syringe and flushing with 10 milliliters of 0.9% sodium chloride. Follow facility protocol for specific flushing guidelines. Using transparent dressing, follow facility protocol for dressing changes, usually every 7 days and when indicated, wet, loose, soiled. Advising the client not to immerse his arm in water, to shower covering dressing site to avoid water exposure. Educating the client not to have blood pressure taken into arm with PICC line. Tunneled percutaneous central catheter. Description: 48 to 104 centimeters, 9 to 41 inches in length. For long-term use. Insertion location: a portion of the catheter lies in the subcutaneous tunnel, separating the point where the catheter enters the vein from where it enters the skin with a cuff. Tissue granulates into the cuff to provide a mechanical barrier to organisms and an anchoring for the catheter. Indications: frequent and long-term need for vascular access. No dressing is needed since entrance into skin and vein are separate, and tissue granulates into catheter cuff, providing a barrier. Grosjean catheters have pressure-sensitive valves to prevent blood reflux and do not require a clamp. Implanted port. Description: port is comprised of a small reservoir covered by a thick septum. Insertion location. Port is surgically implanted into chest wall pocket. The catheter is inserted into the subclavian vein with the tip in the superior vena cava. Indications: long-term, a year or more, need for vascular access, commonly used for chemotherapy. Pre-procedure. To access an implanted port. Apply local anesthetic to skin if indicated. Palpate skin to locate the port body septum to ensure proper insertion of the needle. Clean the skin with alcohol for at least 3 seconds and allow to dry prior to insertion of the needle. Access with a non-coring or a Huber needle. Post-procedure, flush with 10 milliliters 0.9% sodium chloride or per facility protocol after every use and at least once per month. Complications: phlebitis. Phlebitis can be chemical, osmolarity, or pH could be chemical, osmolarity, or pH is different. Veins too small for substance. Bacterial or mechanical irritation, excess IV manipulation. Nursing actions: monitor for signs and symptoms. Erythema at the site, that's the usual initial sign. Pain or burning at the site and the length of the vein. Discomfort when the skin over the tip is touched. Warmth over the site. Edema at the site. Vein indurated or hard. Red streak and or cord-like. Slowing infusion rate. Temperature elevation of 1 degree Fahrenheit or more. Infection appearing 7 to 10 days after insertion. Take preventative measures. Observe the site every 2 hours for signs of infection or infiltration. Non-tunneled catheters required intact sterile dressing. Tunneled catheters do not. Use the smallest gauge in the largest vein possible to minimize mechanical and chemical irritation into the vein wall. Clean the site with 2% chlorhexidine-based preparation, 70% alcohol or tincture of iodine per protocol with friction. Let preparation air dry before insertion. Change IV sites every 3 days. Provide treatment. Discontinue the IV. Apply warm compresses. Restart with new tubing infusate. Occlusion. Occlusion is a blockage in the access device that impedes flow. Nursing actions: flush the line at least every 12 hours, 3 milliliters for peripheral, 10 milliliters for central lines to maintain patency. Studies show that 0.9% sodium chloride is as effective as heparinized flush solutions to maintain catheter patency. Follow facility protocol. Flush ports after every use and at least once a month while implanted. Administer urokinase or abokinase to lyse obstructions per protocol. Catheter thrombosis emboli. Blood can become coagulated and cause an occlusion. Nursing actions: flush the line per facility protocol. Do not force fluid. If resistance is encountered, may dislodge thrombosis. Use a large barrel syringe, 10 cc or bigger, to avoid excess pressure per square inch psi. That could cause catheter fracture or rupture. Infiltration and extravasation. Infiltration and extravasation. Infiltration is fluid leaking into surrounding subcutaneous tissue, and extravasation is unintentional infiltration of a vescient medication that causes tissue damage. Causes: improper IV insertion, improper vein selection, too small, too fragile, poor location, irritating infusates that weaken and rupture the vein wall, over manipulation of the IV catheter, improper taping that allows IV catheter movement and vein compromise, tape too tight, becoming a tourniquet. Nursing actions: monitor for signs and symptoms: swelling around the site and proximal or distal to the IV, edema, puffiness in the dependent area underneath, skin taut or rigid with blanching, sensation of coolness. Check the client and the system. protect the client and the system. Putting pressure on the vein just beyond the tip of the catheter should stop the IV flow. If flow is not affected, the fluid is probably going into the subcutaneous tissue. The IV alarm may sound due to occlusion. Do not rely on the pump alarm because pressure must be significant to activate. If there is leaking at the site after confirming tube connections, this indicates a problem. Blood return is not considered a reliable indicator. Take preventative measures. Do not use arm with MLC or PICC for blood pressure or phlebotomy. Do not use hand veins in older clients who have lost subcutaneous tissue. Do not use hand veins for vesicant medication. Vesicant means. Use a hand board for sites affected by the motion of a joint. Provide treatment. Remove using direct pressure with gauze sponge until bleeding stops. Apply cool compresses. Elevation is now considered optional. Avoid starting a new IV site in the same extremity. Air embolism. Vascular access can result in gas bubbles being introduced into the vascular system. Nursing actions. Leave central lines clamped when not in use. Have the client hold breath while the tubing is changed. If the client has sudden shortness of breath, place in Trendelenburg position on left side. Give oxygen and notify the provider to trap and aspirate air. Okay. Mechanical complications. Mechanical complications include accidental dislodgement, mesh damage on port catheters, and catheter migration. Nursing actions. To prevent accidental dislodgement, cover the extremity site with stretch netting. Wrap a washcloth folded in thirds around the arm before applying a kneaded restraint. This prevents the restraint from sliding and dislodging the catheter. Only tape the catheter hub to minimize manipulation. When removing the dressing, pull from distal to proximal. If the skin is oily, defat oils with alcohol and air dry before antiseptic cleansing. Use only a non-coring or Huber needle to avoid damaging the mesh on port catheters. Note the length to help detect catheter migration. Notify the provider of any changes in length. Okay, application exercises for cardiovascular diagnostic and therapeutic procedures. Place P for preload or A for afterload next to the following hemodynamic pressures. Okay, the wedge pressure is P for preload. SVR, can't remember what that was, is A. PVR is A, and CVP is P. Hemodynamic pressures that would be preload are POP and CVP. Afterload would be SVR and PVR. So the VRs are afterload, the POP and the CVP are preload. Which of the following actions are necessary to obtain an accurate hemodynamic reading? Select all that apply. Let's tell you, it's level transducer to the phlebostatic access by the heart there. Zero transducer to room air. Record readings and compare readings to physical assessment. You want to level the transducer to the phlebostatic access. Zero transducer to... Okay, yeah, let's just set all that. Don't put them in a high Fowler's. It's like 30, no more than 30 degrees. Okay. Why is it imperative that a client lie still for 6 hours following an angiography? Risk of increased blood pressure, risk of infection, anesthesia risk, or increased risk for bleeding. And it's increased risk for bleeding. Following an angiography, the client must lie still for 6 hours due to the increased risk of bleeding. A risk for increased blood pressure or infection or risks related to anesthesia are not necessarily related to the client lying still following angiography.
A nurse receives an order to administer 0.9% sodium chloride IV at 50 milliliters per hour. Which of the following lines can be used for administration? Select all, apply. And it's a peripheral IV site and a proximal CVP lumen of PA catheter. Arterial lines in the distal lumens of pulmonary artery catheters are used for hemodynamic measurements and the collection of blood samples. They are not to be used for intravenous fluid administration. Okay, and a nurse has just obtained the following hemodynamic readings for a client. The PAS is 34, the PAD is 21, the PAWP is 16, and the CVP is 12. Which of the following conditions support these hemodynamic values? It's heart failure, cor pulmonale, and pulmonary hypotension, or hypertension. These elevated hemodynamic measurements are consistent with left ventricle failure and pulmonary problems. Hypovolemic shock is characterized by low hemodynamic values. So I guess those were all high. Okay. Nursing care of clients. No, hold on. Okay, test. Test. Okay, so I'm going to skip to peripheral vascular diseases, and then I'll finish up with hypertension for cardiac. Nursing care of clients with cardiovascular disorders. Peripheral vascular diseases. Overview. Peripheral vascular diseases include peripheral arterial disease, PAD, and peripheral venous disorders, both of which interfere with normal blood flow. PAD affects the arteries, the blood vessels that carry blood away from the heart, and peripheral venous disease affects the veins, the blood vessels that carry blood toward the heart. Peripheral arterial disease, PAD. PAD results from atherosclerosis that usually occurs in the arteries of the lower extremities and is characterized by inadequate flow of blood. Atherosclerosis is caused by gradual thickening of intima and media of the arteries, ultimately resulting in the progressive narrowing of vessel lumen. Plaques may form on the walls of the arteries, making them rough and fragile. Progressive stiffening of the arteries and narrowing of the lumen decreases the blood supply to affected tissues and increases resistance to blood flow. Atherosclerosis is actually a type of arteriosclerosis, which means hardening of the arteries, and alludes to the loss of elasticity of arteries over time due to thickening of their walls. PAD is classified as inflow or distal aorta and iliac arteries, or outflow femoral, popliteal, and tibial arteries, and may range from mild to severe. Tissue damage occurs below the arterial obstruction. Buerger's disease, subclavian steal syndrome, thoracic outlet syndrome, Raynaud's disease and Raynaud's phenomenon, and popliteal entrapment are examples of PADs. Assessment. Risk factors. Hypertension, hyperlipidemia, diabetes mellitus, cigarette smoking, obesity, sedentary lifestyle, familial disposition, age. Older adult clients have a higher incidence of PAD. Rate of occurrence is increased in men over 45 and in women who are postmenopausal, and have a higher mortality rate from complications than younger individuals. Subjective data. Burning, cramping, and pain in the legs during exercise, intermediate claudication, numbness or burning pain, primarily in the feet when in bed. Pain is relieved by placing legs at rest in a dependent position. Objective data. Physical assessment findings. Bruit over femoral or aortic arteries. Decreased capillary refill of toes, greater than 3 seconds. Decreased or non-palpable pulses. Loss of hair on lower calf, ankle, and foot. Dry, scaly, mottled skin. Thick toenails. Cold and cyanotic extremity. Pallor or extremity with elevation. Dependent rubor. Muscle atrophy. Ulcers and possible gangrene on toes.
Diagnostic procedures. Arteriography. Arteriography of the lower extremities involves arterial injection of contrast media to visualize areas of decreased arterial flow on an X-ray. It is usually done only to determine isolated areas of occlusion that can be treated during the procedure with percutaneous transluminal angioplasty and possible stent placement. Nursing actions. The nurse should observe for bleeding and hemorrhage. Palpation of pedal pulses should also be done to assess for post-procedure occlusions. Exercise tolerance testing. A stress test is done with or without the use of treadmill medications such as percentine and adenocard may be given to mimic the effects of exercise in clients who cannot tolerate treadmill. With the onset of symptoms or 5 minutes of exercise, delays or 5 minutes of exercise. Delays in return to normal pressures and pulse waveforms indicate arterial disease. It is used to evaluate claudication during exercise. Plethysmography. Plethysmography is used to determine the variations of blood passing through an artery, thus identifying abnormal arterial flow in the affected limb. Blood pressure cuffs are attached to the client's upper extremities and a lower extremity and attached to the plethysmograph machine. Variations in peripheral pulses between the upper and lower extremities are recorded. A decrease in pulse pressure of the lower extremities indicates a possible block in the leg. Segmental systolic blood pressure measurements. A Doppler probe is used to take various blood pressure measurements, thigh, calf, ankle, brachial, for comparison. In the absence of peripheral arterial disease, pressures in the lower extremities are higher than those in the upper extremities. Okay. With arterial disease, the pressures in the calf, or in the thigh, calf, and ankle are lower. Okay, so peripheral arterial disease, pressures in the lower extremities are higher, and with arterial disease, the pressure in the thigh, calf, and ankle are lower. Okay. Collaborative care, nursing care. Encourage the client to exercise to build up collateral circulation. Initiate exercise gradually and increase slowly. Instruct the client to walk until the point of pain. Stop and rest, and then walks a little farther. Positioning. Instruct the client to avoid crossing her legs. Tell the client to refrain from wearing restrictive garments. Tell the client to elevate her legs to reduce swelling, but not to elevate them above the level of her heart, because extreme elevation slows arterial blood flow to the feet. Promote vasodilation and avoid vasoconstriction. Provide a warm environment for the client. Have the client wear insulated socks. Tell the client to never apply direct heat to the affected extremity, as sensitivity is decreased and she may be inadvertently burned. Instruct the client to avoid exposure to cold causes vasoconstriction and decrease arterial flow. Instruct the client to avoid stress, caffeine, and nicotine, which also cause vasoconstriction. Complete abstinence from smoking or chewing tobacco is the most effective method of preventing vasoconstriction. Vasoconstrictive effects last up to 1 hour after each cigarette smoked. Medications. Antiplatelet medications. Aspirin. Plavix. Trentol. Antiplatelet medications reduce blood viscosity by decreasing blood fibrinogen levels, enhancing erythrocyte flexibility, and increasing blood flow in the extremities. Medications such as aspirin, Plavix may be prescribed. Trentol, sometimes referred to as a hemorrhagic medication, was one of the first to be used and is still used today, but less commonly than the other medications. It may be given to specifically treat intermittent claudication experienced by clients who have PAD. Nursing considerations. Give medication with meals. Client education. Inform the client that the medication's effect might not be apparent for several weeks. Advise the client to monitor for signs of bleeding such as abdominal pain, coffee ground emesis, or black tarry stools. Surgical interventions. Surgical procedures for peripheral arterial disease. Percutaneous transluminal angioplasty. It's an invasive intra-arterial procedure. Use a balloon and stent to open and help maintain the patency of the vessel. It is used for candidates who are not suitable for surgery or in cases where amputation is inevitable. Laser-assisted angioplasty. Laser-assisted angioplasty is an invasive procedure where a laser probe is advanced through a cannula to the site of stenosis. The laser is used to vaporize atherosclerotic plaque and open the artery. Nursing actions. The priority for postoperative care is observing for bleeding at the puncture site. That's the priority. And closely monitor the client's vital signs, peripheral pulses, and capillary refill. If prescribed, keep the client on bed rest with this limb straight for 6 to 8 hours before ambulation. Anticoagulant therapy is used during the operative procedure, followed by antiplatelet therapy for 1 to 3 months. Arterial vascularization surgery is used with clients who have severe claudication and or limb pain at rest, or with clients who are at risk for losing a limb due to poor arterial circulation. Bypass grafts are used to reroute the circulation around the arterial occlusion. Grafts can be harvested from the client autologous or made from synthetic materials. Nursing actions. The priority for postoperative care is to maintain adequate circulation in the repaired artery. The location of the pedal or dorsalis pulse should be marked and its pulsatile strength compared with the contralateral leg on a scheduled basis using a Doppler. Color, temperature, and cap refill should also be compared with the contralateral extremity on a scheduled basis. Warmth, redness, possibly edema of the affected limb should be present as a result of increased blood flow. Monitor the client for pain. Pain may be severe due to the reestablishment of blood flow to the extremity. Ow. Monitor the client's blood pressure for hypotension or hypertension. Hypotension may result in an increased risk of clotting or graft collapse, while hypertension increases the risk for bleeding from sutures. Instruct the client to limit bending of the hip and knee to decrease the risk of clot formation. Client education. Instruct the client to avoid crossing his legs or raising his legs above the level of the heart. Instruct the client to wear loose clothing. Instruct the client on wound care if revascularization surgery was done. Discourage smoking and cold temperatures with the client. Instruct the client about foot care. Keep feet clean and dry. Wear good fitting shoes. Never go barefoot. Cut toenails straight across and have the podiatrist cut nails. Or have the podiatrist cut your nails. Client outcomes. The client's extremity distal to the repaired occlusion will be warm, pink, and have 2+ pulse. The client will report being able to walk without pain in the affected leg. Complications. Graft occlusion. Graft occlusion is a serious complication of arterial revascularization and often occurs within the first 24 hours following surgery. Nursing actions. Promptly notify the surgeon of signs and symptoms of occlusion, such as absent or reduced pedal pulses, increased pain, change in extremity color, or temperature. Be prepared to assist with treatment, which may include an emergency thrombectomy, removal of a clot, local intra-arterial thrombolytic therapy with an agent such as tissue plasminogen activator, infusion of a platelet inhibitor, or a combination of the above. With these treatments, closely assess the client for manifestations of bleeding. Compartment syndrome. Compartment syndrome is considered a medical emergency. Tissue pressure within a confined body space can restrict blood flow, and the resulting ischemia can lead to irreversible tissue damage. Symptoms of compartment syndrome include tingling, numbness, worsening pain, edema, pain on passive movement, and unequal pulses. Immediately report symptoms to the provider. Loosen dressings. Be prepared to assist with fasciotomy or surgical opening into the tissues, which may be necessary to prevent further injury and to save the limb. Now, peripheral venous disorders. Overview. Peripheral venous disorders are problems with the veins that interfere with adequate return of blood flow from the extremities. There are superficial and deep veins in the lower extremities that have valves that prevent backflow of blood as it returns to the heart. The action of the skeletal muscles of the lower extremities during walking and other activities also promotes venous return. 3 peripheral venous disorders that nurses should be familiar with are venous thromboembolism, or VTE, and venous insufficiency in varicose veins. VTE is a blood clot believed to form as a result of venous stasis, endothelial injury, or hypocoagulability. Thrombus formation can lead to a pulmonary embolism, a life-threatening complication. Thrombophlebitis refers to a thrombus that is associated with inflammation. Venous insufficiency occurs secondary to incompetent valves in the deeper veins of the lower extremities, which allows pooling of blood and dilation of the veins. The veins' inability to carry fluid and wastes from the lower extremities precipitates the development of swelling, venous stasis ulcers, and in advanced cases, cellulitis. Varicose veins are enlarged, twisted, and superficial veins that may occur in any part of the body. However, they are commonly observed in the lower extremities and in the esophagus. Assessment. Risk factors. Venous thromboembolism. Hip surgery, total knee replacement, open prostate surgery. Heart failure, immobility, pregnancy, and oral contraceptives. That's risk factors. Venous thromboembolism. Venous insufficiency. Risk factors: sitting or standing in one position for a long period of time, obesity, pregnancy, thrombophlebitis. And varicose veins: older than 30 years with an occupation requiring prolonged standing, pregnancy, obesity, systemic diseases like heart disease, family history. Subjective data: limb pain, aching and feeling of fullness or heaviness in the legs after standing. Objective data: physical assessment findings: deep vein thrombosis, or DVT, and thrombophlebitis. In DVT and thrombophlebitis, the client can become asymptomatic. Classic signs of DVT and thrombophlebitis are calf or groin pain, or tenderness and a sudden onset of swelling of the legs. Palpate the site for warmth, edema, and induration, and hardness over the involved blood vessel. Examine the area and compare it to the contralateral limb. Measure, record, and compare the right and left calf and high circumference for changes over time. Observe for a localized edema. Monitor the client for shortness of breath and chest pain, which can indicate that the embolus has moved to the lungs, pulmonary embolism. Venous insufficiency. Stasis dermatitis is a brown discoloration along the ankles that extends up the calf relative to the level of insufficiency. So, starts at the ankle, moves up the calf, brown discoloration. Edema. Stasis ulcers, typically found around the ankles. Varicose veins. Distended superficial veins that are visible just below the skin and are tortuous in nature. Ooh, they're torturous. Ow. Laboratory tests. A D-dimer test measures fibrin degradation products present in the blood produced from fibrinolysis. A positive D-dimer test indicates the presence of these products in a client's body, which indicates that thrombus formation has possibly occurred. Diagnostic procedures: DVT and thrombophlebitis. Venous duplex ultrasonography uses high-frequency sound waves to provide a real-time picture of the blood flow through a blood vessel. Impedance plethysmography can be used to determine the variations of blood passing through a vein, thus identifying abnormal venous flow in the affected limb. If the above tests are negative for DVT, but one is still suspected, a venogram, which uses contrast material, may be needed for accurate diagnosis. Varicose veins, the Trendelenburg test. The Trendelenburg test assists with the diagnosis of various veins. Okay, nursing actions. Place the client in a supine position with legs elevated. When the client sits up, the veins will fill from the proximal end to the varicosities. And if varicosities are present, veins normally fill from the distal end. Okay, so if they fill from the proximal end, varicosities are present. Collaborative care, nursing care, DVT and thrombophlebitis. Encourage the client to rest. Facilitate bed rest in the client and elevation of the extremity above the level of the heart is as prescribed. Avoid using a knee gauge or pillow under knees. Administer intermittent or continuous warm, moist compresses to the client as prescribed. To prevent thrombus from dislodging and becoming an embolus, do not manage the affected limb. Provide thigh-high compression or anti-embolism stockings as prescribed to reduce venous stasis and to assist in venous return of blood to the heart. Prepare the client for an inferior vena cava interruption surgery. A filter traps emboli and prevents them from reaching the heart, is as indicated. Venous insufficiency. Ensure that the client elevates his legs several times a day for at least 15 to 30 minutes. The client should elevate his feet approximately 6 inches at night. The client should avoid crossing his legs and wearing constrictive clothing or stockings. The client should wear elastic compression stockings and apply them after he has elevated his legs and when swelling is at a minimum. Medications: DVT and thrombophlebitis anticoagulants. Unfractionated heparin is given IV to prevent formation of other clots and to prevent enlargement of the existing clot. It has significant side effects and must be given in the facility. Prior to discharge, the client will be converted over to oral anticoagulation therapy with warfarin or Coumadin. Nursing actions: monitor APTT to allow for adjustments of heparin dosage. Monitor platelet counts for heparin-induced thrombocytopenia, and ensure that protamine sulfate, the antidote for heparin, is available if needed for excessive bleeding. Monitor for hazards and side effects associated with anticoagulant therapy. Low molecular weight heparin is given subcutaneously and is based on a client's weight. Lovenox is used for the prevention and treatment of DVT. It is given in the facility, but the twice-daily injections can be given in the home setting if adequate medical support is available. Nursing actions: ensure that protamine sulfate, the antidote for heparin, is available if needed for excessive bleeding. Instruct the client to observe for signs of bleeding. Instruct the client on bleeding precautions that should be taken. Use electric instead of bladed razor and brush teeth with soft toothbrush. Warfarin inhibits synthesis of the 4 vitamin K-dependent clotting factors. The therapeutic effect takes 3 to 4 days to develop, so it is usually begun while the client is still on heparin. Nursing actions: monitor the client for bleeding. Monitor the client's PT and INR. Ensure that vitamin K, the antidote for warfarin, is available in case of excessive bleeding. Instruct the client about which signs of bleeding to look for. Instruct the client on bleeding precautions that should be taken. Use electric instead of bladed razor and brush teeth with soft toothbrush. DVT and thrombophlebitis. Thrombolytic therapy. Thrombolytic therapy dissolves clots that have already developed. The therapy must be started within 5 days after the development of the clot for the therapy to be effective. Tissue plasminogen activator, a thrombolytic agent, and platelet inhibitors such as Riopro and Integralin can be effective in dissolving a clot or preventing new clots during the first 24 hours. Giving the medication in a manner that provides direct contact with the thrombus can be more effective and lessen the chance of bleeding. Nursing actions. Monitor the client for bleeding, intracerebral bleeding. Instruct the client about bleeding precautions that should be taken. Use electric razor, soft toothbrush. Interdisciplinary care. Venous insufficiency. Care of venous stasis ulcers requires long-term management. Consultation with a dietitian and wound care specialist will facilitate the healing process. Therapeutic procedures. Varicose veins. Sclerotherapy. A sclerosing, irritating chemical solution is injected into the varicose vein to produce localized inflammation, which will, over time, close the lumen of the vessel. For larger vessels, an incision and drainage of the trapped blood in a sclerosed vein may need to be performed 2 to 3 weeks after the injection. Pressure dressings are applied for approximately 1 week after each procedure to keep the vessel free of blood. Ooh. Client education. Instruct the client to wear elastic stockings for prescribed time. Mild analgesics such as Tylenol can be taken for discomfort. Surgical intervention. Varicose veins, vein stripping. Vein stripping is the removal of large varicose veins that cannot be treated with less invasive procedures. Nursing actions. Vein stripping. Okay. Nursing actions. Preoperatively. Assist the provider with vein marking. Evaluate the client's pulses as baseline for postoperative comparison. Postoperatively, maintain elastic bandages on the client's legs. Monitor the client's groin and leg for bleeding through the elastic bandages. Monitor the client's extremity for edema, warmth, color, and pulses. Elevate the client's legs above the level of his heart. Encourage the client to engage in range of motion exercises of the legs. Instruct the client to elevate his legs when sitting and avoid dangling them over the side of the bed. Client education. Emphasize the importance of wearing elastic stockings after bandage removal. Varicose veins. Endovenous laser treatment. This type of treatment uses a laser fiber that is inserted into the vessel proximal to the area to be treated and then threaded to the involved area where heat from the laser is used to close the dilated vein. Varicose veins. Application of radiofrequency energy. This type of treatment uses a small catheter with a radiofrequency electrode instead of a laser that is inserted into the vessel proximal to the area to be treated that scars and closes a dilated vessel, or vein, not vessel, vein. Client outcome. The client's lower extremities will be warm, pink, and free of pain. Complications. Ulcer formation. Venous stasis ulcers often form over the medial malleus. Venous ulcers are chronic, hard to heal, and often recur. They can lead to amputation and or death. Clients who also have neuropathy may not feel as much discomfort from the ulcer as its appearance may warrant. Nursing actions. Apply often oxygen-permeable polyethylene films to superficial ulcers. Apply occlusive hydrocolloid dressings on deeper ulcers to promote granulation tissue and reepithelialization. Leave a dressing on for 3 to 5 days. If wound needs chemical debridement, apply prescribed topical enzymatic agents to debride the ulcer, eliminate necrotic tissue, and promote healing. Administer systemic antibiotics as prescribed. Client education. Recommend to the client a diet high in zinc, protein, and vitamin A and C. Pulmonary embolism. A pulmonary embolism recurs when a thrombus is dislodged, becomes an embolus, and lodges in a pulmonary vessel This can lead to obstruction of pulmonary blood flow, decreased systemic oxygenation, pulmonary tissue hypoxia, and possible death. Nursing actions for pulmonary embolism. Symptoms include sudden onset dyspnea, pleuritic chest pain, restlessness and apprehension, feelings of impending doom, cough, and hemoptysis. Signs include tachypnea, crackles, pleural friction rub, tachycardia, S3 or S4 heart sounds, diaphoresis, low-grade fever, petechiae over chest and axillae, and decreased arterial oxygen saturation. Notify the provider immediately, reassure the client, and assist him to a position of comfort with the head of the bed elevated. Prepare for oxygen therapy and blood gas analysis while continuing to monitor and assess the client for other manifestations. Okay, application exercises. Application exercises, answer key. A nurse performing an assessment with a client who has chronic peripheral arterial disease, PAD, should expect to find its pallor on elevation of limbs and rubor when limbs are dependent. Rubor, I believe, is red, and white when they're elevated, red when they are dependent. Findings depend on the severity of PAD. Observe the client for loss of hair on his lower calf, ankle, and foot, dry if his skin is scaly, dusky, pale, or mottled, and whether his toenails are thickened. If the disease is severe, the client's extremity will be cold and gray, blue, cyanotic, or darkened. In chronic disease, pallor may occur when the client's extremity is elevated. Dependent rubor may occur when the extremity is lowered. Muscle atrophy can accompany prolonged chronic arterial disease. Edema around the ankles and feet, ulceration around the medial malleoli, and scaling eczema of the lower legs with stasis dermatitis are seen with venous stasis. Okay. Chronic PAD is pallor on elevation of limbs and rubor when limbs are dependent. Okay, a nurse is caring for a client who has severe peripheral arterial disease, PAD. The nurse should expect that the client will sleep most comfortably in which position? With affected limb hanging from the bed, with the affected limb elevated on pillows, with the head of the bed raised in a side-lying recumbent position, and it's with the affected limb hanging from the bed. Clients who have severe PAD may find comfort with the affected limb in a dependent position. The other positions will not promote circulation in the lower extremities. A nurse is caring for a client who has chronic venous insufficiency. The provider prescribed thigh compression stockings. The nurse should instruct the client to massage both legs firmly with lotion prior to applying the stockings. Apply the stockings in the morning upon awakening and before getting out of bed. Roll the stockings down to the knees if they want to stay up on the thighs. If they will not stay up on the thighs, remove the stockings while out of bed for 1 hour, 4 times a day to allow the legs to rest. And it's B. Apply the stockings in the morning upon awakening and before getting out of bed. Applying stockings in the morning upon awakening and before getting out of bed reduces venous stasis and assists the venous return of blood to the heart. Legs are less edematous at this time. Massaging the affected areas can dislodge a clot and cause embolism. Rolling stockings down can restrict circulation and cause edema. Stockings should be removed at night before going to bed. A nurse is caring for a client who has deep vein thrombosis and has been taking unfractured heparin for 1 week. The client's condition is improving. 2 days ago, the primary care provider also prescribed warfarin. The client questions the nurse about receiving both heparin and warfarin at the same time. Which of the following responses is appropriate for the nurse to give to the client? A. Your provider must have forgotten that you were already taking heparin. I will remind her. B. Your blood was so thick that 2 anticoagulants were needed. C. Warfarin takes 3 to 4 days to achieve therapeutic anticoagulant effects. Heparin will be discontinued soon. D. Only one of the medications is being given to treat your deep vein thrombosis. And it's C. Warfarin takes 3 to 4 days to achieve therapeutic anticoagulant effects because it depresses synthesis of clotting factors, but does not have any effect on clotting factors that are already present. Effects are delayed until the clotting factors that are present decay. Okay, on to the greatest and best disease in the world, hypertension, Chapter 40. Nursing care of clients with cardiovascular disorders, Chapter 40, hypertension. Overview. Hypertension occurs with systolic blood pressure as at or above 140 mmHg, or diastolic blood pressure is at or above 90 mmHg. The normal adult blood pressure is less than 120 over 80. Essential hypertension, also called primary hypertension, accounts for most cases of hypertension. There is no known cause. Secondary hypertension can be caused by certain disease states, such as renal disease, or a side effect of some medications. Secondary hypertension can be treated by removing the cause, adrenal tumor, medications. Blood pressure is regulated by 4 bodily mechanisms: arterial baroreceptors, regulation of body fluid volume, renin-angiotensin system, and vascular autoregulation. So arterial baroreceptors are located in the carotid sinus, aorta, and left ventricle. They control blood pressure by altering the heart rate and or causing vasoconstriction or vasodilation. Regulation of body fluid volume, that would be properly functioning kidneys either retain fluid when the client is hypotensive or excrete fluid when the client is hypertensive. Renin-angiotensin system. Angiotensin II vasoconstricts and controls aldosterone release, which causes the kidneys to reabsorb sodium and inhibit fluid loss. Vascular autoregulation. This maintains consistent levels of tissue perfusion. Clients who have a systolic blood pressure of 120 to 139 or a diastolic blood pressure of 80 to 89 are considered pre-hypertensive. Lifestyle changes are needed for these clients to help prevent cardiovascular disease. Prolonged, untreated, or poorly controlled hypertension can cause peripheral vascular disease, PVD, especially affecting the heart, brain, eyes, and kidneys. The risk of developing complications increases as blood pressure increases. Hypertrophy of the left ventricle can develop as the heart pumps against resistance caused by hypertension. Health promotion and disease prevention. The client should maintain a body mass index of less than 30. Clients who have diabetes mellitus should keep blood glucose within a recommended reference range. Clients should limit caffeine and alcohol intake. Clients should use stress management techniques during times of stress. Clients should stop smoking nicotine patches or engaging in a smoking cessation class may be indicated. The client should engage in exercise that provides aerobic benefits at least 3 times a week. Assessment. Risk factors. Essential hypertension, positive family history, excessive sodium intake, physical inactivity, obesity, high alcohol consumption, African American, smoking, hyperlipidemia, and stress. Secondary hypertension, renal disease, Cushing's disease, excessive glucocorticoid secretion. Primary aldosteronism causes hypertension and hypokalemia. Pheochromocytoma, excessive catecholamine release, brain tumors, encephalitis. Medications such as estrogen, steroids, and symphomimetics. Subjective data. Clients have hypertension can experience few or no symptoms. The nurse should monitor for headaches, particularly in the morning, dizziness, fainting, retinal changes, visual disturbances, nocturia. Objective data. Physical assessment findings. When a blood pressure reading is elevated, it should be taken in both arms and with the client sitting and standing. There are several levels of hypertension as defined by the Joint National Committee of Prevention, Detection, Evaluation, and Treatment of High Blood Pressure. Prehypertension, 120 over 39, 120 to 139, systolic, dystolic, 80 to 89. Stage 1 is 140 to 159, dystolic 90 to 99, and stage 2 hypertension, systolic greater than or equal to 160, dystolic greater than or equal to 100. That's me. Laboratory tests. No laboratory test exists to diagnose hypertension. However, several laboratory tests can identify the causes of secondary hypertension and target organ damage. Bun creatinine elevation indicative. Box elderbug on me. Okay. Bun creatinine elevation indicative of renal disease. Elevated serum corticoids to detect Cushing's disease. Blood glucose and cholesterol studies can identify contributing factors related to blood vessel changes. Diagnostic procedures. An ECG is used to evaluate cardiac function. Tall R waves are often seen with left ventricle hypertrophy. A chest X-ray may show cardiomegaly. Collaborative care, nursing care. Discuss factors with the client that increase the risk of hypertension and how they can be managed. Medications. Medications that are added to treat hypertension are not responsive to lifestyle changes alone. Diuretics are often used as the first-line medication. However, clients can require a combination of medications to control hypertension. Clients who are taking antihypertensives should be instructed to change positions slowly. Be careful when getting out of bed, driving, and climbing stairs until the medication's effects are fully known. Diuretics. Thiazide diuretics such as hydrochlorothiazide or hydrodiryl inhibit water and sodium reabsorption and increase potassium excretion. Other diuretics may be used to treat hypertension not responsive to the thiazide diuretics. Loop diuretics, such as furosemide or Lasix, decrease sodium reabsorption and increase potassium excretion. Monitor the client closely for hypokalemia. Potassium-sparing diuretics, such as spirulactone or aldactone, affect the distal tubule and prevents reabsorption of sodium in exchange for potassium. Monitor the client closely for hyperkalemia. Nursing considerations. Monitor the client's potassium levels and watch for muscle weakness, irregular pulse, and dehydration. Thiazide and loop diuretics can cause hypokalemia, and potassium-sparing diuretics can cause hyperkalemia. Education for the client. Encourage the client to keep all appointments with the provider to monitor efficacy of pharmacologic treatment and possible electrolyte imbalances, hyponatremia, and hyperkalemia. If the client is taking a potassium depleting diuretic, encourage consumption of potassium-rich foods such as bananas. Calcium channel blockers. Verapamil hydrochloride or Calon, amlodipine, Norvasc, and cardizem alter the movement of calcium ions through the cell membrane, causing vasodilation and lowering blood pressure. Nursing considerations. Monitor the client's blood pressure and pulse and change the client's position slowly. Hypotension is a common side effect. Common side effect of calcium channel blockers. Okay. Calcium channel blockers should be used cautiously with clients who have heart failure. Client education. Constipation can occur with verapamil hydrochloride, so encourage intake of foods with high fiber. Decreased or increased heart rate and atrioventricular AV block can occur, so teach the client how to take her pulse and call the provider if the pulse is irregular or lower than established rate. Instruct the client to avoid grapefruit juice, which potentiates the medication's effects, increases hypotensive effects, and increases the risk of medication toxicity. Angiotensin converting enzyme, ACE inhibitors. ACE inhibitors prevent the conversion of angiotensin 1 to angiotensin 2, which prevents vasoconstriction. Nursing considerations. Monitor the client's blood pressure and pulse. Hypotension is a common side effect. Monitor the client for signs of heart failure, such as edema. The medication may cause heart and renal complications. Client education. Teach the client to report a cough, which is a side effect of ACE inhibitors. The client should notify the provider of this side effect, as the medication can be discontinued due to its persistent nature and occasional relationship to angioedema, which is swelling of the tissues in the throat that can progress to a life-threatening obstruction. Teach the client to report signs of heart failure or edema. Report edema with the ACE inhibitors. It's heart failure. Angiotensin 2 receptor antagonists, also called angiotensin receptor blockers, or ARBs. These medications, such as candesartan or Atacand, losartan, Cozar, and telmisartan, Micardis, are a good option for clients taking ACE inhibitors who report cough and those who have hyperkalemia. Also, ARBs do not require a dosage adjustment for older adult clients. Nursing considerations. Monitor the client for signs of angioedema or of heart failure. Angioedema is a serious but uncommon adverse effect, and heart failure can result from taking this medication. Client education. Teach client to change position slowly. Teach client to report signs of angioedema, which are swollen lips or face, or heart failure, which would be edema. Aldosterone receptor antagonists. Aldosterone receptor antagonists, such as eplerenone or Inspra, block aldosterone action. The blocking effect of eplerenone on aldosterone receptors promotes the retention of potassium and excretion of sodium and water. Nursing considerations. Monitor the client's renal function, triglycerides, sodium, and potassium levels. The risk of adverse effects increases with deteriorating renal function. Triglyceridemia, hyponatremia, and hyperkalemia can occur as dose increases. Monitor the client's potassium levels every 2 weeks for the first few months and every 2 months thereafter. Do not give the client potassium supplements or potassium-sparing diuretics. Client education. Teach the client about potential medications and herbal interactions. Grapefruit juice and St. John's wort can increase adverse effects. Instruct the client not to take salt substitutes with potassium or other foods that are rich in potassium. We're talking about Inspra right now. Beta blockers. Beta blockers, such as metoprolol, Lopressor, and atenolol, Tenormin, are indicated for clients who have unstable angina or MI. They decrease cardiac output and block the release of renin, subsequently decreasing vasoconstriction of the peripheral vasculature. Nursing considerations. Monitor the client's blood pressure and pulse. These medications can mask hypoglycemia in patients who have diabetes mellitus. Client education. Teach the client that these medications may cause fatigue, weakness, depression, and sexual dysfunction. Advise the client not to suddenly stop taking the medication without consulting with the provider. Stopping suddenly can cause rebound hypertension. Teach the client symptoms of hypoglycemia that do not include tachycardia, which is suppressed with beta blockers. Okay, central alpha agonists. Central alpha agonists, such as clonidine or catapres, reduce peripheral vascular resistance and decrease blood pressure by inhibiting the reuptake of norepinephrine. Nursing considerations. Monitor the client's blood pressure and pulse. This medication is not indicated for first-line management of hypertension. Client education. Teach the client that side effects include sedation, orthostatic hypertension, and impotence. Alpha-adrenergic antagonists. Alpha-adrenergic antagonists, such as prazosin or Minipress, reduce blood pressure by causing vasodilation. Nursing considerations: start treatment with a low dose of medication. Give the client the first dose at night and monitor blood pressure for 2 hours after initiation of treatment. Client education: advise the client to rise slowly to prevent postural hypertension and hypotension. Tell the client to use caution when driving until the effects of the medication are known. Care after discharge: express to the client and family the importance of adhering to the medication regimen, even if the client is asymptomatic. This is for all of them, I believe. Yeah. Express to the client and family the importance of adhering to the medication regimen, even if the client is asymptomatic. Provide verbal and written education to the client regarding medications and their side effects. Ensure that the client has the resources necessary to pay for and obtain prescribed antihypertensive medication. Encourage the client to schedule regular provider appointments to monitor hypertension and cardiovascular status. If the client has blood pressure that is difficult to manage, teach the client or a significant other how to take their blood pressure. Encourage the client to report symptoms or side effects, as they may be indicative of additional problems. Medications can often be changed to alleviate side effects. Older adult clients are more likely to experience medication interactions. Older adult clients are more likely to experience orthostatic hypotension. Treatment involves the client making lifestyle changes. Sodium restriction: monitor potassium with salt substitute use. Consume less than 2.3 grams a day of sodium. Weight reduction: consume a diet low in fat, saturated fat, and cholesterol. Control alcohol intake: 2 ounces of liquor, 8 ounces of wine, and 24 ounces of beer per day. Exercise: begin slowly and gradually advance the program with the guidance of the primary care provider and physical therapist. Exercise at least 3 times a week in a manner that provides aerobic benefits. Smoking cessation: smoking is not directly linked to hypertension, but it should be avoided due to its high association with the development of cardiovascular diseases. Stress reduction: encourage the client to try yoga, massage, hypnosis, or other forms of relaxation. Client outcomes: the client's blood pressure will be maintained with a systolic pressure less than 140 and a diastolic less than 90. The client will be able to verbalize proper administration of medications and side effects that should be reported to the provider. The client will not report side effects such as postural hypertension, dizziness, weakness, or fatigue. Complications: hypertensive crisis. Hypertensive crisis often occurs when the clients do not follow the medication's therapy regimen. Nursing actions: recognize signs and symptoms: severe headache, extremely high blood pressure, generally systolic blood pressure greater than 240, diastolic greater than 120. Blurred vision, dizziness and disorientation, epistaxis. Administer IV antihypertensive therapies such as nitroprusside or nipride, nicardipine or cardine IV, and labetalol or normidine. Before, during, and after administration of IV antihypertensive, closely monitor blood pressure every 5 to 15 minutes as prescribed. Assess the client's neurological status, such as pupils, level of consciousness, and muscle strength, frequently to monitor for cerebral vascular change. Monitor for ECG to assess the client's cardiac status. Okay, hypertension application exercises. Which of the following practices should be avoided by client who are predisposed to or have hypertension? Select all apply. Drinking 8 ounces of non-fat milk daily, eating popcorn at the movie theater, walking 1 mile daily at 12 minutes a mile pace, consuming 36 ounces of beer daily, or smoking a pipe. It's eating popcorn, consuming 36 ounces of beer, and smoking a pipe. Popcorn at a movie theater contains a large amount of sodium fat, which should be limited for a client who has hypertension. Consuming more than 24 ounces of beer per day can contribute to weight gain. Smoking causes vasoconstriction, which can increase the client's blood pressure. Clients should consume low-fat foods and beverages and engage in regular exercise. A nurse is caring for a client who is diagnosed with hypertension and prescribed spirulactone, aldactone, 25 milligrams a day. Which of the following statements by the client indicates a need for further teaching? I should eat a lot of fruits and vegetables, especially bananas and potatoes. Yeah, that's not the one. Okay, that's the one. Potatoes and bananas are high in potassium, and spironolactone is a potassium-sparing diuretic. Consuming these foods can lead to hyperkalemia. The client should report any changes in heart rate or rhythm. Use salt substitutes that are low in potassium to prevent hyperkalemia. And know to continue taking the medication even if symptoms are gone. A nurse is caring for a client who is admitted to the emergency department with a blood pressure of 266 over 147. The client reports headache and states she is seeing double. The client states that she ran out of her cardizem or her dilatzem 3 days ago, and she has not been able to purchase more. Which of the following nursing interventions should the nurse expect to perform? And administer acetaminophen for headache, provide teaching in regard to the importance of not abruptly stopping antihypertensives, obtain IV access and prepare to administer an IV hypertensive, call social service for referral for financial assistance in obtaining prescribed medication. It's obtain IV access, prepare to administration because it's a hypertensive crisis. The greatest risk to the client is injury due to blood pressure 266 over 147, which can be life-threatening. The highest priority is to decrease the client's blood pressure as quickly as possible. An IV should be started for IV access. Medications given by the IV route will be absorbed and distributed much faster than the oral route. Administering acetaminophen for headache, providing teaching, blah, 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 is not right. Good. It's good, but not now. Okay. Nurse is providing discharge teaching for a client who has a prescription for furosemide Lasix, 40 milligrams by mouth per day. What time of day should the client be encouraged to take this medication? Morning, lunch, immediately after lunch, immediately before lunch, or bedtime? And it's morning. The client should take the furosemide in the morning so that the peak action and duration of the medication occurs during waking hours. All other times may increase the likelihood of interrupting the client's sleep with the need to urine. Okay, I'm not gonna read all of the heart failure and pulmonary edema. I'll probably just get to the whole left-right thing and go from there. So, overview: heart failure occurs when the heart muscle is unable to pump effectively, resulting in inadequate cardiac output, myocardial hypertrophy, and pulmonary systemic congestion. The heart is unable to maintain adequate circulation to meet tissue needs. Heart failure is the result of an acute or chronic cardiopulmonary problem such as systemic hypertension, myocardial infarction (MI), pulmonary hypertension, dysrhythmias, valvular heart disease, pericarditis, and cardiomyopathy. Pulmonary edema is a severe life-threatening accumulation of fluid in the alveoli and interstitial spaces of the lung that can result from severe heart failure. Overview: the severity of heart failure is graded on the New York Heart Association's functional classification scale, indicating how little or how much activity it takes to make the client symptomatic: chest pain or shortness of breath. Class 1, client exhibits no symptoms with activity. Class 2, client has symptoms with ordinary exertion. Class 3, client displays symptoms with minimal exertion. Class 4, client has symptoms at rest. Low output heart failure can initially occur on either the left or right side of the heart. Left-sided ventricular failure results in the inadequate left ventricle cardiac output and consequently inadequate tissue perfusion. Forms include systolic heart or ventricular failure, ejection fraction below 40%, pulmonary and systemic congestion, and systolic heart ventricular failure, inadequate relaxation or stiffening prevents ventricular filling. Right-sided heart or ventricular failure results in inadequate right ventricle output and systemic venous congestion and peripheral edema. So left side lungs, right side peripheral. An uncommon form of heart failure is high output failure, in which cardiac output is normal or above normal. Health promotion and disease prevention. Maintain an exercise routine to remain physically active and consult a provider before starting any exercise regimen. Consume a diet low in sodium along with fluid restrictions and consult with the provider regarding diet specifications. Refrain from smoking. Follow a medication regimen and follow up with the provider as needed. Assessment. Risk factors. Left-sided heart failure or left-sided ventricular failure, hypertension, coronary artery disease, angina, MI, valvular disease, mitral and aortic. Right-sided failure is left-sided heart. These are the risk factors. So right-sided heart failure risk factor is left-sided heart failure. Right ventricular MI, pulmonary problems like COPD and ARDS. High output heart failure, increased metabolic needs. Septicemia or fever, anemia, and hyperthyroidism. Cardiomyopathy would be coronary artery disease, infection or inflammation of the heart muscle, various cancer treatments, prolonged alcohol abuse, and heredity. Systolic blood pressure is elevated in older adults, putting them at risk for coronary artery disease and heart failure. Subjective objective data. Left-sided failure, dyspnea, orthopnea or shortness of breath while lying down, nocturnal dyspnea, fatigue, displaced apical pulse or hypertrophy, S3 heart sound, it's a gallop, pulmonary congestion, dyspnea, cough, bibicillary crackles, frothy sputum can be blood tinged, altered mental status, symptoms of organ failure such as oliguria, decrease in urine output. That's all left-sided subjective and objective. Now right-sided subjective and objective. Jugular vein distension, ascending dependent edema, legs, ankles, and sacrum. Abdominal distension, acidez, fatigue, weakness, nausea, and anorexia. Polyuria at rest, nocturnal. Liver enlargement, hepatomegaly, and tenderness. Weight gain. Then for, I think that's all I wanted to read out of this. Medications, you have the diuretics and inotropic agents such as digoxin, dopamine, dobutamine or Dobutrex, and Primacor are used to increase contractility and thereby improve cardiac output. Nursing considerations for a client taking digoxin: take the apical heart rate every minute or for a full minute. Hold the medication if apical pulse is less than 60. Notify the provider. Observe the client for nausea and vomiting. Dopamine, dobutamine, and melanin are administered via IV. The ECG, blood pressure, and urine output must be closely monitored. Teach clients who are self-administering digoxin to count pulse for a minute. If pulse rate 60 outside limits set by the provider, usually less than 60 or greater than 100, instruct the client to hold the dose and to contact the provider. Take digoxin at the same time every day. Do not take digoxin at the same time as antacids. Separate the two medications by at least 2 hours. Report signs of toxicity, including fatigue, muscle weakness, confusion, and loss of appetite. Regularly have digoxin and potassium levels checked. Then you have vasodilators for angina. Yeah, you got nitroglycerine, human B-type natremic peptides, anticoagulants also can help, such as warfarin. Can be prescribed if the client has a history of thrombus formation. Surgical interventions. Ventricular assist device, a VAD. A VAD is a mechanical pump that assists the heart that is too weak to pump blood through the body. A VAD is used in clients who are eligible for heart transplants or who have severe end-stage heart failure and are not candidates for heart transplants. Heart transplantation is the treatment of choice for clients who have severe dilated cardiomyopathy. And then a little bit about pulmonary edema. Cardiogenic factors are the most common cause of pulmonary edema. It is a complication of various heart and lung diseases and usually occurs from increased pulmonary vascular pressure secondary to severe cardiac dysfunction. Non-cardiac pulmonary edema can occur due to barbiturate or opiate overdose, inhalation of irritating gases, rapid administration of IV fluids, and after pneumonectomy, evacuation, or pleural effusion. Neurogenic pulmonary edema develops following a head injury. For older adults, increased risk of pulmonary edema occurs related to decreased cardiac output and congestive heart failure. Increased risk for fluid and electrolyte imbalance occurs when the older adult client receives treatment with diuretics. For older adults, IV infusions must be administered at a slower rate to prevent circulatory overload. Basically, same thing. Exercise, diet, no smoking, regimen. Follow the regimen. And that's it for that. It's pretty much the same drugs. Alright, Unit 8, let's learn about some respiratory diseases. Asthma. Overview. Asthma is a chronic inflammatory disorder of the airways that results in intermittent and reversible airflow obstruction of the bronchioles. The obstruction occurs either by inflammation or airway hyperresponsiveness. Asthma can occur at any age. The cause of asthma is unknown. Manifestations of asthma: mucosal edema, bronchoconstriction, excessive mucus production. Asthma diagnoses are based on symptoms and classified into one of the following 4 categories. Mild intermittent, symptoms occur less than twice a week. Mild persistent, which is symptoms arise more than twice a week but not daily. Moderate persistent, daily symptoms occur in conjunction with exacerbation twice a week. Severe persistent, symptoms occur continually along with frequent exacerbations that limit the client's physical activity and quality of life. Health promotion and disease prevention. If the client smokes, promote smoking cessation. Advise the client to use protective equipment, mask, and ensure proper ventilation while working in environments that contain carcinogens or particular particles in the air. Encourage influenza and pneumonia vaccinations for all clients who have asthma, and especially for the older adult. Instruct the client how to recognize and avoid triggering agents, such as environmental factors such as changes in temperature, especially warm to cold, and humidity, air pollutants, strong odors, perfume, seasonal allergens, grass, tree, and weed pollens, and perennial allergens, mold, feathers, dust, roaches, animal dander, foods treated with sulfites. Stress and emotional distress. Medication: aspirin, NSAIDs, beta blockers, cholinergics, enzymes, including those in laundry detergents, chemicals, household cleaners, sinusitis with postnasal drip, viral respiration tract infections. Instruct the client how to properly self-administer medications, nebulizers, and inhalers. Educate the client regarding infection prevention techniques. Encourage regular exercise as part of asthma therapy that promotes ventilation and perfusion, maintains cardiac health, and enhances skeletal muscle strength. Also, clients may require pre-medication. Assessment. Risk factors. Older adult clients have decreased pulmonary reserves due to physiologic lung changes that occur with the aging process. Older adult clients are more susceptible to infections. The sensitivity of beta adrenergic receptors decreases with age. As the beta receptors age and lose sensitivity, they are less able to respond to agonists, which can result in bronchospasms. Clients who have mild to moderate asthma can experience few or no symptoms between asthma attacks. During attacks, monitor for signs and symptoms. Subjective data: dyspnea, chest tightness, anxiety or stress. Objective data: physical assessment findings: coughing, wheezing, mucus production, use of accessory muscles, poor oxygen saturation, low SaO2, barrel chest or increased chest diameter. Obtain the client's history regarding current and previous asthma exacerbations, onset and duration, precipitating factors, stress, exercise exposure to irritant, changes in medication regimen, medication that relieves symptoms, other medications taken, self-care methods used to relieve symptoms. Laboratory tests. ABGs, hypoxemia is decreased PaO2 less than 80. Hypocarbia, which is decreased PaCO2, which is less than 35. This is early in the attack, and then hypercarbia, increased PaCO2, which is greater than 45. So 35 to 45 for carbon, and that's later in the attack. It goes from hypo to hypercarbia. Sputum cultures. Bacteria can indicate infection. Diagnostic procedures. Pulmonary function tests, or PFTs, are the most accurate tests for diagnosing asthma and its severity. Forced vital capacity, or FVC, is the volume of air exhaled from full inhalations to full exhalation. Forced expiratory volume in the first second, the FEV1, is the volume of air blown out as hard and fast as possible during the first second of the most forceful exhalation after the greatest full inhalation. Whoa, okay. Peak expiratory rate flow, PERF, is the fastest airflow reached during exhalation. A decrease in FEV1, or PERF, by 15% to 20% below the expected value is common in clients who have asthma. An increase in these values by 12% following the administration of bronchodilators is diagnostic for asthma. A chest X-ray is used to diagnose changes in the client's chest structure over time. Collaborative care. Nursing care. Position the client to maximize ventilation. High Fowler's 90 degrees. Administer oxygen therapy as prescribed. Monitor cardiac rate and rhythm for changes during an acute attack. Can be irregular, tachycardic, or with PVCs. Initiate and maintain IV access. Maintain a calm and reassuring demeanor. Provide rest periods for older adult clients who have dyspnea. Design room and walkways with opportunities for rest. Incorporate rest into ADLs. Encourage prompt medical attention for infections and appropriate vaccinations. Administer medications as prescribed. Medications: bronchodilators or inhalers, short-acting beta-2 agonists such as albuterol, Ventolin, provide rapid relief of acute symptoms and prevent exercise-induced asthma. Anticholinergic medications such as apratropium or Atrovent block the parasympathetic nervous system. This allows for the sympathetic nervous system effects of increased bronchodilation and decreased pulmonary secretions. Methixanthines, such as theophylline or theodur, require close monitoring of serum medication levels due to a narrow therapeutic range. Nursing considerations. Theophylline, monitor the client's serum levels for toxicity. Side effects will include tachycardia, nausea, diarrhea. Albuterol, watch the client for tremors and tachycardia. Ipratropium, observe the client for dry mouth. Client education. Ipratropium, advise the client to suck on hard candies to relieve dry mouth. Anti-inflammatory agents. These are used to decrease airway inflammation, and they include corticosteroids such as fluticasone or Flovent and prednisone, deltazone. Leukotriene antagonists such as montelukast or Singulair, mast cell stabilizers such as cromolyn sodium or Intal, and monoclonal antibodies such as amalizumab or Xolair. I love saying those names. Nursing considerations. Watch the client for decreased immunity function. Monitor for hyperglycemia. Advise the client to report back tardy stools. Observe the client for fluid retention and weight gain. This can be common. Monitor the client's throat and mouth for ophthalmos lesions or cold sores. Client education. Encourage the client to drink plenty of fluids to promote hydration. Encourage the client to take prednisone with food. Okay. Combination agents. Bronchodilator and anti-inflammatory. Ipratropium and albuterol. Fluticasone and samariterol or Advair. If prescribed separately for inhalation administration at the same time, administer the bronchodilator first in order to increase the absorption of the anti-inflammatory agent. Okay. Interdisciplinary care. Respiratory services should be consulted for inhalers and breathing treatments for airway management. Nutritional services can be contacted for weight loss or gain related to medications or diagnosis. Rehabilitation care can be consulted if the client has prolonged weakness and needs assistance with increasing level of activity. Client outcomes. The client will maintain adequate gas exchange. The client will prevent acute attacks. The client will have relief of symptoms. The client will adhere to the medication regimen. Complications. Respiratory failure. Persistent hypoxemia related to asthma can lead to respiratory failure. Nursing actions. Monitor oxygenation level and acid-base balance. Prepare for intubation and mechanical ventilation as indicated. Also, complications, status asthmaticus. This is a life-threatening episode of airway obstruction that is often unresponsive to common treatment. It involves extreme wheezing, labored breathing, use of accessory muscles, distended neck veins, and creates a risk for cardiac and respiratory arrest. Nursing actions. Prepare for emergency intubation as prescribed. Administer oxygen, bronchodilators, epinephrine, and initiate systemic steroid therapy. So that's status asthmaticus. Status asthmaticus and respiratory failure. Okay. Asthma application exercises. Answer key. Which of the following parameters indicate deterioration in the client's respiratory status? Select all that apply. 95% O2, wheezing, retraction of sternal muscles, warm and pink extremities, mucous membranes, premature ventricular complexes, PVCs, respiratory rate of 34 a minute, and anxiety. And it's all of them except for the 95 O2 and warm and pink extremities and mucous membranes. So, wheezing, retraction of sternal muscles, blah, 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 blah. Okay, yeah. 2 hours after arriving on the medical surgical unit, the client develops dyspnea. O2 is 91% and client is exhibiting audible wheezing and use of accessory muscles. Which of the following medications should the nurse expect to administer? A. Antibiotic, B. Beta blocker, C. Antiviral, or D. Beta 2 agonist. And that's a beta 2 agonist, because beta 2s are for the whatever, non-selective or selective. The nurse should expect to administer a beta 2 agonist. Beta 2 agonists are used for relief of acute symptoms. Neither an antibiotic, an antiviral, or a beta blocker are indicated for this condition. A nurse is completing discharge teaching with a client who has a new prescription for prednisone or deltazone for asthma. Which of the following client statements indicates a need for further teaching? I will drink plenty of fluids while taking this medication. I will tell the doctor if I have black tarry stools. I will take my medication on an empty stomach. I will monitor for my mouth for cold sores. And further teaching would be I will take my medication on an empty stomach. Indicates a need for further teaching. Prednisone can cause an empty stomach, an upset stomach, so it should be taken with food. The other options are all correct statements regarding this medication. On to, the big daddy, COPD, Chapter 23. Overview. Chronic obstructive pulmonary disease, COPD, encompasses two diseases, emphysema and chronic bronchitis. Most clients who have emphysema also have chronic bronchitis. COPD is irreversible. Emphysema is characterized by the loss of lung elasticity and hyperinflation of lung tissue. Emphysema causes destruction of the alveoli, leading to a decreased surface area for gas exchange, carbon dioxide retention, and respiratory acidosis. Chronic bronchitis is an inflammation of the bronchi and bronchioles due to chronic exposure to irritants. COPD typically affects middle-aged to older adults. Health promotion and disease prevention. Promote smoking cessation. Use protective equipment such as masks and ensure proper ventilation while working in environments that contain carcinogens or particles in the air. Influenza and pneumonia vaccinations are important for all clients who have COPD, but especially for the older adult clients. Older adult clients have decreased pulmonary reserve due to normal lung changes. Assessment risk factors are advanced age. Cigarette smoking is the primary risk factor for developing COPD. Alpha-1 antitrypsin or AAT deficiency, exposure to air pollution. Subjective data, chronic dyspnea. And objective data would be physical assessment findings, dyspnea upon exertion, productive cough that is most severe upon rising in the morning, respiratory acidosis and compensatory metabolic alkalosis. So you get the respiratory acidosis and then you breathe and then you get alkalosis. Okay, crackles and wheezes, rapid and shallow respirations, use of accessory muscles, barrel chest or increased chest diameter with emphysema. Hyperresonance on percussion due to trapped air with emphysema, irregular breathing pattern, thin extremities and enlarged neck muscles, dependent edema secondary to right-sided heart failure, clubbing of fingers and toes, pallor and cyanosis of nail beds and mucous membranes, late stages of the disease. Decreased oxygen saturations, expected reference range is 95 to 100%. In clients who have dark colored skin or in older adults, Oxygen saturation levels can be slightly lower. Laboratory tests. An increased hematocrit level is due to low oxygenation levels. Increased hematocrit level is due to low oxygenation levels. Use sputum cultures and WBC counts to diagnose acute respiratory infections. Diagnostic procedures. Pulmonary function tests. These tests are used for diagnosis as well as determining the effectiveness of therapy. Comparisons of forced expiratory volume, the FEV, to forced vital capacity, the FVC, are used to classify COPD as mild to very severe. As COPD advances, the FEV to the FEV to FVC ratio decreases. The expected reference range is 100%. For mild COPD, the FVC ratio is decreased to less than 70%. As the disease progresses to moderate and severe, the ratio decreases to less than 50%. Chest X-ray reveals hyperinflation of alveoli and flattened diaphragm in the late stages of emphysema. It is often not useful for the diagnosis of early or moderate disease. Excuse me. Arterial blood gases, ABGs, hypoxemia, hypoxemia, decreased O2 less than 80, hypercarbia, increased CO2 is greater than 45, and respiratory acidosis, metabolic alkalosis compensation. So hypoxemia to hypercarbia. So lots of O2 or low O2 to high carbon. Okay. Pulse oximetry. Clients who have COPD usually have oxygen levels less than the expected reference range of 95 to 100%. AAT alpha antitrypsin levels used to assess for AAT deficiency, a deficiency in a special enzyme produced by the liver that helps regulate other enzymes that help break down pollutants from attacking lung tissue. Okay, so low those. Collaborative care, nursing care. Position the client to maximize ventilation, high Fowler's 90. Encourage effective coughing or suction to remove secretions. Encourage deep breathing and use of an incentive spirometer. Administer breathing treatments and medications as prescribed. Administer oxygen as prescribed. Monitor for skin breakdown around the nose and mouth from the oxygen device. Promote adequate nutrition. Increase work of breathing increases caloric demands. Proper nutrition aids in the prevention of infection. Encourage fluids to promote adequate hydration. Dyspnea decreases energy available for eating, so soft, high-calorie foods should be encouraged. Monitor current weight and note any changes. Instruct the client to practice breathing techniques to control dyspneic episodes. For diaphragmatic or abdominal breathing, instruct the client to take breaths deep from the diaphragm. Lie on back with knees bent. Rest hand over abdomen to create resistance. If the client's hand rises and lowers upon inhalation and exhalation, the breathing is being performed correctly. For pursed breathing, instruct the client to form the mouth as if prepared to whistle. Take a breath in through the nose and out through the lips or mouth. Do not puff the cheeks. Take breaths deep and slow. Incentive spirometry. This is used to monitor optimal lung expansion. Nursing actions. Show the client how to use the incentive spirometer machine. Client education. Instruct the client to keep a tight mouth seal around the mouthpiece and to inhale and hold breath for 3 to 5 seconds. As the client inhales, the needle of the spirometry machine will rise. This promotes lung expansion. Clients who have COPD may need 2 to 4 liters a minute of oxygen via nasal cannula or up to 40% via Venturi mask. Clients who have chronically increased CO2 levels usually require 1 to 2 liters a minute of oxygen via nasal cannula. It is important to recognize that low arterial levels of oxygen serve as the primary drive for breathing. It's important to recognize that low arterial levels of oxygen serve as the primary drive for breathing. Okay. Determine the client's physical limitations and structure activity to include periods of rest. Provide rest periods for older adult clients who have dyspnea. Design the room and walkways with opportunities for relaxation. Provide support to the client and family. Talk about disease and lifestyle changes, including home care services such as portable oxygen. Encourage verbalization of feelings. Increase fluid intake. Encourage the client to drink 2 to 3 liters a day to liquefy mucus. Medications of bronchodilators, short-acting beta agonists such as albuterol provide rapid relief. Cholinergic antagonists, anticholinergic medications such as ipratropium or Atrovent block the parasympathetic nervous system. This allows for the sympathetic nervous system effects of increased bronchodilation and increased pulmonary secretions. Xanthines, just say xanthines, such as theophylline or theodur, relax smooth muscle of the bronchi. These medications require close monitoring for serum medication levels, have narrow therapeutic ranges. Nursing considerations, monitor client's serum levels. Okay, we've been through all this with xanthines, down to anti-inflammatory agents. These medications decrease airway inflammation. If corticosteroids such as fluticasone or Flovent or deltazone are given systemically, monitor for serious side effects, immunosuppression, fluid retention, hyperglycemia, hypokalemia, poor wound healing. So that's the Flovent, hypokalemia, and hyperglycemia. There's the leukotriene. Okay, we've been through all these in the last one for asthma. But it's Xolair, Singulair, mast cell stabilizers. Watch client for decrease in immunity function. Monitor the client for hyperglycemia. Advise the client to report back tarry stools. Observe the client for fluid retention and weight gain. This is common. Check client's throat and mouth for lesions or cold sores. Care after discharge. COPD is debilitating for older adult clients. Referrals to assisted programs such as food delivery services can be indicated. Set up referral systems including home care services such as portable oxygen. Client education. Encourage the client to eat high-calorie foods to promote energy. Encourage rest periods as needed. Promote hand hygiene to prevent infection. Reinforce the importance of taking medications, inhalers, other oral medications as prescribed. Promote smoking cessation if the client is a smoker. Encourage immunizations such as influenza and pneumonia to decrease the risk of infection. Clients should use oxygen as prescribed. Inform other caregivers not to smoke around the oxygen due to flammability. Provide support to the client and family. Outcomes: the client will maintain adequate gas exchange. The client will be able to keep a patent airway. The client will remain free from infection. The client will be able to maintain 10% of ideal body weight. Okay, complications of respiratory infection. Infections result from increased mucus reduction in poor oxygenation levels. Nursing action: administer oxygen therapy, monitor oxygenation levels, and administer antibiotics and other medications as prescribed. Right-sided heart failure or cor pulmonale, air trapping, collapse, airway collapse, and stiff alveoli lead to increased pulmonary pressures. Blood flow through the lung tissue is difficult. This increased workload leads to enlargement and thickening of the right atrium and ventricle. Manifestations include low oxygenation levels, cyanotic lips, enlarged and tender liver, distended neck veins, dependent edema. Nursing actions: monitor respiratory status and administer oxygen therapy, monitor heart rate and rhythm, administer medications as prescribed, and administer IV fluids and diuretics to maintain fluid balance. That's with right-sided heart failure. Okay, application exercises. I think we're just going to skip these on this one and go straight into pneumonia. Nursing care of clients with respiratory disorders. Pneumonia, I'll just give subjective and objective data. Anxiety, fatigue, weakness, chest discomfort, confusion from hypoxia is the most common manifestation of pneumonia in older clients. Objective data: physical assessment findings: fever, chills, flushed face, diaphoretic, shortness of breath or difficulty breathing, tachypnea, pleuritic chest pain, sharp, sputum production, yellow tinged, crackles and wheezes, coughing, dull chest percussion over areas of consolidation, decreased oxygen saturation levels. Expected reference range is 95 to 100%. Fever, cough, and yellow tinged sputum are often absent in clients who have pneumonia. Okay. And I'll just read a little bit about pneumonia. Pneumonia is an inflammatory process in the lungs that produces excess fluid. Pneumonia is triggered by infectious organisms or by the aspiration of an irritant, such as a fluid or a foreign object. The inflammatory process in the lung parenchyma results in edema and exudate that fills the alveoli. Pneumonia can be a primary disease or a complication of another disease or condition. It affects people of all ages, but the young, older adult clients and clients who are immunocompromised are more susceptible. Immobility can be a contributing factor in the development of pneumonia. There are two types of pneumonia. Community-acquired pneumonia, or CAP, is the most common type and often occurs as a complication of influenza. Hospital-acquired pneumonia, HAP, also known as nosocomial pneumonia, has a higher mortality rate and is more likely to be resistant to antibiotics. It usually takes 24 to 48 hours from the time the client is exposed to acquire HAP, or hospital-acquired pneumonia. Older adult clients are more susceptible to infections and have decreased pulmonary reserve due to normal lung changes, including decreased lung elasticity and thickening alveoli. Okay. Decreased pulmonary reserves due to normal lung changes, in decreased lung elasticity and thickening alveoli. Health promotion, encourage older adult clients, especially those with chronic illnesses, to receive immunizations for influenza and pneumonia, promote smoking cessation, and perform frequent hand hygiene to prevent spread of infection. Collaborative care. Position the client to maximize ventilation in a 90-degree high Fowlers. Encourage coughing or suction to remove secretions. Administer breathing treatments and medication as prescribed. Administer oxygen therapy as prescribed. Monitor for skin breakdown around the nose and mouth from the oxygen device. Encourage deep breathing with an incentive spirometer to prevent alveolar collapse. Determine the client's physical limitations and structure activity to include periods of rest, and promote adequate nutrition. Also, an increased work of breathing increases caloric demands. Proper nutrition aids in the prevention of secondary respiratory infections. Encourage fluid intake of 2 to 3 liters a day to promote hydration and thinning of secretions unless contraindicated due to another condition. Periods of rest for older clients who have dyspnea. Reassure client who is experiencing respiratory distress. Medications are antibiotics. Commonly used antibiotics include penicillins and cephalosporins. It's important to obtain any culture specimen prior to giving the first dose of an antibiotic. Once the specimen has been obtained, the antibiotics can be given while waiting for the results of the ordered culture. Nursing considerations: observe clients taking cephalosporins for frequent stools. Monitor clients' kidney function, especially older adults who are taking penicillins and cephalosporins. Watch out for C. diff. Encourage clients to take penicillins and cephalosporins with food. Some penicillins should be taken 1 hour before meals or 2 hours after, so don't take them with the foods. Bronchodilators. Bronchodilators are given to reduce bronchospasms and reduce irritation. Anti-inflammatories decrease airway inflammation. Glucocorticosteroids such as Flovent and Deltazone can be prescribed to help with inflammation. Monitor for immunosuppression, fluid retention, hyperglycemia, hypokalemia, and poor wound healing. There's considerations is decrease immunity function. Monitor client for hyperglycemia. Advise the client to report black tarry stools. Observe client for fluid retention and weight gain. This can be common. Monitor the client's throat and mouth for lesions and cold sores. I guess we already read that the third time. Client outcomes. The client is able to maintain adequate gas exchange. The client is able to keep a patent airway. The client remains free from infection. Complications: atelectasis, airway inflammation, and edema lead to alveolar collapse and increase the risk of hypoxemia. The client might report shortness of breath and exhibit signs of hypoxemia. The client might have diminished or absent breath sounds over the affected area. A chest X-ray will show an area of density. Bacteremia or sepsis. This can occur if pathogens enter the bloodstream from the infection in the lungs. That was pneumonia. Okay, so on to 9. Oh my god. Alright. End of life care, Unit 9. Back to ATI Fundamentals Nursing. Grief, Loss, and Palliative Care, Chapter 36, Psychosocial Integrity. Grief, Loss, and Palliative Care. Overview. Clients experience loss in many aspects of their lives. Grief is the inner emotional response to loss and is exhibited in many ways as there are individuals. Bereavement includes both grief and mourning, the outward display of loss, as the individual deals with the death of a significant individual in his life. Palliative or end-of-life care is an important aspect of nursing care and attempts to meet the client's physical and psychosocial needs. End-of-life issues include decision-making in a highly stressful time during which the nurse must consider the desires of the client and the family. Any decisions must be shared with other healthcare personnel for a smooth transition during this time of stress, grief, and bereavement. Advanced directives, legal documents that direct end-of-life issues. Living wills, directive documents for medical treatment per client's wishes. Durable power of attorney for healthcare, a document that appoints someone to make medical decisions when the client is no longer able to do so on his own behalf. Types of loss. Necessary loss. This is a part of the cycle of life that is anticipated but still may be intensely felt. This type of loss can be replaced by something different or better. Actual loss. This is any loss of a valued person or item. Perceived loss. This is any loss defined by the client that is not obvious to others. Maturational loss. This is any loss normally expected due to the developmental processing of life. These these are associated with normal life transitions and help to develop coping skills. Situational loss. This is any unanticipated loss caused by an external event. Theories of grief. Kubler-Ross, 5 stages of grief. Denial. The client has difficulty believing a terminal diagnosis or loss. Anger. The client lashes out at other people or things. Bargaining. The client negotiates for more time or a cure. Depression. The client is saddened over the inability to change the situation. And acceptance. The client recognizes what is happening and plan for the future. Stages may not be experienced in order, and the length of each stage varies from person to person. Worden has the 4 tasks of mourning. Task 1, accepting the inevitability of the loss. Task 2, using coping mechanisms to experience the emotional pain of the loss. Task 3, changing the environment to accommodate the absence of the deceased. And Task 4, readjusting emotional ties to new individuals and moving thoughts about the deceased to a less prominent place in everyday thoughts. To complete all 4 tasks, it should take about a year, but may vary. Factors influencing loss, grief, and coping ability. The individual's current stage of development, interpersonal relationships and social networks, type and significance of the loss, culture and ethnicity, spiritual and religious beliefs and practices, prior experience with loss, socioeconomic status. Factors that may increase an individual's risk for dysfunctional grieving include having a great deal of dependence on the deceased dying unexpectedly at a young age through violence or by socially unacceptable manner, inadequate coping skills or lack of social supports, lack of hope or pre-existing mental health issues such as depression or substance abuse. Assessment. Types of grief and manifestations. Normal grief. This grief is considered uncomplicated. Emotions may be negative, such as anger, resentment, withdrawal, hopelessness, and guilt, but should change to acceptance with time. Some acceptance should be evident by 6 months after the loss. Somatic complaints may include chest pain, palpitations, headaches, nausea, changes in sleep patterns, and fatigue. Anticipatory grief. This grief implies the letting go of an object or person before the loss, as in a terminal illness. Individuals have the opportunity to grieve before the actual loss. Dysfunctional grief, unresolved or chronic grief, is a type of complicated grief. This grief involves difficult progression through the expected stages of grief. Usually the work of grief is prolonged, the symptoms of grief are more severe, and they may result in depression or exacerbate a pre-existing disorder. The client may develop suicidal ideation, intense feelings of guilt, and lowered self-esteem. Somatic complaints persist of an extended period of time. Disenfranchised grief. This grief entails an experienced loss that cannot be publicly shared or is not socially acceptable, such as suicide. Nursing interventions. Facilitate mourning. Grant time for the grieving process. Identify expected grieving behaviors such as crying, somatic symptoms, and anxiety. Use therapeutic communication. Name the emotion the client is feeling. For example, say, "You sound as though you are angry. Anger is a normal feeling for someone who's lost a loved one. Tell me about how you're feeling." And avoid communication that inhibits the open expression of feelings, such as offering false reassurance, giving advice, changing the subject, and taking the focus away from the grieving individual. Assist the grieving individual to accept the reality of the loss. Support efforts to move on in the face of the loss. Encourage the building of new relationships. Provide continuing support. Encourage the support of family and friends. Assess for signs of ineffective coping, such as refusing to leave the home months after the client's spouse has died. Share information about mourning and grieving with the client who may not realize that her feelings, such as anger toward the deceased, are expected. Encourage attendance at bereavement or grief support groups. Provide information about available community resources. Initiate referrals for individual psychotherapy for clients who are having difficulty resolving grief. Ask the client if contacting a spiritual advisor would be acceptable or encourage the client to do so. Participate in debriefing provided by professional grief mental health counselors. Client outcomes. The client verbalizes needs to healthcare provider. The client progresses through the stages of grief in a timely manner. Palliative care. The nurse serves as an advocate for the client's sense of dignity and self-esteem by providing palliative care at the end of life. Palliative care improves the quality of life of clients and their families facing end-of-life issues. Palliative care interventions are primarily used when caring for clients who are dying and family members who are grieving. Palliative care may be provided by an interdisciplinary team of physicians, nurses, social workers, massage therapists, occupational therapists, music art therapists, touch energy therapists. Whew. Hospice care is a comprehensive care delivery system implemented when a client is not expected to live longer than 6 months. Further medical care aimed toward cure is stopped and the focus becomes symptom relief and enhances quality of life. Assessment data collection. Characteristics of discomfort and signs and symptoms of approaching death. Characteristics of discomfort: pain, anxiety, dyspnea, nausea and vomiting, dehydration, diarrhea or constipation, urinary incontinence, inability to perform ADLs. Signs and symptoms of approaching death: decreased level of consciousness, muscle relaxation, labored breathing, dyspnea, apnea, Cheyenne-Stokes respirations, mucus collecting in large airways, incontinence of bowel or bladder, mottling occurring with poor circulation, pupils no longer reactive to light, pulse weakening and blood pressure dropping, cool extremities, perspiration, decreased urine output, inability to swallow. Determine the client's sources of strength and hope. Identify the desires and expectations of the family and the client for the end-of-life care. Nursing interventions. Promote continuity of care and communication by limiting assigned staff changes. Assist the client and family to set priorities for end-of-life care. Physical care. Give priority to controlling symptoms. Administer medications that manage pain, air hunger, and anxiety. Perform ongoing assessments to determine the effectiveness of treatment and the need for modifications of the treatment plan, such as lower or higher doses of medication. Manage adverse side effects of medications. Reposition the client to maintain airway patency and comfort. Maintain the integrity of skin and mucous membranes. Provide an environment that promotes dignity and self-esteem. Remove products of elimination as soon as possible to maintain a clean and odor-free environment. Offer comfortable clothing. Provide careful grooming for hair, nails, and skin. Encourage family members to bring in comforting possessions to make the client feel at home. Encourage the use of relaxation techniques such as guided imagery and music. Promote decision-making in food selection, activities, and health care to give client as much control as possible. Encourage the client to perform ADLs as able and willing to do so. Psychosocial care. Use an interdisciplinary approach. Provide care to the client and family. Use volunteers when appropriate to provide non-medical care. Use therapeutic communication to develop and maintain a nurse-client relationship. Facilitate the understanding of information regarding disease progression and treatment choices. Facilitate communication between the client, the family, and the provider. Encourage the client to participate in religious practices that bring comfort and strength if appropriate. Assist the client in clarifying personal values in order to facilitate effective decision-making. Encourage the client to use coping mechanisms that have worked in the past. Be sensitive to comments made in the presence of clients who are unconscious, as hearing is the last sensation lost. Prevention of abandonment and isolation. Prevent the fear of dying alone. Make your presence known by answering call-outs in a timely manner, making frequent contact. Keep the client informed of procedure and assessment times. Allow family members to stay overnight. Determine where the client is most comfortable, and such as in a room close to the nurse's station. Support for the grieving family. Suggest that the family members plan visits to promote the client's rest. Ensure that the family receives appropriate information as the treatment plan changes. Provide privacy so family members have the opportunity to communicate and express feelings among themselves without including the client. Determine family members' desire to provide physical care. Provide instructions as necessary. Educate the family about physical changes to expect as the client moves closer to death. Client outcomes. The client verbalizes pain and discomfort and they are controlled. Client rests comfortably and shows minimal signs of distress. Client participates in care to his greatest ability. Post-mortem care. Nurses are responsible for following federal and state laws regarding requests for organ or tissue donations, obtaining permission for autopsy, ensuring the certification and appropriate documentation of the death, and providing postmortem after-death care. The client's family now becomes the nurse's primary focus. Nursing interventions. Care of the body. Provide care with respect and compassion while attending to the desires of the client and family per cultural, religious, and social practices. Recognize that the provider certifies death by pronouncing the time and documenting therapies used and actions taken prior to death. Preparing the body for viewing includes maintaining privacy, shaving facial hair if applicable and or desired by the family, removing all tubes and soiled linens unless organs are to be donated or this is a medical examiner's case. Remove all personal belongings to be given to the family, cleansing and aligning the body with a pillow under the head, arms outside the sheet and blanket, dentures in place, and eyes closed. Apply fresh linens and a gown, brushing, combing the client's hair, replacing any hair pieces, removing excess equipment and linens. Wait, it feels like I've already read this, like at the beginning. No, I didn't. I'm having deja vu here. Dimming the lights and minimizing noise to provide a calm environment. Viewing considerations include asking the family if they would like to visit with the body, honoring any decision, clarifying where the client's personal belongings should go with the body or to a designated person, adhering to the same procedures when the client is an infant, with the exception of swaddling the infant's body in a clean blanket, transporting the infant in the nurse's arms or in an infant carrier, offering mementos to the infant, identification bracelets, footprints, the cord clamp, a lock of hair, photos. Post-viewing, apply identification tags according to facility policy, complete documentation, remain aware of visitor and staff sensibilities during transport. Organ donation. Recognize that requests for tissue and organ donation must be made by specifically trained personnel. Provide support and education to families as decisions are being made. Use private areas for any family discussion concerning donation. Be sensitive to cultural and religious influences. Maintain ventilatory and cardiovascular support for vital organ retrieval. Autopsy considerations. The provider typically approaches the family about performing an autopsy. The nurse's role is to answer the family's questions and support its choices. Autopsies can be conducted to advance scientific knowledge regarding disease processes, which can lead to the development of new therapies. The law may require an autopsy to be performed if the death is due to homicide, suicide, or accidental death, or if death occurs within 24 hours of hospital admission. Most facilities require that all tubes remain in place for an autopsy. Cultural religious beliefs. Identify cultural religious beliefs of family members. Be sensitive to these practices when providing post-mortem care. Documentation and completion of forms following federal and state laws typically include who pronounced the death and at what time, consideration of and preparation for organ donation, disposition of personal articles, who was notified and any decisions made, the location of identification tags, the time the body left the facility and the destination, care of nurses who are grieving. Care long-term for clients can create personal attachments for nurses. Nurses can use coping strategies such as going to the client's funeral, communicating and writing to the family, attending debriefing sessions with colleagues, using stress management techniques, and talking with a professional counselor. Okay, and that was end of life. We just have 9 questions out of psych, and some lab stuff. Unit 10, psych. I lost my psych ATI book. I just had it. So, no psych. But we just did that, so that should still be fresh. I could go through psych meds, but that's just There's other things you can listen to on the YouTube channel, breakdown of meds and other stuff. Plus it's late, so we'll just go to lab. Okay, labs, injection sites. We've got the deltoid muscle and in the shoulder there, and the ventrogluteal site on the side of your hip, and the dorsogluteal site along the back of your butt, and the vastus lateralis site on your thigh area. Okay, guidelines for appropriate catheter selection out of Potter and Perry, box 45A. 8. The catheter size should be determined by the size of the client's urethral canal. When the French system is used, the larger the gauge number, the larger the catheter size. Generally, children require 8 to 10 French FR. Women require 14 to 16 FR, and men require 16 to 18. So 8 to 10, 14 to 16, 16 to 18. To prevent trauma, the smallest effective catheter size is preferred. Larger sizes than 18 FR create discomfort, increase risk of blockage, and lead to UTI, urethral irritation, and erosion. The expected duration of the catheterization will determine the catheter material selection. Plastic catheters are suitable only for intermittent use during their due to their inflexibility. Latex catheters are recommended for use for up to 3 weeks. Beware of allergies. Pure silicone or Teflon catheters are best suited for long-term use, 2 to 3 months, because of less incrustation at the urethral meatus. Balloon size is important in selecting an indwelling catheter. Balloon sizes range from 3 milliliter for pediatric to large postoperative volumes of 75 milliliters. In adults, the 5 milliliter and 30 milliliter sizes are the most common. The 5 milliliter size allows for optimal drainage, whereas 30 milliliter size is used for prostatectomies to provide hemostasis of the prostatic bed. Use only sterile water to inflate the balloon because saline will crystallize, resulting in incomplete deflation of the balloon at the time of removal. If leakage occurs around the catheter, a change in lumen size or use of antispasmodic medication is necessary. Needles. Needles come packaged in individual sheaths to allow flexibility in choosing the right needle for a client. Some needles are pre-attached to standard size syringes. Most needles are made of stainless steel and all are disposable. The needle has 3 parts: the hub, which fits into the tip of a syringe, the shaft, which connects to the hub, and the bevel, or slanted tip. The tip of a needle or bevel is always slanted. The bevel creates a narrow slit when injected into tissue. This slit quickly closes when the needle is removed to prevent leakage of medication, blood, or serum. Long beveled tips are sharper and narrowed, which minimize discomfort when entering tissue, used for subcutaneous or IM injections. Needles vary in length from 1/4 to 3 inches. Choose the needle length according to the client's size and weight and the type of tissue into which the medication is to be injected. A child or slender adult generally requires a shorter needle. Use longer needles, 1 to 1.5 inches, for intramuscular injections, and a shorter needle, 3/8 to 5/8 inches, for subcutaneous injections. As the needle gauge becomes smaller, the needle diameter becomes larger. The selection of gauge depends on the viscosity of fluid to be injected or infused. Rationale for needle selection is included in each skill. Okay. Alright, abnormal lung sounds. When auscultating, abnormal sounds result from air passing through moisture, mucus, or narrowed airways. They also result from alveoli suddenly reinflating or from an inflammation between the pleural linings of the lung. Adventitious sounds often occur superimposed over normal sounds. The four types of adventitious sounds are crackles, rhonchi, wheezes, and pleural friction rub. A specific entity causes each sound, and each has typical auditory features. During auscultation, note the location and characteristics of the sounds and listen for the absence of breath sounds found in clients with collapsed or surgically removed lobes. So crackles, the site of auscultation, are most common in dependent lobes, right and left lung bases. The bases cause random sudden inflammation or reinflammation of groups of alveoli, disruptive passage of air through small airways. Character: fine crackles are high-pitched, fine, short, interrupted crackling sounds heard during end of inspiration, usually not cleared with coughing. Medium crackles are lower, more moist sounds heard during middle of inspiration, not cleared with coughing. Coarse crackles are loud, bubbly sounds heard during inspiration, not cleared with coughing. Then rhonchi, or sonorous wheeze, are primarily heard over trachea and bronchi. If loud enough, you are able to hear over most lung fields. Muscular spasm, fluid or mucus in large airways is the cause. New growth or external pressure causing turbulence. Sounds like loud, low-pitched rumbling, coarse sounds heard either during inspiration or expiration, sometimes cleared by coughing. Wheezes, or sibilant wheeze, heard over all lung fields, caused by high-velocity airflow through severely narrowed or obstructed airway, and sound like high-pitched continuous musical sounds like a squeak, heard continuously during inspiration or expiration, usually louder on expiration. Pleural friction rub. This is heard over the anterior lateral lung field. If the client is sitting upright, it's caused by inflamed pleura, parietal pleura rubbing against visceral pleura. Has dry rubbing or grating quality heard during inspiration or expiration. Does not clear with coughing. Heard loudest over lower lateral anterior surface. Lower lateral anterior surface. Auscultate for normal breath sounds and abnormal or adventitious sounds. Okay, that's good. We got all that. Okay, that's all I got. But apparently there's supposed to be some stuff on there about assessment findings, how to find the injection sites, wound care, and we did lung sounds. Okay. So I'll end on Jenny's 4 rules for the final exam. Get a good night's sleep tonight. Don't come in here all doped up on caffeine. Stay calm, stay focused, and read the question. The end.